हद है, बस हिंदुस्तान की है पर मैसेज फारसी में लिखा है, कैसे समझेंगे लोग?
फारसी में नहीं, हिंदी में लिखा है।
आपको समझ आ रहा है?
बिल्कुल समझ आ रहा है। कोरोना से जंग अभी जारी है, मास्क ठीक से पहनना सबकी
जिम्मेदारी है।
मास्क सही से पहने।
Mama! Hi!
How are you, my darling?
Okay, listen. You're not going to believe this. But we are fine! Are fine. We are fine. Hi, Mama!
Oh, my baby. How are you, my Raja?
We are fine. We are fine. And you know what? Past 2 weeks, we haven't ordered any outside food.
What? Is everyone dieting?
Yeah, right, ma'am. What about you? Looking tired?
It's tough, darling. So many people need care. But I am a few. Okay, listen. I'll have to stay here longer. I don't think.
You're not coming home for the festival, no? It's okay, Ma. We'll celebrate when you return. Don't worry about us. Arey, Ma. We are fine. Promise. See?
Hi, Baba.
Hi.
Baba.
Chup, man. Okay, see this.
Australia.
What?
The shape of your dosa.
Very clever. And guess what? We have chutney also, and your little hero is in charge of the grated coconut.
He's what?
Hey, hero. See, Baba, I told you we'll be okay. Only home cooking. So listen, you want to see what Pappu's making for lunch and for dinner?
What?
Ready?
So, for lunch, we have Malabar parota and paneer. For dinner, we have wheat parota, paneer and dahi.
Wow. I'm gone for 2 weeks and you guys have become master chefs.
I know.
I'll be home soon. As soon as I can.
Hey, Baba, don't worry about us. We're fine, yeah.
Ma'am, please thank Mr. Rao. He sent a whole bunch of this to us.
This is from you.
A little something to cheer all of you up, na?
Dr. Rao, you're needed in room number 24.
Hey, listen, I...
Go and make us all proud.
Bye, Mama. We are fine, Mama.
To the warriors who keep us safe every day, thank you for your sacrifice and love. ID, made with love.
நீங்க பேசுறது கேட்கும்.
Okay. Just a minute, start video. No, there was
அந்த சிம்பிள்
video edit. Mute பண்ணிருந்தேன்.
ஓகே நீங்க பேசுறது கேட்கும்.
Hello everybody. Can you hear me?
Good afternoon.
Good afternoon everybody. Can you hear me? I'm Dr. Asha Murthy from Chennai.
I can hear you.
Yes, we can, madam. We will start in a minute.
Okay.
From there.
A very good afternoon, everyone. Welcome back after that session on exotic interventions. From exotic intervention, we go to a more
Full piece பண்ணுங்க.
maybe a sacred topic. Mothers always have a special place in all of our hearts.
I'm screen sharing.
So,
Hello.
next session is a tribute to our mothers.
Hello.
For this session, we have Dr. Jolsna, Dr. Vijayalakshmi IB, and Dr. Asha Murthy as chairs, and Dr. Rajalakshmi S, Dr. Aparna Jaiswal, and Dr. Rupali Khanna as expert. Over to you, madam.
Good afternoon everybody. I am Dr. Asha Murthy, senior cardiologist from Chennai. I'm going to chair this session. Before starting, I would just like to thank Dr. Mohanan and the committee members, organizing committee members, for giving me this wonderful opportunity to chair this important session that is on tribute to mother. And before that, I just want to congratulate Dr. Mohan and the committee members for very excellent scientific feast arranged, organized in this setting of pandemic COVID in the hybrid virtual conference of the annual Cardiology Society of India for the first time of this century. So before wasting my time, I will just request all the speakers to be on the time. And the first speaker available, Dr. Anupa Hegde. Is she there?
I'm available.
Okay, fine. So first the session is going to start on hypertension in precious pregnancy, and how will I manage, by Dr. Anupa Hegde. She's a senior cardiologist and she's going to speak on this important topic on tribute to mother. Over to Dr. Anupa Hegde.
Thank you, madam.
Anupa, I can't see you. I can't. Okay, fine. I can see your video. I can see your share screening.
Okay, ma'am. Let's start.
Yeah, we can start.
Good afternoon, everybody. So, I thank the organizers for giving me this chance and paying my regards to all my teachers and senior colleagues on the panel and my friends and the delegates who have joined it. I'll start my topic, hypertension in precious pregnancy. How will I manage? For a mother, each pregnancy is precious, whether it is assisted conception. But by conception, precious pregnancy is usually used for IVF pregnancy or conception that occurs after more than 10 years of the previous pregnancy. Pregnancy in mother aged more than 40
Anupama
years.
madam.
Pregnancy after multiple miscarriage.
Anupama madam.
And pregnancy in mother with comorbidities. Hypertension is the most common medical disorder during pregnancy, with prevalence of 5 to 10% of pregnancies worldwide. But when it comes to assisted pregnancy, it can increase up to 20%. Hypertension and antihypertensive drugs have adverse effects on both mother and fetus. Management of hypertension during pregnancy needs expertise in the field of high-risk pregnancy and cardiovascular diseases, which is why a combined team approach by both obstetricians and cardiologists has been recommended. So why are we worried? Hypertension in pregnancy, whether it is assisted or unassisted, has both maternal fetal complications. The maternal complications include placental abruption, stroke in the mother, multi-organ failure, DIC. This is the immediate effects. The long-term risk of hypertensive disorder, pregnancy, and preeclampsia include four-fold higher risk of chronic hypertension and a two-fold higher risk of stroke and ischemic heart disease. Women who develop hypertension have higher rates of both adverse maternal and perinatal outcomes when they have associated preeclampsia.
Ma'am, make it full screen, ma'am, your slides.
PD complications include high-risk intrauterine growth retardation, which is seen in almost 25% of cases of preeclampsia, prematurity seen in 27% of preeclampsia cases, and IUD in 4% of preeclampsia cases. So what are the factors which contribute to pregnancy-induced hypertension in women who undergo infertility treatment? Women who are going for infertility treatment are usually of higher age. They may have multiple pregnancies, and the underlying pathologic basis like polycystic ovaries and endometriosis must be considered as a cause or a correlation with hypertension. Most of them have obesity or insulin resistance. There will be androgen excess, sympathetic nerve overactivity, and chronic use of oral contraceptives, which all contribute to increased risk of hypertension in these women when they become pregnant. What are the drugs which are used in infertility treatment? Most commonly used drugs are clomiphene, metformin, aromatase inhibitors like letrozole, human chorion gonadotropins like menotropin, dopamine agonists like bromocriptine, and gonadotropin-releasing hormone agonists like leuprolide, which are used in GnRH protocol along with progesterone and estradiol. Of these drugs, letrozole, leuprolide, and estradiol can induce hypertension with a prevalence of 5 to 8%, 8%, and 3 to 7% respectively. There are few isolated case reports on bromocriptine-induced hypertension. Though bromocriptine is a vasodilator, there are rare reports of bromocriptine causing hypertension. So, with this background, how do we diagnose and manage the patient who come with precious pregnancy? First of all, we have to categorize these patients into whether they have chronic hypertension or pre-existing hypertension. That is, the hypertension is noted early in the pregnancy. Gestational hypertension, which is seen after 20 weeks of pregnancy. Pre-existing hypertension plus superimposed gestational hypertension. Hypertension with proteinuria. And the new subgroup, which is antenatally unclassifiable hypertension. That is, when the BP is recorded for first time after 20 weeks of gestation and you diagnose hypertension. This is called antenatally unclassifiable hypertension. Reassessment is necessary in these patients after 42 days postpartum, whether these were only gestational hypertension or they had underlying chronic hypertension. How do we record BP in pregnant women? BP in pregnancy should be measured in sitting position or during labor in left lateral recumbent position with an appropriately sized arm cuff at heart level and using Korotkov 5 sounds for diastolic blood pressure. Mercury sphygmomanometers, though not recommended regularly, but they're still the gold standard for BP measurement in pregnancy, as automatic devices tend to under-record the true blood pressure and are unreliable in severe preeclampsia. The diagnosis of hypertension in pregnancy by ambulatory BP monitoring is superior to routine BP measurement for the prediction of pregnancy outcome. This is because it avoids unnecessary treatment of white coat hypertension and is also useful in management of high-risk pregnant women with hypertension and those with diabetic or hypertensive left. So, what are the basic investigations required in these patients? The basic laboratory investigation recommended for monitoring pregnant hypertensives are urine analysis, blood count hematocrit, liver enzymes, serum creatinine, and serum uric acid. Because hyperuricemia in hypertensive pregnancy identifies women at increased risk of adverse maternal fetal outcomes and in patients with clinical preeclampsia. So assess for proteinuria in early pregnancy to detect pre-existing renal disease and repeat in second half of pregnancy to screen for preeclampsia. The recent guidelines recommend a dipstick test for urine protein analysis, and if the result of more than 1+, this should prompt further investigations, including albumin creatinine ratio or protein creatinine ratio, which can quickly determine in a single spot urine sample. The recommendation now says don't use the first body urine sample in the morning. If you use protein creatinine ratio, then a value of less than 30 milligram per millimole rules out proteinuria of pregnancy. If you use albumin creatinine ratio, the cutoff is 8 milligram per millimole. Also, you need to do the Doppler ultrasound of uterine arteries after 20 weeks of gestation to detect women who are at higher risk of gestational hypertension, preeclampsia, and IVD. And soluble FMS like tyrosine kinase 1 to placental growth factor ratio is used to diagnose development of preeclampsia. If the ratio is less than or equal to 38, that excludes development of preeclampsia next week when suspected clinical. We also need to look for the other secondary cause of hypertension. You need to do the ultrasound of adrenal glands, the plasma and urinary fraction metanephrine to rule out pheochromocytoma as a cause of hypertension in these patients. Also, you may have to do ECG and echo. ECG to look for arrhythmias, echo to look for any hypertensive heart disease or any development of LV dysfunction. So now we look into the management of patients in each category. In patients with chronic hypertension, pre-pregnancy counseling is required. You need to talk to the prospective mother regarding the risk and prognosis of the proposed pregnancy. If the patient is on API or ARBs and thiazides, please stop them and change to other alternative drugs. If patient on AC or ARB reports to you after conception, stop these drugs within 2 days of reporting pregnancy. Also, these patients need to be advised on weight management, exercise regimen, healthy eating, and lowering of salt in their diet. Antihypertensive treatment in treatment-naive hypertensive, chronic hypertensive is recommended if the BP is more than or equal to 149. Labetalol is now the drug of first choice. If the patient cannot tolerate labetalol, then use mifepristone. When both are not suitable, methyl-dopa can be used. Methyl-dopa is the only drug which has maximum evidence in treatment of pregnancy-induced hypertension. As per the recent NICE guidelines, the target BP now is 135 by 85 millimeter mercury on treatment. If the patient has persistently low systolic BP less than 110 or diastolic less than 70, then either try to reduce the dose of antihypertensives or if required, you may have to stop the antihypertensive, especially in the second trimester. Antenatal checkup is recommended every 2 to 4 weeks for optimal BP control. And usage of aspirin 75 to 1 milligram from 12 weeks of pregnancy is recommended in these patients.
41.
When do you time the delivery? It is preferable to deliver the fetus at more than 37 weeks of gestation if BP is less than or equal to 160 by 110 and the mother has no signs of preeclampsia. The mode of delivery is to be based on obstetric indications as decided by senior obstetrician. Cesarean section is not mandated in all the cases, nor shortening of second stage of labor. If delivery is planned early, then or patient goes into premature labor, antenatal regimen of corticosteroids and magnesium sulfate needs to be given in these patients. Post-delivery, check the blood pressure daily for the first 2 days, that's when the patient is in the hospital. Later, one reading to be taken within 3 to 5 days after delivery.
Dr. Anupama, I'm sorry to interrupt. 1 minute is only left, right?
Okay. Change antihypertension is clinically indicated and target BP of less than 140 by 9. So review treatment after 2 weeks and methyl dopa to be stopped within 2 days of delivery to avoid postnatal depression. Review 6 to 8 weeks after delivery. So the management of gestational hypertension and preeclampsia is to be based on the clinical condition of the patient. If the BP is more than 160 by 110, these patients may need to be hospitalized and the BP needs to be controlled. The postnatal checkups remain same as the chronic hypertension. And aspirin is used recommended in the dose of 75 to 150 milligrams as per the risk profile. So long-term management is same as gestational hypertension. Counseling regarding the risk of developing preeclampsia during subsequent pregnancies need to be highlighted in patients who have preeclampsia during the present pregnancy. So what are the take-home messages? Hypertensive disorders of pregnancy is a heterogeneous disease that increases the risk of maternal and fetal morbidity and mortality. Early detection and management are necessary by routine measurement of BP at regular antenatal care visits. Pre-pregnancy counseling is required with patients with chronic hypertension and other comorbidities. Management of these patients should be done by team of obstetricians and cardiologists. Thank you.
Thank you, Dr. Anupama Hegde, for your very nice and lucid presentation. And so we are going to have the questions after the ending of this session. Dr. Rajalakshmi, anything? So fine. Can we go to the next speaker? The next speaker is Dr. Sarita Rao, and she is going to speak on peripartum cardiomyopathy and update. She is a senior interventional cardiologist from Apollo Hospital, Indore, and she is going to speak on this a very interesting topic on peripartum cardiomyopathy. So over to Dr. Sarita Rao.
Thank you, madam. Am I audible?
Yeah, you're audible. Well.
Good afternoon, ladies and gentlemen. Today my topic is peripartum cardiomyopathy. So this is a form of systolic heart failure with reduced LV ejection fraction, and it affects the childbearing women during pregnancy or in the early postpartum period. Now, the delay in the diagnosis, this usually occurs because the symptoms and the signs of peripartum cardiomyopathy can mimic the normal findings of late pregnancy and the peripartum period. So to define it, it's basically heart failure secondary to LV systolic dysfunction with an ejection fraction to the tune of less than 45%. It usually occurs towards the end of pregnancy or in the months following delivery. And usually the diagnosis is by exclusion and no other identifiable cause of heart failure should be present. So various risk factors have been postulated for the development of peripartum cardiomyopathy. The probable risk factors would be a twin pregnancy, a high parity and a high gravida, and extremes of reproductive age. So the elderly ladies usually have it more, a prolonged period of tocolysis, also a possibility of pre-existing smoking, pre-existing hypertension, malnutrition, substance abuse such as cocaine, and African ancestry. They usually have a higher incidence of peripartum cardiomyopathy and a lower socioeconomic status. Also, some genetic factors have been postulated. So preeclampsia and hypertension were found to be strongly associated with peripartum cardiomyopathy. And in a study which was a meta-analysis of 22 studies having more than almost 1,000 patients, they found that preeclampsia was present in 22% of the women as compared to an average worldwide rate of 5%. Now, if you look at the maternal mortality, the global estimates of the incidence of peripartum cardiomyopathy varies by regions, with reports as high as 1 in 100 deliveries in Nigeria to as low as 1 in 20,000 deliveries in Japan per se. Now let's look at the Idiopathogenesis. Well, there are various, triggering events: a hemodynamic stress, a possibility of a viral myocarditis, a microchimerism because of the fetal cells. And the proposed pathogenesis is a two-hit hypothesis in which we have genetic factors, we have the titin truncating variants, and various anti-angiogenic factors, and of course the cleavage product of prolactin. So basically, peripartum cardiomyopathy is likely caused by a complex interaction of genetic and environmental factors both. So when we talk about the pathophysiology of this disease, it's basically a vascular hormonal hypothesis. So the secretion of the prolactin by the pituitary gland, and which cleaves into a 16 kDa fragment, which causes the damage, and then the placental secretion of the soluble FMS like tyrosine kinase receptor 1. Both of these ultimately, the end result is cardiomyocyte dysfunction and apoptosis, leading to the peripartum cardiomyopathy. Now, based on this knowledge which we discovered from this, one of the newest strategies for treating peripartum cardiomyopathy is based on this, which they tried prolactin inhibition with the use of bromocriptine, which receives a class 2B recommendation, but it also impairs the nursing ability. So what are the symptoms of peripartum cardiomyopathy? Well, the symptoms are very similar to those that a normal pregnant woman would have in late pregnancy. So the overlap is because all women would experience fatigue, tachycardia, dyspnea, and edema. But then the patients with peripartum cardiomyopathy also complains of chest pain, orthopnea, PND, and on examination they have rales, a third heart sound, and hepatosplenomegaly. There are various differential diagnoses of peripartum cardiomyopathy, which must be explored before we make a diagnosis of peripartum cardiomyopathy, such as a myocarditis or a pre-existing familial or an idiopathic cardiomyopathy, or a pre-existing valvular or congenital heart disease. The possibility of pulmonary embolism, amniotic fluid embolism has to be ruled out before we label it as PPCM, and also a pregnancy-associated MI needs to be ruled out. So there are various points on which we can rule out the other possibilities of the cardiomyopathy and the heart failure are all elucidated. I won't go into the details, but we can look at the biomarkers, the echo, the cardiac MRI, and differentiate it. And also, very importantly, the history. Various circulating biomarkers of peripartum cardiomyopathy have been elucidated, and some are used for the prognosis, some for the diagnosis. We predominantly focus more on the BNP and the NT-proBNP levels. So whenever we have a patient who's a suspected acute peripartum cardiomyopathy, we look at the natriuretic peptides on one hand and the echocardiography on the other hand. So if we have an ejection fraction less than 45% and we have an elevated markers, then the possibility of an acute peripartum cardiomyopathy becomes more likely. Now, how do we manage it? Having diagnosed it, we would need to manage it, and the management has to be pregnancy specific. So we would have to look at excluding drugs that may have a harmful effect on the developing fetus or that are contraindicated during breastfeeding. So the ACE inhibitors, the ARBs, the RBs, the potassium-sparing diuretics, warfarin, ivabradine should be avoided in these patients. Otherwise, according to the latest guidelines, the treatment of the heart failure in this condition does not deviate from the recommendations used in acute heart failure or cardiogenic shock of a different etiology. So various drugs which are safe during pregnancy and lactation can be used, such as the loop diuretics, the beta blockers, the JAKs and heparin. So these can be used, and of course the hydrolysine and isosorbide dinitrates can be used. Now, depending on whether we are dealing with a mild form of the disease, a moderate or a severe form of peripartum cardiomyopathy, the management would differ. So in a mild case, we could get away with oral heart failure drugs and oral diuretics. But in a severe case, the patient would require admission and would require IV diuretics, inotropes, possibility of an invasive ventilation or mechanical circulatory support. And of course, the role of bromocriptine comes in. Whether we use it for 1 week or we use it for up to 8 weeks would depend on what is the condition of the patient. Now, whenever we are dealing with a patient who has an ejection fraction less than 35%, the question of whether the patient requires an ICD also comes into role. But because the LV recovery is so common in a patient with peripartum cardiomyopathy, the decision to insert an ICD has to be delayed. So maybe a wearable cardioverter defibrillator can be considered instead, and we should wait and confirm that this patient has a no recovery, only then it can be used. In a patient who cannot be stabilized hemodynamically, an urgent delivery by a cesarean section is necessary. However, for patients who are hemodynamically stable, a vaginal delivery would be preferred. Now, breastfeeding, that's a controversial situation. So it was earlier thought that because of the high metabolic demands of lactation and breastfeeding, preventing lactation may be considered in these patients with severe heart failure, received the class 2B recommendation. But now we have other studies which say that, you can breastfeed the baby. This was the board scheme for the therapy of patients with acute peripartum cardiomyopathy, usually addresses patients after delivery who do not breastfeed. So we have bromocriptine, oral heart failure, drugs, anticoagulation, the relaxants, vasodilators, and the diuretics. Now, bromocriptine treatment is considered a class 2B recommendation depending on the disease severity. So there are various regimens of this. And for a patient who has an ejection fraction greater than 25%, no shock, no ICU treatment, the dose would be 2.5 mg once daily for 7 days. Gradually, it's escalated up depending on the severity of the LV dysfunction, RV dysfunction associated, and whether the patient is on an invasive ventilation or not. And you can up titrate the dose up to 10 to 20 mg daily, depending on the serum prolactin levels, and you can go up to as long as 8 weeks. Also, bromocriptine needs to be, with bromocriptine, we need to give prophylactic anticoagulation because the higher incidence of thrombosis. If you look at the clinical outcomes for peripartum cardiomyopathy, well, the poor predictors of outcome would be the race of Black women, patients who have severe LV dysfunction, who have an LV EDD of greater than 6 centimeters. However, 72% of the women with peripartum cardiomyopathy do have an improvement in the LV ejection fraction. The maternal mortality varies from less than 2% to as high as 50%, depending on these criteria. And the risk factors for an increased mortality would be a worse NYHA functional class at ejection fraction less than 25%, a Black race multiparity, and an elderly age group. So what is the risk in a subsequent pregnancy in a patient with peripartum cardiomyopathy? Well, if they have partially or fully recovered LV function, the EF has gone to greater than 50%, then there's still a substantial risk of relapse with a subsequent pregnancy. But the risk of heart failure of death is less than 10%, and usually you have a good fetal outcome. However, for patients who have a poorly recovered LV function, the ejection fraction continues to remain low. These are the patients who have a higher risk of relapse with the subsequent pregnancy. The risk of heart failure or death is greater than 10%, and there is a risk of premature delivery and fetal death. So we should advise against it. Now, having said that, how do we go ahead and give these patients contraceptive choices? Well, what is recommended is an IUD device or a progestin-only contraceptive. Estrogen contraceptive should be avoided, again, because of the high risk of thrombosis. And there are still gaps in our knowledge. A major question is, how long do you treat this patient? So what is the optimal treatment of women with a recovered LVEF who make up the majority of our cases? Well, the treatment is recommended for at least 12 months after recovery, and a period of time without medication and recurrent echocardiogram is ideal for confirming that the ejection fraction again does not deteriorate before a decision is made regarding a new pregnancy. Complications, we have both maternal and fetal complications.
Sorry to interrupt you. Now,
yes, madam. 1 minute left. Okay, so maternal complications include thromboembolism, arrhythmias, heart failure, sudden death, fetal complications, fetal distress from hypoxia. So to conclude, the diagnosis should be considered in any pregnant or postpartum women with symptoms concerning for heart failure. Elevated BNP level and echocardiogram has to be done. Prompt treatment with medications tailored for pregnancy lactation may prevent adverse outcome. Limited studies suggest that breastfeeding is safe, and acutely ill women may require advanced heart failure therapies. When considering a subsequent pregnancy, they need proper counseling and follow-up. And long-term follow-up is still important because the optimal duration of medications following recovery is still unknown. Various questions still remain. So important gaps in our knowledge would remain the optimal anticoagulation strategy, timing of ICD, risk prediction management during a subsequent pregnancy, and long-term duration of medicines. Given the overall rarity, collaboration among multiple centers will be needed to answer these questions. Ladies and gentlemen, thank you so much.
Thank you, Dr. Sarita Rao, for a very excellent presentation. You had covered the wide topic in a very brief and very precise form and given all the reasonable explanations, and plus with the emerging risk factors and also the treatment modality and all explanation explained well. So,
thank you, madam.
So now we go on to the next speaker. I call upon Dr. Rupa Salvan, and she is going to speak on cardiac interventions during pregnancy, how to ensure a safer outcome. So over to Dr. Rupa Salvan. She is a senior director of MAX program from Delhi, consultant intervention cardiologist, and she is going to speak on this very interesting topic on pregnancy and how to ensure the safe outcomes. Over to Dr. Rupa. Rupa, you're not audible. Dr. Rupa, your slides are seen, but you're not audible.
Please unmute yourself, madam.
It's okay.
Thank you very much. And I think, thanks a lot to Vinkas. A lot of us are here today, and Jyotsna and Asha ji for all you've done. I think we all are just getting benefits of all your hard work, but thank you and cheers to all of you. So, cardiac intervention during pregnancy, how to ensure safe outcomes. How do the slides move? Any help on how the slides move?
Slides have been moved.
Yeah, okay, they're moving to along. So, pregnancy is a major life event for almost every woman. And in a woman with heart disease, pregnancy is associated with additional risks and deserves special attention. It can bring out or destabilize well compensated disease, or occult pre existing disease may first manifest under the pregnant state. So, maternal heart disease complicates between 1 to 4% of pregnancy and accounts for 15% of mortality. Now, seen in context, maternal mortality in developed economies is about 12 per 100,000 live births. In emerging economies, is 239 per 100,000 live births. And in the ROPAC registry, a 0.6% mortality converts to 600 per 100,000 live births. And this is the responsibility we all have to really deal with to reduce the maternal mortality in the next few years, which is also a WHO goal. The burden of heart disease is expected to increase with women with corrected congenital heart disease reaching adulthood, a trend to delay motherhood, with a rise in comorbidities like the metabolic syndromes, and in countries like ours, rheumatic heart disease is still the most important cardiac disease in a pregnant woman and the most important cardiac cause of maternal death. So the registry of pregnancy and cardiac disease is the largest registry of its kind ever taken between 2007 and 18. It was a prospective registry of 5,739 pregnancies in women with structural valvular heart disease, ischemic heart disease, PH, and aortic pathologies. The most important complication in women is heart failure, which occurs in 11%, and 7% of them can be seen for the first time in postpartum. Arrhythmias, thrombotic event, aortic dissections are also seen. Majority of them have normal deliveries, but obstetric and fetal complications are seen in about 20%. Now, the valvular heart disease unfortunately do worse. Most of them come in late in pregnancies, meaning to say that they only become symptomatic when they're severely symptomatic and can't tolerate the symptoms. Is that the attention they come to the attention of family and healthcare, and this has a much higher mortality and a higher incidence of heart failure. So the ROPAC's registry over the last 10 years of its being has seen that the highest mortality is in cardiomyopathy and pulmonary artery hypertension. But interestingly, with the systems that were put into place, though they were seeing more class 4 WHO patients, the outcomes of these patients was actually better. So the worst outcomes were seen with cardiomyopathy, but over 10 years, even those improved. Valvular heart disease comes next, and congenital heart disease that is corrected has a comparatively lower incidence of complications in pregnancy. Now, the WHO scale and the three clinical scales, the CAPREC, Zahara, and ROPAC, are integrated. What the WHO scale, so first let's come to the hemodynamic changes and the physiological changes that happen in pregnancy. The cardiac output goes up by 80% more so during labor and the puerperium. And the aortic wall fragmentation of the medial elastic with the increase in heart rate and autonomic nervous system change is seen. Now, this graph nicely tells us that the cardiac output goes up right from the first trimester, peaking at 24 weeks, initially contributed by heart rate and subsequently by increase in plasma volume. Left-sided lesions, obstructive lesions, and right-to-left shunts are very poorly tolerated in pregnancy because of these reasons. Now, the maternal risk is of death, stroke, arrhythmia, heart failure, while the fetal risk is of IUGR, embryopathy, intracranial bleeds, and recurrence of heart disease in the child in patients who are born after treatment. Now, the risk stratification, the WHO is an important basic step. It's based on expert opinion. It gives the first impression, and mainly for congenital heart disease. It should be integrated with the three clinical scales, the CAPREC, the Zahara, and the ROPAC. So this basically puts you, if you're in grade 1, you can carry on where you are and you don't need to be referred. But grade 2, grade 3 need to go to specialized centers. And in grade 4 WHO, pregnancy is contraindicated. And after treatment of underlying disease, they should be done in high tertiary care centers. There's also a classification of valvular heart disease of low maternal risk in mild valvular lesions, mitral valve prolapse, high risk in severe lesions, independent maternal and neonatal risks. And I think it is for each of us in our setups to adopt these and adapt them to our requirements. Rheumatic disease remains the most common form of disease, but the other ones that are seen are mitral valve prolapse, prior endocarditis, and valve lesions in patients with systemic diseases. Now, in the ROPACs, there was a large number, 319, of rheumatic valvular disease and pure mitral stenosis. I mean, a good, majority of patients had mitral stenosis, isolated MR in a quarter of them. And the mild and the severe could be 20%, but a very sizable person, 40%, are in the moderate range. And this is where the discretion happens in their treatment. Now, these patients with mitral stenosis have more fetal deaths. They give birth to babies which are small for gestational age. They have preterm babies and they have low birth weight babies. Now, the risk of heart failure, we know about moderate and severe, but is importantly even happens in mild mitral stenosis. And while it can happen in pregnancy and the first week after that, a significant number of patients go into heart failure only at delivery. And this is understandable from the autotransfusion from the uterus after labor, after delivery. So this study has led to a lot of change in the, it has made BMB a class 1 indication in a patient with less than 1.5 centimeter pre-pregnancy, even if she's asymptomatic, because the odds of going into heart failure are very high. In severe MS, it is clear that before pregnancy, if it is identified, she should be treated. And in pregnancy, if it is identified, they should be treated preferably in the second trimester or whenever they present. Now, the moderate ones can be kept on medical therapy, but the threshold to do a BMB is truly low because these patients are unpredictable in their behavior, and heart failure is what takes the mother's life. Now, when we take these patients to lab, radiation is important. The basic principle of radiation is as low as reasonably achievable. That's the ALARA principle. The effect of radiation can be stochastic and deterministic, and the fetal radiation of less than 5 millisieverts is what is considered to be safe. It doesn't mean you have to go there. Any amount of radiation is harmful. Second trimester, organogenesis is complete. And also the uterus is small. The distance between the chest and the uterus is lesser. So second trimester is usually the preferred time to do an intervention. Now, do it on fluoro. Do not use the cine. To put in perspective, low dose fluoro, you give 20 micrograys, and on cine, you're giving 200. So minimize the fluoro. Be careful of radiation, but that's not a reason to not offer a patient a life-saving procedure. You must keep the X-ray source as distant as possible from the patient and work in an AP plane, collimate well, and use an echo or an ultrasound guidance for the vascular access wherever possible. If you're doing coronary interventions, go to a radial approach and shield the abdomen. So this is coming to the distance when the eye is close to the patient and the source is far, the radiation is the least. And second is, if you're going to do magnification, you're going to increase the dose by 4 times. If you keep the fluoro down to 3 frames per second, you're going to minimize the dose to 20% of the dose you give on a full. Now, we all are using lead, but you must understand in the beam, it's more the scattered radiation that is affecting the fetus. And this lead gives more mother a psychological advantage. And the most important thing in the lab is the operator motivation. After putting lead, it doesn't spare us from all our responsibilities of keeping the fluoro rate down, of collimating, of using minimum and doing it. Now, there are many series from India on BMB in pregnancy, but I'm going to speak on the recent publication by Rupali. I hope she's on the panel. And this, I think, is a very nice study of 97 patients, retrospective over 10 years. Following that, majority of these patients had their intervention in the second trimester. A significant number had AFib, and they also had a prior BMB. A successful procedure, but the good thing is she talks of the mean fluoro time is just 6 minutes. She talks of the complications or the worsening of MR grade, which doesn't change the clinical picture of the patient, a non-yielding valve with an embolic infarct and fetal death, or adverse outcome in the form of fetal demise and preterm labor. These are high-risk procedures, and we should not, feel shy to say that this happens. And I think it takes a lot of courage, to be honest, in our publications where we do, say that these are the risks and these are the ways to do it carefully. And also on a 5-year follow-up of 89% and a 10-year follow-up of 65%. Now, aortic valve disease is a second disease. Bicuspid valve is in 2% of the population. Along with it, the aorta can be weak. And the patient should, if they have aortic stenosis diagnosed before pregnancy, it should be treated. If they come into you in pregnancy, it's a very tough decision because if the valve is clear, it's not thickened, you can do a cautious BAV with an undersized balloon. The biggest problem with this is you can have an uncontrolled regurgitation, and also you don't know the duration of benefit. You may do it in the second trimester and by third trimester again have a failure. It's very important to have a rescue surgical or a TAVI backup when you do these interventions. Surgery is safe for the mother, but the baby's outcome is terrible with a 30% mortality. A lot of women opt for bioprosthetic valves that degenerate rapidly. Pregnancy itself does not hasten the rate of degeneration of these valves. Now, dilemma and intervention is the TAVI during pregnancy. The first publication was in 2016 of a 22-year-old patient who presented at 15 weeks. She had a BAV at 9 years of age and was very active.
Rupa Sarwan, sorry to interrupt you, the time is over. So you can just summarize your talk.
This was done with transesophageal echo guidance, a self-expanding valve, monitoring the uterine artery. Pulmonary hypertension, AV malformations are also seen sometimes with a normal structural heart, and they are very high radiation consuming, so they should not be done in pregnancy. MIs are seen in women of which spontaneous coronary artery dissection, coronary embolism from valve and spasm can happen. And these tend to happen more often in multigravida in the third trimester. And angioplasty is, to be done only as life-saving for the mother. In spontaneous dissection, CABG can be seen if there are multiple vessels with spontaneous dissection. We are seeing patients with coronary artery disease. I've had a patient with edema who came in, but they surprisingly do well. And except for a STEMI intervention should be avoided, they should be managed medically. Assisted technologies don't increase the incidence of MI. And the last I would cover is a patient presenting in complete heart block. Even in them, you can implant a pacemaker using electroanatomic mapping of the heart and ultrasound guided axillary and a femoral vein puncture and implant these pacemakers. The arrhythmias, we must just highlight that cardioversion is extremely safe, and adenosine is safe in pregnancy rather than using drugs which are harmful, followed by beta blockers. And the guidelines have most importantly said that every patient should have a risk stratification and should be sent to a multi-team effort. And we are going to see more pregnant patients, and we are as responsible to reduce mortality in this group.
I'm not able to hear. Now the sound has gone.
Multidisciplinary teams are there. Now, behind every outcome is a series of
processes. I'm not hearing them.
Outcomes. We have to address these processes, and we have to close the implementation gap. And from autonomy of physicians, we have to convert to more accountable teams.
I was able to hear them till now. Now I'm not.
Dr. Rupa, I thank you very much for your very good presentation. And this is being a very interesting topic, very large subjects have been, indications has been covered. And now we are going to a very interesting session.
Ma'am,
that is.
Excuse me, madam. We will have a short discussion on these three topics. Following that, we will go to the case-based discussion.
Fine. Okay. So now let me go.
I wanted to actually start with the first topic. That is pregnancy-related hypertension.
Yes.
The major importance is. The major importance is not only the management of the hypertensive crisis during the pregnancy, but long-term outcomes also has to be the paid attention. So actually we brought up one separate issue on the pregnancy-related heart diseases about 1.5 years back from the IJCDW, which mainly says how do you risk stratify these hypertensive emergencies during a pregnancy, and subsequently what is the event rates of the developing the cardiovascular events. Even though the theoretically it's supposed to be the subset after the postpartum period, after 42 days after the pregnancy, after delivery, many of the times it doesn't happen. Is the controversy that comes whether it is persistence of the hypertension before or the subsequently. So I wanted to know the Anupama madam's opinion on these follow-up of these cases, how frequently they see them, do they have the collaboration with gynops people to have that?
We have collaborated gynops people, and the initial recommendation we say is first 2 weeks after delivery, let them come for the first follow-up to see how much is the optimization of the antihypertensive therapy. Then once in 4 to 6 weeks, we ask them to come for follow-up. Especially the new category of people whom the blood pressure was recorded for the first time after 20 weeks of gestation, especially those who are unbooked cases. So these patients, we ask them to come back after 42 days after delivery to reassess whether this was just a gestational hypertension or the patient had a pre-existing hypertension. We have to decide on long-term therapy on that.
Yeah, I want to know whether long-term prognosis is told to the patient, and is that informed to the patient that they requires a follow-up with the 5 years, 10 years, or 15 is down in the lane. That is the most important.
Yeah, that has been highlighted.
Okay. Because this gynops, cardio gynops is becoming a very important branch nowadays on the cardiology, which requires a real multi-team approach and requires a risk assessment at every 5 years, not even a decade. Previously, it was told as a decade, but these high-risk patients requires a much more frequent evaluation. I expect the Vijayalakshmi Madam's comments are also on this topic.
You're not.
Would you please would you please unmute, madam?
She is unable to do. Dr. Anupama Hegde, I have a question for you. Is it possible that what criteria do you take in hypertension, the ACC guidelines or European Society guidelines or Indian International Society of Hypertension or the Indian Society of Hypertension? Which criteria to take to say that the patient has gone into an accelerated form of hypertension?
Now the cutoff is in pregnancy 160 by 110 is accelerated hypertension in all the guidelines same.
Okay.
But for treatment, now the recent NICE guidelines has said the cutoff is at 140/90. And they say bring down BP to less than 135/85. So that is the recent guidelines they said.
Okay.
Rupali, would you like to add anything to this topic? Vijayalakshmi Madam's voice is not coming anyway.
Audio is not there. She had some problem. Dr. Vijayalakshmi had a problem with the audio yesterday also with one of the meeting. And I think
Rupali doesn't have any other questions. I think we'll take up the next point of it. Please.
I just wanted to ask, I'm Dr. Rajalakshmi. I just wanted to ask Dr. Sarita about the mechanical circulatory support and ECMO role in peripartum cardiomyopathy. ECMO, role of ECMO.
Good afternoon, madam. Madam, in very severe peripartum cardiomyopathy, those patients who require hemodynamic instability require admission to the ICU. If they are not stabilizing on IV inotropic support, and they have gone on to invasive ventilation, then in these patients, there are few small studies in which they are saying that you can try ECMO, right? But we don't have still large studies on that. But yes, they have recommended that in refractory cases not responding to anything, we can try it.
And anticoagulation, I just wanted to ask you, do you anticoagulate if you find severe LV systolic dysfunction in a patient, maybe less than 25, and you are on other optimal medication? In the absence of atrial fibrillation and LV thrombus or systemic embolism, do you anticoagulate such patients?
Yes, madam. That is a very interesting question, and it opens up a whole vista. So any patient, even according to the routine heart failure guidelines, any patient who has severe LV systolic dysfunction, presence of an LV thrombus or atrial fibrillation per se will require anticoagulation. So we do anticoagulate such patients. The second thing is that there is a high risk of thrombosis in peripartum cardiomyopathy, especially if you have started the patient on bromocriptine. So the risk of thrombosis is high in such patients. So the recommendation is that we should anticoagulate these patients. According to the latest update, which has been published by the ACC, they are recommending that anticoagulation should be given depending on what is the severity. So if it's mild, you could anticoagulate for up to 1 week. And if it's a severe one, you can anticoagulate to up to 8 weeks. So yes, anticoagulation is now receiving a class 2A recommendation. They are recommended it, but yes, severe LV systolic dysfunction, thrombus, and presence of atrial fibrillation, we do. The other thing is that, especially these patients, sometimes they've undergone a cesarean section. So again, the immobilization risk would be higher. So these patients are more predisposed to develop a thrombotic event. So I think, yes, anticoagulation has to be given.
This question is for Dr. Sarita. I just want to interpret. This FMS tyrosine, the investigation for detecting this preeclampsia, can be done routinely because availability is a matter of this thing. It's not available easier.
It's not easily available. So I was also listening to Dr. Anupama that she also mentioned that. So that is basically, it has a role in the Idiopathogenesis, but not routinely available. So I don't think it would help us so much. It's much more easy to do the BNP levels for the diagnosis and for the prognosis of the patient, and also to look at the treatment effect. So, but FMS tyrosine is difficult.
Okay.
To do.
What about the Arrhythmia and other minotropes? like it is tried in all the refractory and heart failures? Is there any studies or is there any contraindications in a particular set of the people we can't use them?
Good afternoon, madam. A very interesting question, madam. So whenever we are treating a patient with heart failure and pregnancy, the question is always there that we have to optimize the treatment for pregnancy and for lactating mothers also. So for pregnancy, ACE inhibitors, ARBs, ARNIs are contraindicated. And also MRSAs. So subsequently after that, if the mother is lactating mother, again, they have said that ACE inhibitors, ARBs, you should avoid. But if the mother is not lactating, then possibly we can try all of these drugs on these mothers, and they would help.
Actually, when we wrote these drug-drug interactions in the recent past of COVID, then we came across the same topic, whether we should have the avoidance, the lactation should be the stopped or the drugs to be the continued. So it is a general condition of the patient. If the peripartum cardiomyopathy is not always that is before the delivery, and most of the frequently we see after the delivery.
After the delivery,
the general
also.
condition of the patient is requires it. It's better to stop the lactation and start the drug therapy than thinking about it. And Anita madam have put a one question, that is, does the BNP useful for a prognostication?
Yes, madam. In the biomarkers which they have elucidated for both the diagnosis, prognosis, and a combination of the two. So they have said that BNP and NT-proBNP can be used both for the diagnosis and also for the prognosis. So depending on how the response is to the treatment, if we are treating a patient aggressively and the BNP level still remains high, so we know that this patient is not going to do very well, is not responding very well.
Do you use bromocriptine? Do you use?
I personally do not use bromocriptine. I would like to ask Dr. Jyotsna whether she uses it or not.
Yes, we use it.
No, we do use for bromocriptine for patients with peripartum cardiomyopathy too. Yeah, with the severe LV dysfunction, definitely.
Yes.
But we have to titrate the dosage. We have to titrate the dosage. That is first few weeks, and then we have to give the accordingly.
Yes, very true. So the dosing recommendations are very interesting. So you can start from as low as 2.5 mg once in a day, and you can increase it to 2.5 BD. And in severe cases, you can go up to 10 or 20 mg per day. And then you would have to look at the serum prolactin levels to titrate your dosages.
Okay. Yeah, we use it. But most frequently what we do it is at the end of the 7 days, we re-evaluate the patient, because there are some people will develop really because of not only the breast suppression of the milk, they have the side effects significantly of the breast pains and everything. So we can't say take it granted that only the control with the bromocriptine. So at the end of the 7 days, again we re-evaluate. If the patient is able to tolerate, we will continue further till the 6 weeks. But many of the patients, we are getting a good results within 1 week, and it may be a natural because it is not a randomized control trial to say that it is not happened in the control patients. So, but we are seeing, and we have to stop at the end of the 1 week. Only the 30% probably, I'm not sure, may be requiring a continuation for the 6 weeks.
Yes,
another thing for Dr. Sarita or anybody can question whoever is saying that feeding for baby is safe, they say. But what the studies have shown that there is evidence that there is a secretion of this prolactin and subfragments in the milk, and it is not safer for the babies.
So, no,
feeding is not recommended for patients with high risk situation. That's what they mentioned.
Madam, that's a very interesting question. So this is one of the ongoing controversies regarding peripartum cardiomyopathy, is whether to breastfeed or not to breastfeed. Yeah. One is that when you're giving prolactin, you're suppressing breastfeeding. The second thing is whether it's safe or not, because the cleavage fragment you're talking about, that's a 16 kDa fragment which comes. But there have been small studies in which they have continued breastfeeding without any adverse effects. So the earlier 2018 recommendation was that do not breastfeed. But now the recommendation is changing, and there have been small studies in which they have elucidated that it is safe to breastfeed. So I think at the end of the day, we can breastfeed right now.
Yeah.
Yeah, about the interventions during the pregnancy, I think other than of course, all of us are doing the PBMVs much more frequently than any other intervention. I would like to ask Rupa Salwan, because we have done in a coaptation and tie over crisis of the aortic stenosis, balloon dilatation. So, as the madam got any other cases like anecdotally to say that these are the helpful during the pregnancy to tie over the crisis to for both, which is safe to the mother and baby.
A lot of high-risk pregnancies, if you manage them, we have followed a team approach. The obstetrician, the anesthetist, and the cardiologist literally see the patient twice a day, and we are able to tide through most of them. So a BAV we have done in pregnancy, and PTMC all of us have done. Ravi, I have heard that in Jaipur, Dr. Ravinder Rao did a week or 2 weeks ago, a month ago, but the outcome of the patient has not been shared. So these are all new things, and most patients with the pulmonary AV fistula I mentioned to you, she settled down. What we did carefully was we screened her spine because they had to give an epidural, and sometimes there are multiple hemangiomas. So when they give epidural, you can't have an hemangioma sitting there. Eisenmenger we have delivered. We were so scared to see the mother or the child will all die, but we've been able to deliver. I think what I'm trying to highlight is a teamwork and very meticulous attention to patient requirement. We are doing small things, but those little things add up significantly in pregnancy.
This pulmonary arterial hypertension,
I think
actually, a doctor.
in cath lab, I think nobody is really taught in detail about how to minimize radiation, and there's a lot of casualness after putting lead. So that is extremely important. Another important thing is when you do CT scans, we don't understand the breast is more sensitive to radiation. So just doing CT scans, whether it's for a pulmonary embolism or aorta, is not good because that breast is also susceptible to cancer later. So holding your hands back and tiding over, and after delivering the mother, dealing with the problem is important.
Yep. On the contrast, actually,
except for mitral stenosis or an aortic stenosis, where the patient that's life-saving, you'll be able to come out of it.
Yeah. Another point for the breast cancer, no, sorry, not cancer, breast calcification. In the elderly people, probably this may not have been applicable because breast calcification presence itself may be a marker, one of the marker for the, like a CAT for the detection of the coronary atherosclerosis. Probably in the younger females, yes, it is going to be then very effective.
Even non-STEMIs, you can manage them medically. So a lot of things can be managed medically, except for the obstructive outflow tract, mitral and aortic valve, or a coarctation if you saw.
Yeah, we had a case of actually pregnancy-related aortic dissection, coronary dissection, and fortunately we can come out with a good result by putting a one stent. But there really we had to pay attention because most of the time it is a progressive dissection occurs and multiple stents may be required. After putting all the stents, sometimes we have to send to the surgery. That is also becomes an added risk. With the stent, it becomes difficult for them. I think we have only the 1 more minute for the discussion. If anyone want to add anything, I will be.
Dissections are of different types. So if you see a clear 2 lumens, you shouldn't intervene. If you see a hematoma compressing like looks like a normal lesion, then stent it very gently. Again, in these patients, we don't give statins. We don't want those vessels, so they differ. So use a bare metal stent and come away fast with a single antiplatelet beyond 4 weeks and no statins for these patients, even in the long run.
I just wanted to add one point that recently I've been reporting the CT coronary angiograms, and I found that younger women are having a lot of breast calcification, and they are prone for a coronary disease in a later event because the risk score, if it is more than 401, it is significant. So what we found is that in the proximal level of the LAD and left circumflex, we find when there is a calcification, or in the artery territory, we find there is some evidence that there is a calcification seen in the breast tissue also. So such patients should be followed up and screened up regularly. That is my advice for patients going for a CT coronary and for follow-up patients. Yeah.
The changing scenario, I had a patient who had a Lima put for her LAD because she didn't want, stents and stuff, and then she had a very uneventful pregnancy. But it's very intimidating to see a patient with a graft coming to you for antenatal checkup. But things are changing. The younger population are changing.
Yes.
Thanks for all the people. I think now this is the time to start on a case-based discussion.
Yes.
And our great teacher, Dr. Anita Saxena, is going to discuss about the congenital heart diseases patients. And really, I am thankful to you, madam. We had so many webinars on the congenital heart disease for the students. And now again, madam is going to discuss much more effectively. Madam, please. Anita Saxena, madam, doesn't require any.
Over to, No, Dr. Anita Saxena, who is a Professor HOD of All India Institute of Medical Sciences, eminent speaker and renowned pediatric cardiologist, is going to speak on a very interesting topic, and we are going to have a good discussion on this. 20 weeks, that is primary gravida with tetralogy of Fallot with saturation of 85%. And so what is your concerns and how will you manage the situation? So over to Dr. Anita Saxena, please.
Thank you, Asha. Thank you, Jyotsna. Am I audible?
Yeah, you are audible, well audible.
Thank you. So thanks to the organizers, thanks to the chairpersons and the experts. This is a case that is given to me. It's a 20 weeks primary gravida with tetralogy of Fallot, saturation of 85%. And what are my concerns and how would I manage this case? So I'll take you through some of my ways of looking at it and how should I be managing this case. Before I start, I would just like everybody to sort of revise their understanding of pregnancy. I think all of us know as cardiologists that there are lots of changes that happen during the pregnancy, and the worst time, or let us say the maximum changes, are end of the second trimester and early third trimester, where there is an increase in blood volume by about 50%, increase in cardiac output, increase in heart rate, and a fall in pressure, and therefore there is a fall in total peripheral vascular resistance. So that is something very important we need to remember, that the vascular resistance in the periphery goes down. A lot of changes happen again at the time of labor. So there is further increase in oxygen, increase in cardiac output, and there is a lot of tachycardia. With each contraction, there is blood volume pushed into the mother. So I think further things are likely to deteriorate during the time of labor. On top of that, I think another thing that we need to remember is that pregnancy overall is a hypercoagulable state, with increased risk of thromboembolic events, and that again becomes important when we are dealing with a cyanotic patient. So what are my concerns? Obviously, the major concern is for the mother, because we know that there is higher morbidity. It has been described up to 50% in many cities, and a mortality of even 12 to 15% has been described from some of the developing countries. But overall, if we look at the figures, about 5%, which is obviously much, much higher than the maternal mortality currently even in India. And for the fetus, there is much more higher fetal wastage. There's likelihood of small for dead babies, preterm labor, and of course, the risk of recurrence of congenital heart disease in the fetus. However, having said that, I would be less worried if the mother has tetralogy than I would be if mother has Eisenmenger syndrome, because Eisenmenger syndrome, the mortalities are in the tune of 30 to 35%. Although we all have experienced safe delivery in some of the Eisenmenger syndrome, but I think that's a much more serious condition than a tetralogy of Fallot as far as mother goes. Now let us look at the maternal concerns in little detail. How does tetralogy of Fallot affects, or how does pregnancy affects tetralogy of Fallot physiology? So as I said, there will be decrease in the systemic vascular resistance. So there will be more right to left shunt, more hypoxemia, and that will lead to increased hemoglobin and increased hematocrit, which are themselves risk factors. And more of erythropoiesis leaves no room or less room for thrombocytopenia, and therefore these patients are likely to have thrombocytopenia. Then the right ventricle, which is already working at a systemic pressure, is further stressed. So there is likely to be right ventricular failure, especially in adults with significant cyanosis, where right ventricle and left ventricle have been exposed to hypoxemia for a long time. And the hypercoagulable state could lead on to thromboembolic events. Other than that, there are a couple of more points that we need to remember. One is more chances of bleeding, because we know these patients, although they may be polycythemic, but they have abnormal bleeding parameters, and that may lead on to hemoptysis during pregnancy or postpartum hemorrhage at the time of delivery. Infective endocarditis, definitely cyanotic heart diseases are more prone to infective endocarditis, and any delivery or labor is a sort of a manipulation that may increase the chances. And because of hypoxemia and because of thrombocytopenia, more infections are likely in these pregnant women. And another point, which is perhaps not very important, is the dilated aorta. By the time they're 20, 25 years of age, majority of unoperated tetralogy of Fallot would have a dilated aorta because of certain inherent changes in their wall, which are further disturbed because of the hormonal changes during pregnancy, and that may lead on to aortic dilatation and dissection. Having said that, it's a rare event. However, one needs to keep an eye for the aortic measurements. So how do we stratify any woman who is pregnant with congenital heart disease? So there are several scores. I think some of them have been talked about. The one that is often used for heart disease in general is RPREG score, where we know that each of these items get 1 point, and if the score is more than 1, then the likelihood of the event could be as high as 65% in a woman who is pregnant. However, Zahara score was primarily developed for women with congenital heart disease, but since it is from the western part of the world, you can see that majority of these points are actually for post-operated cases. So, for example, if you have post-operative tetralogy of Fallot, then you would have pulmonary atrioventricular valve regurgitation, pulmonary valve regurgitation, could almost always there, and then prosthesis and all that. For cyanotic heart disease, you can see that the score given is 1. NYHA class again is very, very important, which has been practically talked about in every score that you would come across for these pregnant ladies. Generally, it is believed that the score of more than 1 would have a significant event rate, and anything between 1.5 and 2.5 is really high event rate during pregnancy. But I think most of us we follow what is called modified WHO risk stratification, where there are 4 grades, 1, 2, 2, 3, and 3. And tetralogy of Fallot falls into WHO risk category 3, unrepaired cyanotic CHD. Most of the literature that we see are from the Western world, and they club all the cyanotic CHDs together, even the ones which have had a shunt, a BT shunt in the past, because majority of the tetralogies would have been operated in these countries. So unrepaired CHD is WHO risk class 3, and aortic dilatation obviously further increases the risk. And in this class 3, it is said that the maternal cardiac events may be to the tune of 19 to 27%. And these women obviously require closer follow-ups and delivery at an expert center. Just to remind you that the repaired tetralogy of Fallot is actually class 2. So that is also not class 1. So one is likely to have more fetal as well as maternal complications, even in repaired tetralogy of Fallot, and the event rates could be 6 to 10.5%, and delivery, although delivery has been allowed at a local hospital. So if it's a good repaired tetralogy of Fallot, even then the risk is little more than the normal population. But of course, unrepaired tetralogy of Fallot who's cyanotic, the risks are much, much higher. So overall, if we look at the predictors of maternal mortality, functional class, very, very important, class 3 or class 4 during pregnancy, and more than, or class 2 prior to pregnancy. Ventricular function, right ventricular dysfunction or even left ventricular dysfunction. Saturation, which is less than 90%. And another factor that has been highlighted is hematocrit, more than 65%. Now let us see what the fetal concerns are. The incidence of fetal and neonatal complications will vary quite significantly depending on the severity of cyanosis. So cyanosis is a very, very important determinant of the fetal growth, and of course, right ventricular function, hematocrit value of the mother. Overall, fetal mortality would be about 3 to 5 times that of the normal baseline. However, morbidity is much more common, seen in almost half of the fetuses. And the commonest one is low birth weight for gestation. So one has to be really looking at the fetal well-being all through the pregnancy. As many as 30-35% of fetuses or babies are born with low birth weight than for the gestation. Prematurity in about 1/4 of these cases, so premature labor is quite common. Recurrent risk of CHD as expected, and then little more depending upon if there are any medicine that the mother is on. The last 2 years ago, ESC published a full guideline on all the cardiac diseases during pregnancy, and in that they said that if the mother has a saturation of less than 85% and the hematocrit is more than 65%, the likelihood of a live birth is only 12%. So tetralogy of Fallot, which is in a cyanotic mother, has quite a significant likelihood of fetal wastage or fetal complications. What is the recurrent risk? It's said to be about 3 to 5% generally, but if you look at all the data, it comes to up to 10%. So obviously, each of these pregnant women deserves a detailed fetal echocardiography to diagnose if there is any congenital heart disease, tetralogy of Fallot, or even any other congenital heart disease in the fetus. Overall, if we look at the maternal fetal outcomes, there was a review article very recently published for various congenital heart disease. And if I want to just show you the data for tetralogy of Fallot, then you will see that even repaired tetralogy of Fallot have a significant amount of complications in the form of arrhythmias and a little bit of increased chances of preeclampsia. But look at postpartum hemorrhage in 10%. And in fetus also, there's about 20% chances that the fetus would have some issue or the other, 6.5% offspring mortality. So this is much, much higher than the average general population. But when it comes to cyanotic or unrepaired congenital heart disease, like our patient who's a tetralogy with 85% saturation, the likelihood of heart failure, arrhythmia, or even progression of cyanosis is so much more. Almost 1/3 of women will have some problem or the other. And again, the fetal complications are also much, much more in cyanotic congenital heart disease in the mother. This was another study which is published quite some time ago, but I always find it very, very interesting and exhaustive because it's a literature review of 48 publications of 2,491 pregnancies where they have really looked at different congenital heart disease. And if we concentrate on cyanotic heart disease, presuming that majority of them would be unrepaired tetralogy of Fallot, we have completed pregnancies in only 55%. 44% of these mothers had miscarriages. So it's a significant number. I'm sure that things are a little better now because this study is about 13 years old. Same study shows cardiovascular events. And what is important over here is heart failure. As many as 20% or 17% have heart failure in cyanotic heart disease as compared to repaired tetralogy of Fallot, which is much less. And when we look at other events, I think what I'm worried about is the thromboembolic events in the mother as shown over here. And this is because of the hypercoagulability state, about 4%. And if you see expected, it's less than 1%. So this is another thing that one needs to keep in mind, and that is how anticoagulation or elastic stockings, etc., become important. Neonatal outcomes are also quite bad, as you can see over here, that a very large number of these neonates have had problems in terms of small for weight and or prematurity, etc., or even mortality. So how would I manage my patient? Ideally, pregnancy should have been discouraged. Tetralogy of Fallot should have been repaired before planning pregnancy. But very often, as we have in India, that people come to us when they're already pregnant. Termination of pregnancy would be advisable in somebody who's 12 or 14 weeks of gestation but has significantly low saturation. However, there are situations where either they present late, like this patient of ours who's 20 weeks of gestation, or there is a lot of societal pressure on the family, on the mother to continue pregnancy. So then we are up against a very, very close monitoring system for having a best outcome for the mother as well as for the fetus. And for that, we have something called expert center where we have a pregnancy heart team. And one of the speakers did mention that if you have a very good team along with close monitoring, the team consisting of cardiologists, obstetricians primarily, but then perinatologists, anesthesiologists, even counselors, social workers, nursing personnel, all coming together, we can perhaps expect a better outcome. So how would I manage this patient? Antenatally, I would be calling her rather frequently. In the first trimester, or about first 16, 18 weeks, she could come monthly, but later on she needs to come weekly, and towards the end, maybe bi-weekly. Very often we actually admit these women beyond 32 weeks of gestation and look at their fetal well-being and their well-being on a sort of a constant basis. Hemoglobin, we should try and maintain to about 14 if the saturation is 85%. Avoid going very high, and therefore iron supplementation as usually used during pregnancy need to be avoided, and we should only use it if we have done serum iron studies and we find that there is iron deficiency anemia. Whatever the hemoglobin is, it's better not to do phlebotomy because we know phlebotomy is hardly ever useful in this setting or in any other setting of high hematocrit. Frequent saturation monitoring, some of them can actually have a monitoring done at home. Supplemental oxygen will not do much to the mother. In fact, it probably will not improve much saturation. However, it is likely to improve oxygen delivery to the placenta and therefore may help the fetus. And therefore, supplemental oxygen in deeply cyanotic women is a good idea. Since some of these mothers are pretty on bed rest, it is good to go for low molecular weight heparin or even unfractionated heparin to avoid hypercoagulability and thromboembolic events. Compression stockings should be advised for all. One must avoid getting any air bubbles into the system through IV lines, because we know right to left shunt can actually create havocs in these patients. And close monitoring for fetal growth and well-being by recurrent or repeated ultrasound examinations. Yes, medications, we need to be careful. Beta blockers, if somebody is on, can be continued. It's not a contraindication either during pregnancy or during lactation, so we could continue that. However, if the patient was not on beta blocker, then one must make assessment of the ventricular function before starting beta blockers during pregnancy. And of course, these are the other drugs that everybody is aware of, which are contraindicated during pregnancy. What is the mode of delivery? Vaginal delivery is preferred, like for any other cardiac cases. Cesarean section should only be reserved for obstetric indication. The reason being that blood loss is much, or almost half of cesarean section in vaginal delivery. And blood loss means hypotension. Hypotension means more right to left shunting. So one would try and have vaginal delivery as much as possible. Second stage of the labor can be shortened by forceps delivery. However, cesarean may be required in some cases for obstetric region and in some cases with a very dilated aorta. One may still have to think about cesarean section if there is a very dilated aorta to prevent dissection of aorta. If we decide to do cesarean, one should go for general anesthesia because the overall control of the circulation, blood pressure, volume is much, much better with GA than with regional anesthesia. Intrapartum oxygen therapy and continuous pulse oximetry monitoring. Avoid hypotension, maintain good volume status because hypotension, bleeding would lead on to more right to left shunt. Endocarditis prophylaxis, of course, indicated in all these patients. We should not forget about postpartum. I think once the delivery has happened, it is very common that both the doctors and the family kind of forget about the mother. The first 24 to 48 hours are really very, very critical because a lot of hemodynamic changes happen at this time. And therefore, for the first 1 or 2 days, even after a normal vaginal delivery, it would be best to manage them in a sort of a intensive care unit where a monitoring is available. We must avoid volume depletion, hypertension. If there has been some bleeding happening, we should probably replace it with blood. Early embolation with support stockings is what is required. Breastfeeding, not recommended if the patient is class 3 or 4. The reason being that oxytocin released during feeding could lead on to hypotension and again more hypoxemia by right to left shunting. Best time to discuss and arrange contraception because they are very, very motivated at this time, and a very early or about a week's follow-up after discharge. The next question is, should the patient be operated since she's significantly blue and she's already 20 weeks pregnant? Not a good idea because the maternal mortality and fetal loss are higher because of cardiopulmonary bypass if one operates during pregnancy. I think surgery or repair should be only reserved for those who are very symptomatic. And if they are less than 16 weeks of gestation, it's better to go in for termination and then an intracardiac repair can be done. But if they are more than 16 weeks or so, then repair can be considered. But again, one has to go for the second trimester rather than first trimester for intracardiac repair. But one should really reserve it for very symptomatic cases. So finally, how will I manage this patient? I think if I was lucky and if she was lucky that I had seen her before she was pregnant, I would really assess her maternal risk in terms of saturation, in terms of ventricular functions, in terms of hemoglobin, and I would think that she should go for surgery and a full repair even before she gets pregnant, more so if she's severely symptomatic. But then very often, as I said, we are in a situation where they're already pregnant. One should try and stratify for risk using the various risk scores. Generally, it is said that the pink tetralogy, it's a pink tetralogy of saturation being more than 90%, the ventricular function being normal, NYHA class 1 or so, and the hemoglobin not very high. Perhaps this is a relatively lesser risk. I wouldn't say low risk, I would say moderate risk. Such patients should be closely followed, and again, they must deliver at an expert center only, even if they're doing well. High-risk patients with significant cyanosis, saturations less than 85%, high or advanced NYHA class, ventricular dysfunction, hematocrit also high. I think these are patients where you are likely to see a lot of events in the mother as well as in the fetus. If they come early, we advise termination. If they don't, then close follow-up by a multidisciplinary pregnant heart team should be done. And again, delivery should be at an expert center with the whole team being there. And these are the patients who require frequent antenatal monitoring, frequent oxygen monitoring, beta blockers to continue, monitor for fetal growth, compression stockings, preferably vaginal delivery, good hydration and good volume status to be maintained all through, avoid any air getting into the system, endocarditis prophylaxis. Don't forget the first 1 or 2 days after delivery because that can be a very critical, crucial period, and advise them contraception at the same time. Thank you very much for your attention. I think mother's safety has to be kept above the fetal safety.
Thank you, Dr. Anita Saxena, for your very excellent talk. And you have made a complicated topic in a simplified manner with such a clarity and very basic thing which you have explained well. I want to ask Dr. Anita Saxena that even if it is 20 weeks of pregnancy and during the anomaly scans when you do during this studies, if you find any abnormality in the fetus, there is any abnormal, like any congenital defect, can it be terminated?
So 20
which is rather to have an abnormal congenital baby, it is better to abort. Even 20 weeks also you can do, right?
Yes, 20 weeks is the upper limit as of now. So surely termination can be done, but that termination will be more for fetal indication. That won't be an indication for the mother because mother is 85% saturated. I wouldn't advise her for termination. But yes, for fetal indication, like in any other mother, even one who doesn't have tetralogy, definitely it can be done.
Thank you, Anita. That was a very lucid and a very masterly presentation. You comprehensively you explained how a patient has to be treated. My question is: suppose that she had undergone surgery and post-surgical infantibilectomy, there is RBBB and the BT has occurred. How will you manage with the pregnancy?
Yes, that's what I was saying, that even if those who have undergone tetralogy surgery, they're not really, sort of immune from the complications. And that is where if you look at their risk of arrhythmias, for example, it's much more. Arrhythmias and heart failure are much more in those who've had surgery done even during, early childhood. So I would just be watching them. And as I said, that if they're doing well all through the pregnancy, yes, they can deliver at a local hospital, but I think their antenatal care has to be important. And I would be not very concerned if they've gone through, say, 32 weeks of gestation or so, because not much really, bad happens after that. So if they've been free of arrhythmias, if they've not had any blocks, I wouldn't worry much about them. Of course, close monitoring is what is required.
You rightly told that a patient has to be counseled even before they become pregnant. But unfortunately, I think Rupa Salvan will agree with me. A lady with achondroplasia with 178 gradient across aortic valve, we did the balloon dilatation full term. The same evening, she developed labor pain, cesarean section was done, and then she just vanished. And she came only next year when she became pregnant. So this is the way our patients are. So we have to be really careful with them.
Absolutely right. I mean, I have a girl who's like 18 or something. She had ASD severe PH, and then they kind of disappear. And then 2 years later, she's got married. She's pregnant, and she's already 22 weeks. And I just, didn't know what to do, what to say. I said, all right, this is what it is. And the mother and, the whole family, especially the maternal side, were so worried. But they said that nothing can be done. We had to get her married. And once she's married, she has to get pregnant. So unfortunately, that is what it is in India.
I must say that this happens outside. So the TAVI case I showed you, there was one patient who had a TAVI in a SAVR, and then she disappeared, and 1 year later she comes to the second. So they're discussing that the TAVR valve did well in pregnancy, didn't degenerate. And on advice, she's again disappeared. So they are migrants, and this migrant population with issues, they come and go, and everyone's seeing them actually.
Dr. Anita Saxena, you said that Eisenmenger is more dangerous than tetralogy of Fallot. Yes. So what do you do in a situation when the patient is Eisenmenger?
No, of course, if she comes before the termination time, I will definitely advise termination. If she's even below 20 weeks, I'll advise a termination. But again, the problem is that many of them come later. And then some of them, even if you advise termination, they don't undergo termination because the family is, there's so much pressure on the family. So we've had patients where despite our telling them no, they would just go on with pregnancy. And of course, we are left with no choice but to give them the best care we can. And we will be admitting them around 28 weeks or something, keep them in the hospital. Everybody's on their toes, trying to not miss any complication. After doing that also, I remember losing 1 or 2 patients at least in the postpartum period. Within a week of postpartum period, when everybody sort of relaxed, they die. So of course we've had majority of them have lived. I must not say that everybody dies, but I think even if 30% die, I think that's a absolutely preventable death.
So, ma'am, are anesthetists using
epidural?
epidural?
I suppose.
Sorry, I couldn't hear.
The dilatation of the PFO can be done as an emergency procedure. PFO.
No, we haven't done that. We haven't done that. I was talking more like an Eisenmenger, where you really don't require a PFO to be done. So Eisenmenger otherwise does very well for a long time. It's the pregnancy which just pushes them.
Dr. Anita, I have a question that now with the so much of advanced scientific technology, the interventions, so why this patient couldn't be done under some palliative intervention and then continue the pregnancy? Because that will definitely reduce, like infant, you can do balloon dilatation or pulmonary stenosis, some intervention.
Yeah, you mean tetralogy patients?
Yes, tetralogy.
Yeah, you can do that. Only thing is, you again the results of intervention tetralogy are not like balloon mitral valvotomy. You know, they're very unpredictable. So you may be able to open the valve a little bit. You may be able to open improve the saturation, but who knows? After 4 weeks, she's back to that saturation. So in tetralogy, it is okay to buy 2 or 3, 4 weeks. Like in infants, we do it all the time. But I'm not sure in an adult who has so much fibrosis in the infundibulum, your balloon is going to do much. And of course, putting a stent and everything is quite a task in these patients with unpredictable results.
Okay, fine.
I have tried balloon dilatation of the pulmonary valve because there was a pulmonary stenosis as well. But then the annulus is so small, even if you overdilate, it is very risky in these adult patients, because it can compress, if you oversize the balloon, it can compress the coronary arteries. So instead of doing good, you may do more harm. So it is a risky problem.
Ma'am, our anesthetists are using epidural for their procedures. What are your thoughts on that? Because
I have been
safe and you don't see so many volume shifts. Most of our very sick patients we've gone on like the Eisenmenger or the epidural and cesarean when needed, and they're quite okay on that.
Yeah, you are right. I think a lot of anesthetists and obstetricians are pretty comfortable with epidural anesthesia now. The only thing is the drugs that they use, they need to have a knowledge, because if there is a hypotension by any of the drugs, then there is a big problem. Because hypotension, see, as long as they're well balanced, everything is fine. But if they dip, then it's very difficult to bring them back. That is my worry. So if they have hypotension, then like any other patient, they don't come back. Sometimes they develop very, we've had patients where the cyanosis increased so much that they have to actually, quickly finish it off and come out. So everything is fine as long as their hemodynamics are maintained. But the moment there is an insult because of a drug or something, then they just deteriorate.
Have you used the nitric oxide when you on them?
For Eisenmengers. For Eisenmengers. Yeah. We always keep it handy.
Anita, because not only the hypertension, dehydration and anemia, these are the 3 things we forget to treat, and as a result there will be more complications. So we have to keep our mind open and treat the patient.
Sure. I have a patient of Eisenmenger who fortunately delivered very well, but she was in ICU for like 3 weeks. The pressures will just not pick up. Her pressure will be 80, 90. She's sitting and eating, but her pressures will just not pick up. And every day I'll be talking to the ICU team and, hoping that she'll come around. She did come around ultimately, but she took a very long time.
So, ma'am, you
So
mentioned...
in such patients, probably we can open up the PFO and put a device with the opening there,
Vijay,
and that could
in
be...
an Eisenmenger, doing a PFO doesn't help. They already have a big hole.
Just to improve your preload, I think that is the only resort that can be tried.
Sorry to interrupt from my side, madam. I guess we are running short of time. We are ready for the convocation from the main hall.
Okay.
This was one of the most lively sessions in terms of speakers as well as discussions, and we used almost every minute of time. We discussed till the last minute. Thank you so much, all the speakers, chairpersons, and expert panel. Thank you so much, and we'll be moving to the Sabarmati hall.
Thank you.
All the best for everybody.
Thank you.
I really enjoyed this session. And thank you, Dr. Josna also.
Thank you, madam.
Thank you.
Josna
I thank the coordinator of this, Narmada, have done it very well. Very well, madam.
Thank you.
With
Thank you
all
so
good
much,
audio
madam.
and good video.
Thank you so much, madam.
And thank you so much.
Thank you.
हद है, बस हिंदुस्तान की है, पर मैसेज फारसी में लिखा है, कैसे समझेंगे लोग?
फारसी में नहीं, हिंदी में लिखा है।
आपको समझ आ रहा है?
बिल्कुल समझ आ रहा है। कोरोना से जंग अभी जारी है, मास्क ठीक से पहनना सबकी
जिम्मेदारी है।
मास्क सही से पहने।
Mama! Hi!
How are you, my darling?
Okay, listen. You're not going to believe this. But we are fine. Are fine. We are fine. Hi, Mama!
Oh, my baby. How are you, my Raja?
We are fine. We are fine. And you know what? Past 2 weeks, we haven't ordered any outside food.
What? Is everyone dieting?
Yeah, right, Ma. What about you? Looking tired?
It's tough, darling. So many people need care. But I am a few. Okay, listen. I'll have to stay here longer. I don't think.
You're not coming home for the festival, no? It's okay, Ma. We'll celebrate when you return. Don't worry about us. Arey, Ma. We are fine. Promise. See?
Hi, Baba.
Hi.
Baba.
Chup, man. Okay, see this.
Australia.
What?
The shape of your dosa.
Very clever. And guess what? We have chutney also, and your little hero is in charge of the grated coconut.
He's what?
Hey, hero. See, Baba, I told you we'll be okay. Only home cooking. So listen, you want to see what Pappu's making for lunch and for dinner?
What?
Ready?
So, for lunch, we have Malabar parota and paneer. For dinner, we have wheat parota, paneer.
Ajit sir? Hello? Ajit sir?
कोरोना से जंग अभी जारी है, मास्क ठीक से पहनना सबकी
जिम्मे हद है, बस हिंदुस्तान की है, पर मैं
Mama! Hi!
How are you, my darling?
Okay, listen. You're not going to believe this. But we are fine. Are fine. We are fine. Hi, Mama.
Oh, my baby. How are you, my Raja?
We are fine. We are fine. And you know what? Past 2 weeks, we haven't ordered any outside food.
What? Is everyone dieting?
Yeah, right, ma'am. What about you? Looking tired?
It's tough, darling. So many people need care. But I am a few. Okay, listen. I'll have to stay here longer. I don't think.
You're not coming home for the festival, no? It's okay, ma. We'll celebrate when you return. Don't worry about us. Arey, ma. We are fine. Promise. See?
Hi, Baba.
Hi.
Baba.
Chup, man. Okay, see this.
Australia.
What?
The shape of your dosa.
Very clever. And guess what? We have chutney also, and your little hero is in charge of the grated coconut.
He's what?
Hey, hero. See, Baba, I told you we'll be okay. Only home cooking. So listen, you want to see what Pappu's making for lunch and for dinner?
What?
Ready?
So, for lunch, we have Malabar parota and paneer. For dinner, we have wheat parota, paneer and dahi.
Wow. I'm gone for 2 weeks and you guys have become master chefs.
Now?
I'll be home soon. As soon as I can.
Hey, Baba, don't worry about us. We're fine, yeah.
Ma'am, please thank Mr. Rao. He sent a whole bunch of this to us.
This is from you.
A little something to cheer all of you up, na?
Dr. Rao, you're needed in room number 24.
Hey, listen,
Go and make us all proud.
Bye, Mama. We are fine, Mama.
To the warriors who keep us safe every day, thank you for your sacrifice and love. ID, made with love.
हद है, बस हिंदुस्तान की है, पर मैसेज फारसी में लिखा है. कैसे समझेंगे लोग?
फारसी में नहीं, हिंदी में लिखा है.
आपको समझ आ रहा है?
बिल्कुल समझ आ रहा है. कोरोना से जंग अभी जारी है, मास्क ठीक से पहनना सबकी
जिम्मेदारी है.
मास्क सही से पहने.
Dr. Kumar, patient to Dr. Kumar. Dr. Kumar, patient to Dr. Kumar.
So in another 5 minutes, we will go to the next section. Dr. Jayaprakash and all the other speakers and faculty, in another 5 minutes, we will go live. All right? All of you, please stay logged in.
Hi, JP.
Hi, Ajit. How are you?
Rajan, how are you?
Hi, sir. Ajit, sir.
Very busy.
I saw you logged in a little earlier, and then you just.
Yeah, I went off some work. Yeah.
You're home or in the institution?
No, I'm in the hospital.
In another 5 minutes, we'll start, sir.
Yeah, sure. So, JP, is that your live background or is it?
No. It's a virtual background.
Okay.
We can go to the video settings and put a virtual background.
Right. Are we live, Natarajan?
Pardon, sir?
We are not live, no?
It's
Are
live.
we live?
The whole thing is
live with the audience?
No, not right now, not. Only when our session starts, we will become live. I will let you know when we become live.
Yeah, you should. Otherwise, we'll talk. And then...
The only problem of JP, the only problem of having a background is sometimes when you move your face, it gets distorted, like 3D mapping systems, no?
Yeah.
That,
Yeah. That happens.
Continuous sinusoid technology reset the bar in stent engineering. Outstanding conformability and flexibility allows excellent stent apposition and may allow vessels to better maintain their natural shape after treatment with the Resolute Onyx stent, even in extra-large vessels. In fact, independent modeling showed that the Resolute Onyx stent platform had better strut apposition and less vessel straightening compared with competitive stent platforms. Resolute Onyx DES, delivering outstanding stent apposition and conformability. Delivering what matters.
Sir, shall we start the session, sir?
Hello.
Sir, shall we start the session?
Yeah.
Okay. Hello. I'm Dr. Ghosh speaking.
We now move on to session number 46 in Narmada Hall on day 2. This is a 1-hour session, a potpourri, a collection of topics ranging from cardiac MR to PET imaging to myocardial bridging, coronary aneurysms, and self-expanding coronary stents. To chair this session, I have great pleasure in inviting Professor V.K. Ajit Kumar and Dr. Sukumar Ghosh. And also, I welcome our expert panel for this session, Dr. Aditya Batra. Over to the chairpersons to continue the proceedings.
Good evening, everybody. At the outset, I should say that the CSI has been doing a wonderful job in organizing this meeting, and it's so comfortable sitting in your station and then viewing all these. We have a very esteemed panel. We have Dr. Sukumar Ghosh and Dr. Ajay, who are my co-panelists, and we have an esteemed panel of moderators, Dr. George Koshi, Dr. Tarun Kumar Madan, and Dr. Aditya Batra. Now, the first talk of the session is on CMR in frequent ventricular ectopics in structurally normal heart by Dr. Jayaprakash. Over to you, Dr. Jayaprakash.
Okay. Discussions at the end of the entire talks. We have a full 20 minutes to discuss aspects out of the 5 presentations. So we'll have the discussion at the very end of all the 5 talks.
Okay. At the outset, I would like to thank the organizers for having invited me as a faculty for this wonderful CSI meeting. Now, I'll be talking on CMR, or cardiac magnetic resonance imaging, in frequent ventricular ectopics in structurally normal heart, so-called structurally normal heart as we call it. Now, the ventricular ectopics are probably one of the most common arrhythmias in clinical practice, and also the most misunderstood amongst the arrhythmias. And because they are misunderstood, quite often the patients not only get frightened by the diagnosis of ventricular arrhythmias, and they also get inappropriately treated also. We have to realize that premature ventricular contraction of the ventricular ectopics account for almost 90% of idiopathic ventricular arrhythmias. When we call ventricular arrhythmias as idiopathic in the absence of cardiac abnormalities on routine transthoracic echocardiography, with the ECG, baseline ECG being normal, except for having the ventricular ectopics. We call them ventricular ectopics as frequent if there are more than 1,000 PVCs, or ventricular ectopics, per 24 hours in a patient with structurally normal heart. Now, by and large, ventricular ectopics are more common in structural heart disease, and in patients with structural heart disease, they have a worse prognosis than in patients with structurally normal heart. Now, it is very important for us to understand when to call a person as having a structurally normal heart, because as you will see later, the whole prognosis of these patients depend on whether they have an absolute structural normal heart, which we can detect by CMR. Now, today, CMR has become a very powerful tool in our hands to identify subtle structural abnormalities, because we can do tissue characterization using various techniques, which I'll go to in the next slide. There are 3 different tissue characterization techniques which we can use. The first is the Myocardial Fat Imaging using the fast or turbo spin echo pulse sequences, or short time of inversion, triple inversion recovery, or stir pulse, or steady state free precision imaging. We have to realize that myocardial fat can even be present in normal hearts, but usually are present in patients with arrhythmogenic RV dysplasia or even myocardial infarction. The second tissue characterization technique using T2 weighted CMR is using a stir FSA pulse is the myocardial edema imaging. The most important amongst them is the third one, which is the late gadolinium enhancement imaging, or where gadolinium accumulates in the scarred and fibrotic myocardium and washes out very slowly. So we are able to pick out areas of fibrosis very clearly. In fact, it can pick up as small a tissue damage as much as 1 gram of myocardial tissue. Now, of this, the late gadolinium enhancement has gained the most importance. Depending on the type of gadolinium enhancement, we can group this into 2 groups. One is the ischemia type of gadolinium enhancement. The other one is the non-ischemic gadolinium enhancement. The ischemic gadolinium enhancement is usually transmural or subendocardial, while as the non-ischemic ones is mid-myocardial, which could be either in patches, it could be linear, or it could be spotty. Also, patients can have subepicardial hyperenhancement, especially in patients with sarcoidosis and myocarditis, Anderson-Fabry disease, and Chagas disease. A global endocardial hyperenhancement, especially the subendocardium, is seen in amyloidosis, systemic sclerosis, and in post-cardiac transplant patients. Some of the early studies which came out in the 90s looked at the abnormalities in patients with ventricular ectopics, which were supposedly from the ventricular outflow tract. They used the spin echo and the gradient echo techniques to identify abnormalities. This was a small study of about 19 patients and 10 controls, where they looked at patients with so-called LBBB morphology ectopics with the rightward axis indicating they were from the right ventricular outflow tract. And what they found was in approximately 84% of the cases, there were outpouchings in the anterolateral wall. And also they found that the diameter of the outflow tract was much bigger compared to the control group in these patients. So this was some of the early findings which came out in the 90s. Later, in the more recent times, they have again looked at the CMR in another small group of 46 patients with so-called idiopathic RV tachycardias and 16 normal controls, and found that there was absolutely no tissue abnormalities in patients with idiopathic RV tachycardia. And they suggested that this vast majority of patients with idiopathic RV arrhythmias have primary electrical disorders and they are not former first day of ARVC. Another study, which is quite large, in fact, using 396 patients, looked at patients with left bundle branch block morphology, ventricular premature ectopics, and looked at the number of abnormalities, whether the patient had no RV abnormality, a single RV abnormality, or more than two RV abnormalities, which included, wall motion abnormalities, like this, or epicardial fat involvement, just like this. And they found out that in those patients who had no wall motion abnormality, which formed a significant subgroup of almost 270 patients, that's about 70% of the patients, they had a good prognosis compared to those patients who had more than two abnormalities, indicating that those patients with abnormal CMR with left bundle branch block morphology have a poorer prognosis. Now, this is another large study which looked at the substrate for ventricular arrhythmias in so-called structurally normal heart. They looked at a very large number of patients. This is a single center prospective study which looked at a large number of 946 patients with ventricular arrhythmias and so-called normal echocardiography. And what they found was that in a significant proportion of cases, almost a quarter of the patients had some form of abnormality. Depending on the severity of ventricular arrhythmias, there was an increasing amount of patients who had myocarditis. So if they had sustained VT or sudden cardiac arrest, nearly 50% would have had suggestions on CMR of myocarditis. And this is one of the echoes compared to the MRI on the right panel. You can see on echo, there is absolutely no abnormality which is seen and the LV function is near normal. But when one looks at the same patient using an MR, you can see subendocardial enhancement indicating healed myocarditis. And the most common structural heart disease which was seen in this study was either myocarditis or an early form of dilated cardiomyopathy or arrhythmogenic RV dysplasia, though there was a small incidence of coronary artery disease too. Another common problem which we are finding these days is cardiac sarcoidosis, and all of us who have been practicing electrophysiology have been seeing this, and many a times in the initial days, we used to mistake this for idiopathic VTs and we would have taken them for a cardiac ablation, ablation of ventricular arrhythmias. This is a large study with about 321 biopsy-proven sarcoidosis who had normal echocardiogram and underwent a CMR. And in this group of patients, almost 30% of the patients were diagnosed to have cardiac sarcoidosis based on the CMR, so indicating that echocardiography had a very limited overall diagnostic value in screening these sort of patients. And the most important screening tool nowadays, which we use as an initial tool, especially when we suspect cardiac sarcoidosis, is the cardiac magnetic resonance imaging. Now, is it different in patients who have idiopathic ventricular arrhythmias of left or right ventricular origin? is a question that we have asked ourselves. This was a magnetic resonance study in a large number of patients who had, approximately about 46 patients had left ventricular origin VPCs, while as about 74 patients had right ventricular origin VPCs. What was surprising was those patients who had right ventricular origin PVCs, there was only 5% who had abnormal LG or myocardial fat replacement, compared to those with left ventricular origin PVCs, where nearly 41% of the patients had some form of abnormality, which included LV, late gadolinium enhancement, or myocardial fatty replacement, or a biventricular myocardial fatty replacement, or LV edema and LVLG. What were the correlates? Now, this is one of the patients who, this is the MRI and the ECG of one of the patients who's a 40-year-old male, a fighter pilot with a family history of cardiomyopathy, who had normal LV function, who was supposedly having idiopathic ventricular ectopics of right bundle branch block morphology. And what you can see is you can see subepicardial fat replacement in these patients, along with myocardial fatty involvement in the epicardium. The correlates were age more than 40 years, a male sex, a family history of sudden cardiac death or cardiomyopathy, and surprisingly SVT, why we do not know in this study, and especially right bundle branch block superior axis VPCs had an increasing incidence of abnormal structural abnormality detected by CMR. So those patients who have right bundle branch block morphology VPCs should be evaluated with probably CMR in this group of patients. Another group of patients who have sort of structurally normal heart but have ventricular ectopics are a group of patients who have exercise-induced VPCs. This is a study which collected data from about 167 patients with exercise-induced VPCs with normal echocardiographic LV function and normal echocardiography. Now, a structural abnormality was noted in about 85% of the patients, of which 68% had mid-myocardial or subepicardial LG, 37% had myocardial edema, and 35% had pericardial enhancement, and 27% had pericardial thickening. And majority of these patients who presented with PVCs, which was exercise associated, had MRI consistent myocarditis or myopericarditis in this study. So finally, coming to how do we approach it? Should every patient undergo an MRI? A question somebody would ask. Now, when you have a patient with ventricular heart arrhythmias, rule out structural heart disease. The moment you do an echo and find an abnormal echo, then they go into specific management depending on the structural abnormality. If the transthoracic echo and especially exercise stress tests are normal, depending on whether you find reversible ischemia, they might require a coronary CT or invasive angiography. If they do not have anything, this workup is negative, they are apparently idiopathic ventricular arrhythmias. But now let us look at it much more closely. Suppose you have a patient with a long history of ventricular arrhythmias. Patient says for 20 years, 15 years, 20 years, I have been having ventricular ectopics. And if it's a female gender, a young patient, there is no family history of sudden cardiac death or cardiomyopathy, and has something which looks like an outflow tract PVCs and has a monomorphic PVC only, then these are likely to be low risk PVCs and low probability. And maybe in only a certain group of patients where the suspicion is extremely high, you might consider a CMR. However, in moderate risk group, if it's a male gender, age more than 40 years, there is a family history of sudden cardiac arrest or cardiomyopathy, or an aborted sudden cardiac death, exercise-induced VPCs, multiple morphologies of VPCs, a right bundle branch block morphology PVCs, then it is quite likely there is a high probability of a structural heart disease in these patients. And these are the patients who should probably be subjected to CMR. Because finally, once we find a structural heart disease, depending on the type of structural heart disease, we might have to treat these patients to reduce the mortality and morbidity. And if you have a completely negative workup, including a negative normal CMR, you can rest assured, you can tell the patient, look, you have a very low risk throughout your lifetime. But however, if you have an abnormality, you need to attend to this specific subgroup of patients depending on what you find on a CMR. In conclusion, chairpersons, ladies and gentlemen, a normal standard echocardiography may not suffice in patients presenting with ventricular arrhythmias and so-called a normal echo in most patients. CMR has a pivotal role in the management of these patients, especially in those patients with ventricular arrhythmias of uncertain origins. A combination of CMR findings with clinical characteristics may significantly improve our risk stratification, and CMR can complement echocardiography. And even if echocardiography shows some abnormality of the right heart or something else, you might need to consider a CMR to confirm the diagnosis and come to a clinical diagnosis. And CMR is a valuable tool to guide interventional treatment and potentially improves the long-term outcomes. Thank you all for a patient hearing.
Thank you, Dr. JP, for that, for clarifying that concept of the role of CMR in frequent VPCs. And I think it's an important area because you often find patients who come to you with VPCs, and the question comes as to whether you should be doing an MRI on these patients. I think we will address this question in the end. We'll go to the next talk. I think Dr. Sukumar Ghosh, I would request you to.
Okay, I appreciate the organizers. It's a very nice conference arranged.
Excuse me. Next is mine, because I have got another session in another annual conference, which head-to-head. Second is mine.
Sir,
the
next talk will be by Dr. Maghabatra only.
Yes, I am calling you. I advanced PET imaging of inflammation and infection infiltration. Dr. Mahapatra, please.
Yeah, I just would like to tell you that I may not be available till the things will be over, because I have got a head-to-head another 42nd annual conference. So if you can permit some questions,
it will be done, and pertinent one or two questions may be allowed after it finishing. Okay, just try to finish in time so that we can allow you time. Okay.
So I'll share the screen now. Okay. Good evening, ladies and gentlemen, and my colleagues. So this is the role of advanced PET imaging for inflammation, infection, and infiltration. So this is where I work, 7 News Hospital in Mumbai. Nuclear cardiology has made significant advances since 4 decades in the evaluation of left ventricular perfusion and function, as you all know. Advances in the cellular molecular biology of the cardiovascular system have helped to user in a new modality in nuclear cardiology that is called molecular imaging. So the molecule of the millennium, that is called fluorine 18 F18 FDG PET-CT, which is a very common, routinely used in day-to-day activities, in day-to-day cases in oncology, in cardiology, neurology. So has been an emerging as a promising diagnostic and therapeutic monitoring tool for cardiac inflammation, particularly a post-MI, infective endocarditis, implanted cardiac device, infiltrative cardiac disease such as sarcoidosis and amyloidosis, etc. So the aim and objectives of this thing is that to monitor the extent, severity, and temporal evaluation of the inflammatory response. Then second, to facilitate non-invasive assessment of novel therapies, to identify the appropriate patient and time for effective intervention, and also subsequent monitoring of the response of the treatment. So, cardiovascular inflammatory and infective processes are, which involve the myocardium, myocardial disease like sarcoidosis, amyloidosis, myocarditis. Then pericardial and epicardial disease, pericarditis and epicarditis. Vascular disease, big vessels, large vessels, atherosclerosis, vasculitis, Takayasu giant cell arteritis. But since the time is very short, I will limit my thing up to myocardial disease and some points on the giant cell arteritis, because the time is too short to cover everything. So, to start with, detection of cardiac inflammation following post-MI. You all know inflammation after a myocardial ischemia influences ventricular remodeling and repair, following either by atherosclerosis, long-standing, or plaque rupture in an acute event, which may lead to complete coronary occlusion, which leads to localized cell death, leading to a secretion of chemical signal, cytokine, the same way the COVID-19 virus attacks to initiate apoptosis and inflammatory cell recruitment. Effect in FDG assesses these leukocyte infiltrations to damage the myocardium, and uptake is there in the leukocyte infiltration. It binds to that and demonstrates localized inflammatory cell signal within the infarct territory. So this is one patient where you can see MRI cannot be confirmed, and here you can see the total infiltration of the leukocytes like a hotspot in the inferior wall of the ventricle. So large vessel arteritis, a 45-year-old man with a low-grade fever, night sweat and malaise. Nobody knows what is the diagnosis. Coronary axial PET-CT image demonstrated diffuse increased FDG uptake circumferentially along the wall of the thoracic and abdominal aorta, a finding suggestive of large vessel arteritis. So what we should do? PET-CT image obtained 6 months after corticosteroid therapy shows a substantial decrease in FDG uptake along the wall of the aorta, suggestive of treatment response. That means one can monitor the treatment response by PET studies to facilitate non-invasive assessment of novel therapies to identify the appropriate patient and time for effective intervention. So this is where you can see that arrow says there are uptake of FDG in the wall of the great vessel aorta, and also this is the descending aorta, lower one, and then after the treatment you can see everything is gone, so that you can monitor the treatment. So this is another patient of cardiac inflammation. PET-CT imaging demonstrated diffuse hypermetabolic activity in the LV myocardium. These findings are suggestive of inflammatory or infective myocarditis, the first left row. Then after the treatment for 6 months, there is complete reduction of the metabolic activity in the form of there is no FDG uptake. You can compare both the images, suggestive of remission of acute inflammatory or infective processing. So now the next is new promising role of effect in FDG PET-CT for the detection of septic embolism in patients with infectious endocarditis. As you all know, infectious endocarditis is a severe disease that is diagnosed using combination of clinical, microbiologic, and imaging criteria. Failure to identify metastatic complication, elsewhere, may lead to early interruption of therapy by the treating physician, thus triggering relapse and an unfavorable outcome. Sometimes infectious embolism can be asymptomatic to be recognized with the result of multiple imaging techniques, CT, MR, and ultrasonography. But the existing imaging techniques are time consuming, like CT, MR, and ultrasonography, cumbersome, unable to perform or survey the whole body in one sitting, one examination, to locate the metastatic involvements, and also to involve frequent transfer of acute ill patient, which is not practically possible by other imaging techniques. So, effect in FDG whole body imaging has a promising role in infectious disease because of high sensitivity, 100%, specificity 80%, positive predictive value is 100%. The possibility of scanning the whole body with a single injection and a single test and without high extra radiation to the other imaging modality like 7 millisievert, which is well within the safety norm. High anatomic precision and lack of toxicity, particularly appealing for clinicians, patients with infectious endocarditis. So this is one patient of infectious endocarditis. You can see the streptococcus uptake in the valve and in the tricuspid ring, as well as the device pump. Then you can see the red arrow is the device pump, the yellow arrow is the tricuspid ring, which shows the uptake of FDG. So this is another patient where you can see a 76-year-old man with a prosthetic aortic valve implanted 1 year back, got infected. You can see an increased uptake of the FDG. So cardiac sarcoidosis. Sarcoidosis is responsible for 30 to 80% of deaths from AV conduction block of ventricular arrhythmia or subsequent fibrotic scar. The value of FDG avid F18 PET studies for identifying cardiac sarcoidosis show comparable accuracy. Lange et al., they performed a retrospective study of 30 patients with a systemic sarcoidosis referred for FDG PET. They found that sensitivity and specificity of 85% and 80% respectively. Focal or focal on diffuse FDG uptake pattern is suggestive of active sarcoidosis. Concomitant use of either SPECT or PET perfusion tracer can help to exclude significant obstructive CAD. So this is a patient which I'm not going to detail. We did a resting perfusion scan and a FDG PET scan. Before that, he went for a lead gadolinium and enhanced of the MRI scan, and then you can see, and these are the protocols which we follow. You can see the perfusion image of the MRI scan. You can see here the lead gadolinium. You can see the white area or gray area is showing the scar. Then you can see also here the scar. Here we did a resting scan showing 56% ejection fraction, and there is a mild wall motion problem. So here you can see the first row is a resting perfusion scan. There is no perfusion defect. But in the second row, with effect in FDG, there is uptake. So that you can tell, look, there is a activity of the disease, but MRI scan cannot say that. So during the activity of the disease, then the steroid or anything can start, and you can repeat, and you can say that active disease is gone. So this is the case. Then this is another case where sarcoidosis, there is a perfusion defect, there is a metabolism uptake, and after pre-steroid therapy and post-steroid therapy, there is an improvement in the lower row of images. This is also another focal sarcoidosis, and you can also diagnose hilar lymphadenopathy with focal sarcoidosis. So PET imaging in cardiac amyloidosis. So this is a cardiac amyloidosis, a abnormal deposition of abnormal insoluble proteins, amyloid fibrils in the heart, which results in cardiac hypertrophy. Cardiac involvement seen with amyloidosis characterized by deposition of light chains. And there are two types, TTR amyloidosis and light chain, AL. So these two, we can differentiate which one the patient is suffering from as compared to MRI or any other echo or anything. So PET tracers, which you use F18, sodium chloride, C11, they can show significant diffuse uptake in ATTR. But PET tracer using F18 fluorobutaben, they diagnose and distinguish AL light chain from ATTR. Then the last point I want to tell you, the AL type of amyloidosis, which ATTR type of amyloidosis can be diagnosed by doing simply a bone scan. You must have heard of technetium 99 PIP bone scan, the SPECT scan, which you can see there is uptake on the heart. So these are the normal pattern of the MDP bone scan, and there are visual quantitative that is called Perugini score, grade 1, grade 2, grade 3, and Perugini score more than 2 carrying 100% specificity and 93% sensitivity to diagnose ATTR-CA. Bukhari et al. They showed technetium 99 bone seeking pyrophosphate imaging with a hard to control long life more than 1.5 detected ATTR-CA with 97% sensitivity and 100% specificity. This is you can see that the transthyretin type of amyloidosis showing uptake in the heart, and these are controlled at lung, and the ratio is more than 1.5. This patient, the ratio has 1.76, diagnostic of transthyretin amyloidosis. So concluding, no doubt, inflammatory processes of the cardiovascular system affect the myocardium, pericardium, and blood vessels. PET-CT or PET-MR hybrid imaging is a close to a one-stop shop approach when it comes to diagnose and localize focus of inflammation or infection and infiltration in the cardiovascular system. The diagnosis and management of inflammatory processes present a clinical challenge as there is a substantial overlap in the manifestation. When the patient presents with mimic like a acute myocardial infarction, but it came out to be inflammation. So it mimics. So there is no modality available to diagnose. Look, this patient is having an inflammatory process, is not acute myocardial infarction or any other things. So PET-CT, in contrast to other cardiac imaging studies, provides both anatomic and metabolic information to determine a primary or secondary cardiovascular process. It is a value-based imaging modality, not only for diagnosis, but also for monitoring the treatment response as well, which no other modality can do that. Thank you very much, and I would invite all our delegates, speakers, everybody in CSI to our 3rd World Congress on Clinical Cardiology and Cardiac Imaging, 16 to 18 April 2020 in Mumbai. If at all the corona things will be controlled, or we may shift, because we don't want to do online conferences. So this is a World Congress. Thank you very much for giving me the time. Thank you.
So thank you, Dr. Mahapatra, for a nice and excellent presentation and covering the subject for role at a hybrid imaging. It is coming in force for the detection of the disease and also monitoring of the treatment. Now, whether co-chairperson Dr. Ajay Chaurasi is present, I can hand over to him. Is he there? No. Then I ask next speaker, Dr. Vijay Chandra Reddy, for when to intervene in the myocardial breeze. Okay, you can carry on.
Good evening, everyone. Thank you, sir. And I hope my slides are visible and audibility is okay.
Okay,
Yeah.
visible and audible.
So mine is a straight, simple topic on when to intervene in myocardial bridging. We know about bridging. We see it on a daily basis. And of course, in the last 1 decade, some new concepts have emerged which help us in understanding when to treat this common, probably trivial looking problem. We all know that it happens in quite a number of them. Superficial bridges are quite common. Depending on how you do the angiogram or CT or autopsies, the incidence can be as high as 80%. It can be in any vessel, sometimes in the atrial muscle as well. But what we commonly encounter and ask this question when to intervene is in the LAD bridging. So let's focus on that area. Not all bridges are the same. If it is only a superficial 1 or 2 mm muscular bridge, it doesn't need any attention. In the deeper orientation, this is an important concept. If the depth of the muscle, the LAD tunneling is good, and if the bundle arises from the RV and crosses the LAD transversely and helically before terminating in the IVS. This, of course, this is a pathophysiological explanation, but you can see the deeper orientation bridges, sometimes they twist the artery and compromise the flow, resulting in ischemia. And of course, we can diagnose by angiography anatomically as well as by IVS. And we'll also discuss about the physiological significance, how to assess it. Cardiac CT, of course, can tell the amount of muscle over above the bridge segment. And characteristically, IVS shows the half moon sign. This is the lumen border of the vessel, the vessel actually. And then here on one side, you can see the muscle bridge seen as a echolucent area. And what IVS has shown us is this bridging is not confined to a systolic compression. The diastolic vessel diameter itself is reduced by about 1/3 to half in majority of the bridges. So bridging probably is not a pure systolic phenomenon. This is a very good concept which has been brought out by IVS. Half moon sign, of course, is one important point. So even though the coronaries fill mainly in diastole, especially in LAD, only 20% comes in systole, 80% in diastole. In RCA, of course, a lot of it can come in systole as well. But in LAD bridges, even though 20% is systolic flow, the fact that bridge can extend into the early diastole has important therapeutic implications. So how does bridging cause ischemia? Unless we understand this, we will not know how to when to intervene. So we all know that in systole, as the microcirculation in the LV gets compressed, the flow in epicardial coronary itself will not be much. So that's not a big issue. But then the diastolic flow, which is the predominant flow in LAD, can get impaired because of the bridge extending into diastole. Also, if there is an exercise or some tachycardia producing mechanism, the diastolic perfusion time is reduced, so that might uh, tackle that. Also, the prolongation of bridging into diastole causes flow inhibition of the early diastolic hyperemia. This is a very important concept I'll highlight now. The other is normally itself in diastole, when there is tachycardia or exercise, there is a subendocardial hyperemic delay. The subepicardium gets a good flow initially, but endocardium takes some more time to get the hyperemia, and in bridging, this might get amplified as well. And also sometimes the long bridges have serial stenosis effect, bridge segment can have spasm. And another important concept is there might be atherosclerosis proximal to the segment of bridging, and of course we will have to rule out this component before we think of when to intervene on the bridge. So we will focus our talk on the bridge induced ischemia in distal to the bridge segment in the apical or area of the LV, as well as the ischemia caused in the bridge segment in the septals which are subtended by the bridge segment. There are two different areas of ischemia. The concept we have to understand is in systole, of course, LAD flow is not much. The moment there is diastole, tremendous flow happens, and in tachycardia, in a normal person without bridge, early flow is there and then comes down gradually. Whereas in bridging, if you see here, in severe bridging, this increased diastolic flow is abruptly tapered off. It doesn't go up. It is decapitated. And then, of course, slowly it goes up. So there is a tremendous amount of diastolic underfilling as well with tachycardia in severe bridges. In moderate bridges, to a little extent. This is the concept I said about subendocardial hyperemia is delayed normally itself, and this is amplified in the cases of myocardial bridging. So this is another important concept I was telling about. If the bridging is quite severe and interferes with diastolic flow as well, the distal to the bridge segment, there might be ischemia, which can be brought out with tests, which we'll discuss now. But then there is a concept of a moderate or mild bridges causing something called a septal still. This has been very well recognized in dobutamine stress echo. So what happens is you see here a bigger bridge, systolic compression 67%, you find FFR is low. So distal ischemia is there, agreed. But here, the diameter narrowing is only 55. FFR is quite good, CFR is normal, there is no distal ischemia. But then, this moderate bridging causes some venturi effects here, and then all the septal flow is stolen here. So there is a septal ischemia due to venturi effects or depressurization. We also use the word transmural steal. The significance is the ischemia is amplified in this area of the septal perforators. So there are two different types of ischemia, and the treatment also should focus differently for these two subsets. So, and there is also a difference from the classical fixed anatomic defects of atherosclerosis, where we use the adenosine FFR and other tests. Here, this is a dynamic obstruction, a phasic obstruction seen in late systole to early diastole. And as you said, septal perforator ischemic segment also is important, and you cannot use adenosine or vasodilator stress. It has to be an exercise of dobutamine stress. That only will bring out the bridged issues. So dobutamine stress nuclear scan, a dobutamine stress echo, or a dobutamine flow indices, all three can be used to assess the significance. In dobutamine stress echo, the interesting thing is if you look at the septum in the area of the bridge segment, there will be a focal end systolic to early diastolic buckling, and apical area is spared. So this type of ischemia, you know that the bridge segment needs attention. There's no point in putting a bypass graft distal to the distal vessel, because the distal ischemia is not the issue. This is septal ischemia. And the flow indices, this is quite a useful thing. More of literature has come over into that. Don't use adenosine. And here there is an important concept to understand. We have to use non-hyperemic flow ratios. All of us are aware of FFR, DFR, IFRs. We'll discuss how these two differ here. So if you see the tracing here, the PD, the aortic, and the distal tracing. Yellow is the distal to the segment. So aortic pressure is here in the normal proximal LAD. And when you use a dobutamine stress, you can use atropine as well if the dobutamine is not giving the adequate rates and contractility. You find that in the bridge segment, there is a systolic overshoot actually. The systolic pressure is shot up. And then early diastolic rapid flow is cut off. So now diastolic flow has become very, very low. So this is what we have seen in the bridge segment. Systolic overshoot, and then diastolic gradients are maintained. So if you are using some test like an FFR, where the mean difference between the PDPA is chosen, these are neutralized, and you will find the FFR is normal, or even it might show a bigger value than normal. Whereas if you use a diastolic parameter, you can catch this significance of this ischemia in the diastole. So diastolic parameters only should be used. What happens distal to the bridge segment, you can see still again systolic overshoot, and diastolic is not that bad. So you will, if you find FFR, it might not show much variations, but DFR or RFR or IFR will pick it up quite easily. So this is a very important concept. So if you do a pressure wire and you are doing a pullback in the distal vessel, the DFR might be 0.88. As you're pulling it back in the bridge segment, it might drop to 0.74 and then come back proximally as normal. So you have to use the dobutamine. Once a rest DPR pullback you can do, IFR or whichever you are using. IFR, if you're using a Philips system, if you're using a Boston's, you can use a DPR, DFR. Abbott's, you can use an RFR. Even though RFR is a instantaneous one, it can measure even in systole, but because it is picking up an instantaneous maximum gradients, all three non-hyperemic flow ratios can pick up this issue. FFR will not be able to pick this up. So this is how we can choose to diagnose, when to intervene. Then of course, what to do once you find that the significant ischemia is there. Medication is the crux of the treatment. Beta blockers, nebuvolol supposed to have some additional advantage of relieving the spasm component in the mid segment or the bridge segment as well, because of endothelial issues. Non-dry hydropyridine calcium blockers, verapamil, diltiazem also might help. You are reducing the heart rate, prolonging the positive lucitropic effect. Relaxation is there. Some small studies on ivabradine for reducing rate, ranolazine for relaxation of the heart have been done, but predominantly the beta blockers are this. About the role of surgery, unroofing the muzzle. You just go in and then just unroof the tunnel LED there. So myotomy surgically by a minimally invasive surgery probably can help in some patients. In cases where there is a septal ischemia in that area of the bridge segment, probably this is the only therapy that might work. Even if there is a distal ischemia, this might work. You can also try some investigational approaches like with HOCM, where focused radiotherapy can be done to the muscle, but no one has done that yet. However, the common things we do for atherosclerotic disease like bypass surgery and stenting, do not seem to be very attractive in the light of understanding of the reasons why ischemia happens in myocardial bridging. If this is a local separated perforated ischemia, the septal still phenomenon, absolutely both of them will not do a job. Bypass, because the diastolic mid and distal late diastolic flow is so well maintained, even in bridging, graft closures are a problem there. Stenting, you know that the bridge segment is not a great segment where the diameters will not be much. There is a diastolic negative remodeling as well. Perforations have been reported in a bigger number than in other areas. High TLR, stent recoil, fractures, restenosis is high. And of course, nitrates we know are contraindicated in myocardial bridging. So we don't have a great role for intervention on this. So in fact, the first thing you should do when you see a bridging is to see whether symptoms are really ischemic or not. If it is ischemic, as documented by a dobutamine stress, nuclear scan or a stress echo or a dobutamine uh, diastolic flow ratios, then only we should think of intervention, and that also should be predominantly a medical intervention, and very, very rarely you should think of a surgical deroofing by a minimally invasive approach. Again, this gentleman, class 3, milking, step up, step down, classical type 1 looking LED, but incapacitating angina, tried everything. He was on atenolol before, then propranolol, then he has been trying all the medication. And if you see there, that classical dipping in, milking, classical deep myocardial bridge, if you see the distance there, and he was on nebuvolol, and then dramatically his symptoms disappeared within a month. We are not sure why, whether placebo effect or whether nebuvolol really was superior to other beta blockers he had received before, and he has now asymptomatic. So myocardial bridges, quite common, benign, and very rarely necessitate further testing or interventions. We know the therapies, and document ischemia before intervention. These are the three modalities you should use. Adenosine is of no use. Dobutamine you have to give along with maybe atropine if needed, and do the diastolic flow ratios, and then only decide whether you have to intervene or not. Thank you.
Dr. Reddy, for that wonderful talk on myocardial bridges. I think we will take questions in the end. Meanwhile, we'll go to the next talk, that is on coronary aneurysms treatment dilemmas by Dr. Kane. Over to you, Dr. Kane, please.
Can you hear me?
Yes, sir. You can share your screen, sir.
Yeah, I am.
Yeah, Dr. Kane, please.
Yeah. Can you see my screen?
No, sir. No, sir.
No, still not at this room.
It's coming as sound issue. Just 1 second. It's getting on, but it's getting, I don't know what's happening.
Sir, go to share screen, sir. The below share screen is.
I did that. But it just rotating and got stuck from there. Okay, is it come? Can we see it now?
No, sir.
Not yet.
Not yet, sir.
Do I share it then? I'm already on. I'll put it off and come again then. Then we shall we can you get ready, then we can go to the next talk and then come back to you in the next. I think so, but I don't know what is to be done. Yeah, okay. You can go ahead with the next talk. That would be better. Yeah. The next talk would be on self-expanding coronary stents by Dr. Jay Prakash VL. Is he ready? Is he ready? Yeah. Prakash. Yeah. Okay, sir. Can you see my screen? Yeah, we can.
Sir, we are seeing, sir. You're opening a presentation.
We can see your beautiful screen. Yes. Okay, good evening all. Respected chairs. Thank you, P.P. Mohan sir and the team for giving me the chance to be here. The topic which I am going to touch today is self-expanding coronary stents. What is the current data on self-expanding coronary stents? We all know the contemporary stents, that is a balloon expandable coronary stents, has got its own limitations. Basically, there is a suboptimal conformability. The vessel tapering cannot be adequately emulated. And one of the important things is stent stud malapposition. The issues with bifurcation lesions, stent sizing issues, vascular remodeling and stent under expansion, and also with the delivery of the drug. So all these problems can lead on to clinical consequences like acute, subacute, late, and very late stent thrombosis, restenosis. The polymer damage during the deployment on the abdominal surface can cause problems like inflammatory response, stent thrombosis, and restenosis. And one of the important problems with the balloon expandable stent is stent stud malapposition, which is seen in around 15 to 20% of the stented lesions. This can occur immediately or even months or even years after stent implantation due to vascular remodeling, and it can increase neointima formation due to restenosis as well as stent thrombosis. Stent fracture is another problem, especially when we do a high pressure post dilatation, and this may be undetected, leading on to problems of stent restenosis. Stent recoil due to the shrinkage of the stent platform is seen in around 5%. It also can predict restenosis. And we all know the issue of longitudinal compression of the, especially when the stent is short and we dilate. So all these are inherent problems of the balloon expandable stents. And so this self-expanding stent came and thought that it may obviate all these problems. Although it came in 1986, it was a stainless steel stent, and subsequently the nitinol stents came only, and with its memory of the shape and elasticity of the shape. The stents like Radius and Symbiote, basically they were used in SVG interventions initially. The self-expanding stents is thought to mitigate all the shortcomings which we had seen now, like a malapposition. It may facilitate the stud healing, optimal drug delivery. Stud position may be better, less incidence of no reflow and side branch occlusion, lower edge dissections, and thought to have better overall long-term performance. That is our theory concept. And these are the scenarios where this self-expanding coronary stents were tried, basically in acute SEMI, bifurcations, tapered lesions, aneurysms, SVG, large vessels like LM, and also ectatic vessels. These were tried. And let us see what is the scientific data on this and are these theoretical aspects in the clinical scenario. These are the self-expanding stent platforms which we have the access, the capilla side guard, the Cardiomyopathy Sparrow, Stendis group of stents, and luminal shield. And we have trials on most of these stents. The trials were access plus diverge and accent. Capella sidegun and cardiomyine sparrow has very limited data. Stendis has got the maximum data on this, like open 1 and 2 trials, supposition 1, 2, 3, 4, 5, LM Stendis, MECA setup and trunk trial, and some MEGA data on the luminal shield. Let us look something on the access stent and the data, clinical data. Access, although there are a lot of trials like access, access plus, diverge, and cobra, the only one large trial, most of the trials we can see that these are only small trials, single arm trials, safety efficacy trials. And the diverge is one single arm study, but having a 302 patients. And also we have other trials with the access stents, like, and let us see, there are other trials also. Let us see what are the things with the diverge trial. Diverge was a 9-month clinical angiographic and diverge study, which is a prospective evaluation of the axis, that is a drug-eluting axis in bifurcation lesions. 302 patients were there, and at 9 months, clinical evaluation, angiography by QC and diverge was done. And these were the MACE, that is overall MACE was 16% at 3 years, and with a low number of deaths, 10.1, and this diverge concluded that access bioluminescence eluting stent is safe, and the MACE rates was relatively low with 9.3 events at 1 year, 14 at 2 years, and stent thrombosis was relatively lower, 2.3%, and it was comparable to the balloon expandable stents. The Stendis group of stents has the maximum data. If you look, a lot of trials are there, whole of the apposition trials, open trial, and SVG there, some left main trials are there. And let us look into the major trials. I will look into apposition 2, which is having around 965, although it is a non-randomized registry. And I will be looking into the apposition 4 and the newer trial, which is the MICAS trial. Apposition 3 was it was a registry data, international registry, around 965 STEMI patients with the Stendis implanted, bare metal Stendis as well as paclitaxel eluting Stendis. The primary endpoint was MACE of composite of cardiac death, MI, and the target lesion revascularization, which was evaluated 12 months and 24 months of the randomization. These were the results. At 1 year as well as in 2 years, we can see the MACE rate, the target vessel MI rate, as well as the cardiac death rate was relatively low. And the apposition 3 concluded that the use of Stendis was feasible in STEMI, and long-term clinical events are relatively low. Apposition 4 was published in 2016. This also was in STEMI, and this was a trial design, 152 patients randomized in a 3:2 fashion to Stendis stent versus Medtronic Resolute. And at 4 months and 9 months, they had done the QCA and OCT. And the key endpoints evaluated were the percentage of malapose and uncovered studs by OCT at 4 months and 9 months of follow-up. The results showed that at 4 months, there was a significantly lower malapose stent studs in the Stendis cohort. And these were the pictures, the Resolute showing malapose stent studs at 4 months, whereas Stendis, there was no malapose stent studs seen. Also at 9 months, it has shown that the mean lumen area was higher in the Stendis group. MICAS came subsequently, one of the later published trial, which was in saphenous vein graft intervention. We all know the problems of SVG intervention, debris, the degeneration, the problems with stent sizing, high risk of embolization, the risk of graft rupture, stent underexpansion, and so on. And the MICAS trial, it was a single-center retrospective study. Around 118 patients were there, and 101 was randomized to 50 for the self-expanding coronary stents, and second-generation deaths in the 51 group. We can see at 30 days, the MACE was significantly lower in the group A, that is a self-expanding sirolimus eluting stent group. Whereas at 1 year, although the MACE was not different, we can see the cardiac death, the MI, target lesion revascularization, and MI were significantly lower. So MICAS concluded that the intervention of a degenerated saphenous vein graft had a significantly lower MACE rate and a significantly lower restenosis and target lesion revascularization at 12 months, and lesser incidence of myocardial infarction. But the trial had a limitation of a non-randomized trial, single-center analysis, and it was retrospective. So where are we on this data? We can see that although there are some trials on this self-expanding coronary stents, most of the clinical trials were feasibility and safety trials, single-arm trials with a limited number of patients, and it carried out in a selected group of patients like acute semi-bifurcation lesions, SVG. And none of the trials were a real randomized trial with adequately powered to address the clinical outcomes. But it has been shown that these stent platforms are at least safe and as effective as the bare metal stents. And trials have shown encouraging results and showed that the proof of the concept. Now, what is the future of this? The device improvement, especially we need a smaller profile of the device for a good navigation. Visibility should be improved. Longer devices are not there now, which has to be there. The start profile and has to be reduced. And one of the new things which has come is the exposition stent, which I had shown here, which is a stent. It's a hybrid design where there is a balloon plus a self-expandable stent. This also a stent is family of stent. The stent is mounted on a semi-compliant balloon restrained by a splittable sheath, and the balloon inflation split the sheath and releases the self-opposing stent. A low pressure initial dilatation will split the sheath, and then we can deploy the stent. It can be better positioned, and one of the problems of lack of a correct positioning of the self-expanding stent can be obviated. We need more trials on this, and the cultural acceptance also by the interventional community is needed in this self-expanding stent. Thank you for the kind listening.
Okay, thank you, Dr. Jai Prakash. As we are running late and short of time, without wasting any time, I could ask the previous speaker. Okay, coronary aneurysm treatment dilemmas. Dr. Kane, you are ready now? Hello?
Yes. Yes, can you hear me?
Okay.
Can you see my screen now?
No, yes.
Huh?
Yes. Yes,
Sir,
yes.
able to see
visible
your
and audible.
slides, sir.
You can start now.
It is audible also, so I can start.
Okay.
Yes, you can. You put on that. Yes.
Yeah. Sure.
Yeah, exactly.
Okay. Thank you, chairpersons, for your kind consideration. My topic is dilemmas in managing coronary aneurysm. Oh, goodness, what is happening? Oh, sorry. Yeah. So aneurysmal dilatation of coronary arteries. We confuse always coronary aneurysm from coronary ectasia definition. But coronary aneurysms are generally localized comparatively as compared to ectasia, which is generalized or longer length. And you have secular or fusiform aneurysms. And when the aneurysms are large, there are different definitions of giant aneurysms. More than 8 millimeters, some consider a giant, but more than 4 times the normal size also is considered a giant. So these are the definitions differ from study to study. And how do these generally present? They may either be absolutely asymptomatic, patient may have no symptoms whatsoever and detected incidentally, or there may be exertional symptoms like coronary artery disease, or the patient can present with acute coronary syndrome because of in situ thrombosis, distal embolization, or sometimes there can be catastrophic rupture. So you can have a acute rupture. I'm going to show you a few scenarios. Now, scenario number 1, 59-year-old patients with anterior wall MI. Just go from left to right. The first angio is of acute MI patient taken for PAMI. You can see that the LAD is completely blocked and there's a huge aneurysm of the left main and there is a thrombus there. Now, when you take for PAMI, the person, obviously this is taken from the literature, but it highlights so many points. So the operator tried to search for the LAD to cross the LAD, could not find the LAD ostium at all. They used IVUS from the circumflex, which we generally use when you have a ostial occlusion, could not find the LAD because there's a huge aneurysm. IVUS could not show them. Patient was stable, so they took for a CT scan and identified the LAD origin and subsequently recanalized the LAD with difficulty and with 2B3A inhibitors and all, only to find that within few hours the patient again presented with circumflex occlusion because the thrombus has moved there. They opened the circumflex, again the patient started having better and then again deteriorated. Just to show you that with large aneurysms and massive thrombus, thrombolysis or anticoagulation becomes the right treatment and subsequently surgery as early as possible rather than trying all these things which were tried, and finally this patient had to go for surgery. So just to show you how these things can go. This is another patient, anterior wall MI again, very nice angioplasty done, nice result in here, the stent is there. Only 6 months down the line, patient has again chest pain of varied origin, varied the duration. You do an angio, you find pseudoaneurysms, which we have been seeing when we were using first generation DES. We saw quite a bit of this, and there are different reasons given. I'm not going to go into reasons. So when you find these pseudoaneurysms, the best treatment, the patient is symptomatic. So the best treatment for this, where there are no other branches involved, is a covered stent. And we have a number of covered stents that are available. So papyrus was used in this patient, and which gave a very good result. Just to show you that IVUS can show us the aneurysm very well in a reasonable sized artery, of course, because there is a problem of what how big you can analyze with an IVUS. But IVUS is better than OCT. But if the vessel size is of a normal like this LED size, what I have shown you here, maybe OCT becomes, because of its better resolution, can show you the aneurysms very well, the interiors, whether there is thrombus inside or not, which angiography cannot show you. So this becomes essential. Another scenario, massive aneurysm of the LAD, patient could not be given a covered stent because of whatever reasons for anticoagulation purpose and all. So one of the ways nowadays we deal with this type of situations where surgery also cannot be, is not indicated, is you can put a bare metal stent and then you put coils inside. So you can trap a microcatheter into the cavity along with the stent and then go on putting coils and occlude that. That has been done in this particular patient. So this is one of the ways of stent coiling occlusion of the aneurysm. And you can see here the chroma flow, which is going outside the into the aneurysm. Once you have coiled it, you can see here in number C down that the chroma flow is decreased. And after a few hours, you can see that the chroma flow is right inside the lumen, inside the stent, and nothing goes outside. So this is one of the ways of dealing with these scenarios. Luckily for us, this is another scenario where you have a massive aneurysm. You just can't do anything, as I showed you in the first case. And this patient, the operator was very smart, so he did a CT scan and sent the patient for surgery. And this is a surgical excision specimen of this. And surgery is the ideal treatment when you have massive aneurysms with a lot of thrombus inside, or an impending rupture, or an aneurysm which compromises the cavity like RA, RV, or pulmonary artery, and compresses on that. So surgery becomes the treatment of choice in such situation. Luckily for us, though I've shown you these scenarios, the most common scenario is an asymptomatic patient with an incidental finding of an aneurysm. So that's the best scenario. Pathogenesis wise, we know that there's weakening because of several reasons of the medial layer, and then there is protrusion. Atherosclerosis is a commonest cause. Kawasaki disease, various vasculitis can cause this, or sepsis, infective mycotic aneurysms is a common cause in our country, especially when we reuse equipment. We have seen few cases of the stent getting infected and causing aneurysms. So one has to be very careful when he reuses equipment. So that is one. It is clinical presentation. Incidental finding is the most common, luckily. Angina, acute coronary syndrome, arrhythmias, aneurysmal rupture, and organ dysfunction with compression like SVC syndrome, or RARV compression or PA compression can be seen when the aneurysms are massive. Sizes, as I said, small, moderate, or giant, you can say. And diagnosis, angiography sometimes is misleading. It cannot show you because of the clot formation inside. Pseudoaneurysms can mimic a true aneurysm. So multi-slice CT becomes the diagnostic investigation of choice, because it also helps you to find out the other structures around when planning out whether intervention will work or surgery would be the best thing for this particular patient. CMR has been done in Kawasaki disease. IVUS OCT are helpful. OCT gives you more clearer pictures as compared to IVUS. Uh, in circumstances in the vessels are sufficient size to be imaged by these modalities. Treatment wise, only few studies have been done to study the natural history. So we are not very sure how these things are to be rightfully managed. Warfarin, there are no studies to advise for or against, but whenever the clot burden is high or there are repeated embolic episodes and you cannot do surgery or cannot do an intervention, lifelong warfarin becomes one of the important choices in such a patient. So in non-urgent care patients, those whom aneurysms are found incidentally are asymptomatic, reassuring ECGs, negative cardiac enzymes, regular follow-up, maybe with CT sometimes would be nice. Patients who require urgent care, those with unstable symptoms and abnormal ECGs, rise in enzymes, both surgical or percutaneous methods of intervention have been described. And as I've shown you different scenarios right in the beginning, some places where surgery is helpful, some places where intervention is helpful, and some places where masterly inactivity could be the thing of choice. So difficult management decisions are compounded due to the presence of concomitant stenosis, diverse anatomical involvement, aneurysm of morphological differences, acute complications such as thrombosis, rupture, or dissection. And from a surgical perspective, the pertinent questions are whether a vessel should be ligated, whether aneurysm should be excised or plicated, and whether the thrombus should be removed. So there are a lot of issues which needs, and these things are not common. So every time you have a patient, you need to have a heart team discussion and make a decision which is best for the patient under that circumstances. So in short, just to show you a sort of a summary slide, you can have an asymptomatic patient to the right. So you have to assess the risk of rupture in those patients and risk of embolization, morphology, extent, and then risk factor modification, antiplatelets, consider anticoagulation if there is multivessel ectasia, and if necessary, sometimes an intervention or a surgical ligation may be considered. In patients who have a stable angina, again, you can do a functional assessment, and if they are symptomatic, amenable to PCI, you can either do, as I said, a covered stent when there is no branches involved, or you can do a stent-assisted coiling, as I showed you the case, or if it is not amenable for PCI, a surgical excision with or without CABG, depending upon the number of vessels involved. If there's an acute coronary syndrome, then associated stenosis is there. You go with either CABG or this or PCI. If there are no stenosis, then you go for risk factor modification and all the things which are done for asymptomatic patients. When there's a lot of thrombus and acute syndrome, use thrombolysis or 2B3 inhibitors with without anticoagulation becomes the primary treatment, followed by, depending upon the need, either CABG, angioplasty, or medical treatment. Thank you for your kind attention.
Thank you, Dr. Nare.
Chairpersons, we actually are 10 minutes behind schedule. So originally we intended to have a 20 minutes time for discussion, which will now be truncated to 10 minutes. Thank you.
Okay. Thank you, Dr. Nare, for that guidance. I think, I'm not sure if Dr. Jayaprakash is back. Dr. JP is back? No. So we don't
I am
have
back.
There. He has changed his dress. He is there.
Okay. So thank you all for that wonderful talks. I think we can go on to some aspects of the points discussed. I would like to ask Dr. JP. So when you get ventricular ectopics who comes to you for an radiofrequency ablation, is it routine for you to ask for an MRI? I've been looking at patients with MRI on who have ventricular ectopics, and what I've seen is that I don't really find much of them showing any kind of LG uptake or any structural abnormality on the MRI. However, when I find an odd axis coming up, if I find a left bundle morphology with an abnormal axis, with a superior axis, then yes, then those are the clues for me to do a MRI. Yeah, JP.
See, we have been doing routinely cardiac MRI because we have access to MRI, and now we have a number of patients in whom we have picked up ARVC, and most importantly, nowadays we are seeing a lot of cardiac sarcoidosis. In fact, we have almost about 40 patients who have only ventricular ectopics with very minor bundle branch blocks, normal LV function, who have we have picked up. And in fact, we are using a combination of PET and MRI nowadays, because we have just published it last time. I think we presented an abstract, I think in APHRS, that we're looking at a combination of PET and CMR, and we find that in some patients in whom even CMR is normal, we are picking up something in PET, which indicates that there is some sort of inflammation going on in this patient, especially in those patients who have a little atypical features, and especially in those patients who have right bundle sort of morphology sort of ectopics. We definitely are more in favor of doing an MRI.
If you think they are of the classical, right bundle left axis morphology, a fascicular ectopic, do you do them, or do you?
No, if it's a extremely narrow QRS complex like a fascicle, which you may not need it. But if you definitely have something which is quite broad and has got a superior axis, then you better be warned that you need to go ahead and look at it very closely.
Is Dr. Ghosh, please? Do we have any of the other panelists like Dr. George Kushi and other people there?
Other experts are there. Do you have make any comments or questions from the expert panel group? Are they present or not? I don't think.
Yes, sir.
Okay.
Sir,
Do
myself.
you have just make any? Do you have any comments or question? You can do it.
Dr. Mahapatra is not here, but
So myself, Dr. Aditya Batra.
Ask him what is the routine indication for a PET. As a routine or as a specific indication, we do for all patients with suspected sarcoid. I think that is an important investigation, especially if you do a PET MR, which gives you a clue sarcoid, and I think that's an important investigation that needs to be done. I don't think we do it for endocarditis, but PET MR is certainly useful in sarcoid. So I have a question to Dr. Reddy. You said if you see, we are talking about situations where you find a stenotic lesion which is borderline. We are not talking about the run-of-the-mill bridge where you have in diastole it opens up completely. So if you have a borderline lesion in a bridge, then which of the FFR or IFR, which one would you recommend? You are muted, Dr. Reddy.
No, if you are talking of analyzing the significance of an intermediate anatomic fixed defect, atherosclerotic defect, proximal to a bridge segment, again, in the bridge segment, we are talking of bridge only. Bridge, first the FFR, no use. We have to use only a diastolic. So a DFR is ideal, and that too a DFR pullback. A DFR pullback after giving dobutamine. Start at 10, 15, 20 if heart rate is not going up, atropine 1 mg. And the DFR could be whichever choice you use. You use IFR or DPR or RFR. All three are valid. Any of these three companies. So you should do only that. FFR is of no use.
And you said you wouldn't like to stent these.
No, I think bridges should not be stented. Yes, it should not be stented. It doesn't solve the problem at all.
Okay. So there is a high restenotic rate? Is that the problem?
Restenosis and the pathology, actually pathophysiologically also, it is not the systolic narrowing which is the culprit. It is the venturi forces in the bridge segment. So putting a stent there is not going to solve the venturi forces effect because, and not only that, there is a disparity in size between proximal to the bridge and distal to the bridge, and wherever they have done the stents, the rate of restenosis is quite high. And ruptures, perforations during the procedure also are quite high because the negative remodeling, and it is not as thick a vessel wall as in the proximal atherosclerotic segments.
On the role of stents and bridges when surgeons, people don't really accept surgery straight away.
Yeah, probably in the rare case, as I said, the reason to intervene should be done with a stent, for example, should be done only after confirming the echocardiographically by dobutamine stress that the apical area is showing ischemia. It is not the bridge segment which is ischemic. Or also, you should show it by a DPR fullback that there is a definitive DPR which is low. Otherwise, don't intervene because it could be non-specific symptoms. And even in there are enough tremendous literature where people have put stents or bypasses and the symptoms continue to exist. So it could, in the first instance, be a non-ischemic pain as well. So we have to be very particularly sure about that aspect.
So, Dr. Reddy, may I put up my query?
Yes. Yes, please.
So let that be the last query in the discussion section, sir,
yes,
because
sir.
The next session is about to start.
So many a times what happens is you are treating a LED lesion and you are finding a distal normal landing zone in the bridge segment. So how to deal with this kind of a situation?
Yeah, that is a dilemma. Many a time we try to avoid, if there is a small landing zone 1 mm above the bridge, we like to do that. But as you rightly said, sometimes we'll be forced because there is no proper landing zone, and then we would end up there. And you find that the moment you do that, you find that the bridge segment starts behaving even more aggressively. That is some risk we will have to take when there is no other option available. And there's a classical.
So many times what we have
dilemma.
attempted is on table, we have given IV metoprolol to these patients, and sometimes these bridges they become milder. So we tend to put in a stent as less as possible within the bridge
Yes.
segments. Then we try to keep them on a chronic beta blockade therapy.
Exactly. Long-term beta blockade. Yes, that's the choice.
I think thank you all, because I think
Thank
we
you
are
all.
running short of time. I think thank you all the speakers and all the panelists. Thank you so much.
Thank you.
I thank all the chairpersons, the expert panel, and all the speakers for a very wonderful session that we had. Thank you very much. Thank you very much.
What happens? We become off. We have to go off from this thing, or we can continue
No,
to.
it'll automatically happen. When we move to the next, this will automatically go away.
Okay. Thank you.
Thank you
Bye.
very much. Thank you very much.
Thank you.
Thank you. Okay.
So we move on to the next session, which is session number 47 on interventions based on imaging. And I have a great pleasure in inviting Professor Baulayan, Dr. Ronnie Matthew, and Dr. Vijay Kumar to chair this session. And the experts for this session will be Dr. L. Sridhar, Prakash Chand, and Dr. Julian Johnny. So over to the chairpersons to proceed further.
Thank you, Dr. Natarajan. Can you hear me?
Very loud and clear, louder than usual.
Fantastic. So I think we are just waiting for Dr. Ziad Ali to come inside. He's apparently in and listening to us, but I think he has not been promoted as a faculty yet. So can the organizers do that?
You can swap if you want. You can swap if you want.
Dr. Ziad, are you in? No, I think Dr. Gary Mintz is in, but Dr. Ziad is not yet in. So,
Dr. Ziad is already in queue. He will be quickly promoted. Ronnie, just give a second.
Okay, so while you are promoting Dr. Ziad Ali, let me take this opportunity to thank CSI for having this wonderful session on imaging. And we have two giants in imaging. Yes, I can see Dr. Ziad in. Hi, Dr. Ziad. Good. So we have two giants in imaging on intravascular ultrasound and optical coherence tomography. At this point, I must show my immense gratitude to Dr. Ziad Ali, who at very short notice agreed to come and debate this issue on whether OCT or intravascular ultrasound is the way forward. So without wasting any time, let me invite Dr. Ziad Ali to give the first talk. Is OCT the way forward? Dr. Ziad Ali does not need any introduction to this august audience from India. He's from Columbia University and one of the leaders in the forefront of optical coherence tomography. So Dr. Ziad Ali, over to you.
Hi, good morning or good evening to you. Can everyone hear me okay?
Yes, we can hear you and see you well.
Fantastic. So hello, everyone. This is, it's a pleasure, really a pleasure to be able to talk about this. You know, I think the true legend here is definitely Gary. So I just want to pay tribute to him and where he's helped me get in this. But as a result, it's sort of master and trainee who are going to have a little friendly debate. So I think that'll be a lot of fun. So I'm here to tell you that OCT is the way forward, not necessarily that IVUS is the way backward, but that OCT is going to get us where we want to be more easily. Okay, so let's look at some of the differences between IVUS versus OCT. And displayed graphically on the left side are basically dots suggesting where one may be better than the other. And I think overall what you see is that there's a similar number of dots. So essentially, overall and globally, what IVUS can do, OCT can do, and vice versa. But there are some specific clinical advantages to IVUS and some specific advantages to OCT. So IVUS has extensive experience, the penetration depth is better, there's better clinical evidence, the established predictors of target vessel failure, and it's more durable. But my argument for that would be that, of course, it's older. And so as a result, you're much more likely to have clinical experience and clinical evidence and established predictors. OCT has a higher resolution. It's got better tissue characterization, detection of thrombus. It's also developing evidence, but the major advantage of OCT is that most of the process is automated, and it's going to become even more automated. Of course, the major disadvantages of OCT, which we know, are the additional use of contrast and the limited penetration of OCT. So I thought what we do is do something really fun here. So here's a patient with a diagnostic angiogram who ends up with a proximal vessel, chronic total occlusion, right? So this is just a very simple PCI where a fielder XT wire crosses the artery. And what I wanted to do for the purpose of this talk is actually, we're going to do both imaging on the same patient with all the same steps, all right? So OCT on the left and IVUS on the right, and off we go. And as you all know, we've been talking about this new algorithm, which incorporates for the most part, evidence for a benefit for intravascular imaging, not only for OCT, but also for IVUS. So we're going to look pre-PCI at the morphology, the length and the diameter, and post-PCI at medial dissection, apposition, and expansion by both modalities. So let's take a look at morphology. So this is the IVUS from this patient. And so what we can see is a triple layer appearance, and we can see there's blood speckle within the artery. And to the untrained eye, this grayscale might be difficult. We probably can see a little bit of fibrous plaque. We can see branches coming in. But what we're trying to do here is really do a real-time assessment. Oh, there may be some intramural hematoma at this place. We're trying to do a real-time assessment. And so the major issue with this is that we are constantly analyzing multiple frames on a single pullback in real time. And I feel like that might be slightly difficult. And if we just scroll through this IVUS, it's a very high quality IVUS image. But the limitation is that it requires a lot of real-time work. Now let's take a look at OCT. So OCT is going to automatically allow us to know where we are in the artery, both inside and out. This co-registration allows us to localize exactly the reference segments, both proximally and distally, and identify things that are critically important to us from an OCT or from an imaging point of view, especially for morphology. And that's predominantly the identification of calcification. And so here, if we just play this artery and scroll through quickly, what we're able to see is much more clearly what all of the lesion looks like. The same trilaminar appearance we could see earlier, we can see now. We can see the same area where the intramural hematoma has developed. And it's literally just a more crisp and clear image. And yes, indeed, there are some areas of penetration depth problem, but really those are the areas that we don't really need the penetration. I think what's also important here is we did run out of flush clearance, and we have to recognize one of the limitations of OCT. So let's take head to head, right on top of each other. What's more clear to you? One is a black and white grayscale. The other is a high resolution light attenuation image. And I would argue that they are similar, but the advantage in terms of the ability to detect specific structures really goes to OCT on the two left panels, but onto IVUS because we're able to see the EEL or the outside of the vessel on the right thrombus, although knowing how big the vessel is in this segment specifically may be of limited value. What about length? Well, how we do this by IVUS is we technically look at the longitudinal segments, which is much more difficult to determine what segments are normal. We then go ahead and take a look and see if these segments are normal on either side. And if they are, we determine whether or not to land our stent. Here at the distal reference, there's some disease. And what we want to do is to identify segments proximally and distally within the plaque burden with less than 50%, and then readjust our image. But all of this has to be done manually. And so that's the disadvantage. And here, we're going to see us doing this in real time. So by going through and going into the plaque and then going out of the vessel, what we can do is bookmark where we'd like to land our stents proximally, and then do the same thing proximally. So as we scroll through, we're going to get to the normal segment. And now there's disease here, but the advantage, of course, is that we're able to see the vessel wall. So we can size based on the external elastic lambda. So that's how we conduct the length by intravascular IVUS. And so what we're getting is a measurement of 37.57 millimeters. Let's do the same thing by OCT. The beauty of OCT, however, is that there's an automated measures. We don't need to use the longitudinal. And in fact, what you're looking at in the automated measures is a multiplanar reconstruction similar to a CT scan. So we know exactly where we need to land. We basically taken all 360 degrees of the artery and squashed them down and flattened them. So we know exactly where the fat parts of the artery are, just like an angiogram. And then if we look at this segment, we don't need to scroll because of the multiplanar reconstruction. And we can find the same areas of disease and make the same adjustments just a little bit easier. And if we go ahead and do this in real time, you'll see that what the OCT allows us to do is do this more quickly and efficiently by identifying normal zones based on these larger segments of the artery, where we're able to actually see by the multiplanar reconstruction that it is the largest part of the luminogram. And vice versa, we can do the same thing in the proximal. So what you're going to notice between these two is it's just a little bit faster and easier to do this. So that has an impact potentially on training. What about assessment of diameter? So when we do diameter assessments by IVUS, what we do is use our bookmarks and measure from the ELTL if possible. And so this is a real-time measurement of the ELTL. We try to do this in two different planes so that we can make sure that we don't have a problem with regards to the artery being an oval. And then we basically follow the same pathway in the proximal. And one of the nice things that we can do here specifically, and this is an advantage to IVUS, is we can measure the plaque burden. And when the plaque burden is very large, we need to understand that an aggressive stenting strategy by using EEL may lead to a dissection, in which case we may want to use a lumen-guided PCI approach instead. So that's our pre-PCI distal reference IVUS. That's our pre-PCI proximal reference IVUS, taking into account the plaque burden, and it's relatively straightforward. And so our PCI strategy by IVUS tells us we need a 3.25 by 38 drug-eluting stent. We're going to direct stent because there's very little calcium, and there's a 3.5 by 15 NC post-dilation balloon. What if we do this by OCT? So we do exactly the same thing by OCT. Now what's going to happen is things are going to become a little bit easier again. So we're going to go ahead and make our two reference vessel measurements. And by performing those reference vessel measurements, we know distally that we're at just about 3.3 millimeters by external elastic lamina. Now here, while we can't see the external elastic lamina because of the loss of depth of penetration, we also plan to use an IVUS-guided approach by lumen because we don't want to create a dissection. So essentially what we've done by OCT and IVUS here is exactly the same thing. And so by our IVUS approach and our OCT approach, we get exactly the same findings. Okay, so we go ahead and we put in our stent and we preemptively post-dilate based on the numbers that we have. And then we need to do our post-PCI assessment. And this is where it really gets easier to do things by OCT. Now, when we try to go to the edge of the stent here, first of all, we have to identify the edge and then peruse it manually. And now the grayscale is a little bit more difficult for the untrained eye. And same proximally, it's a little bit more difficult to identify where the stent struts are, especially in the setting of calcium, and this might make things slightly more difficult. And so what we can do is go ahead and scroll these two segments on either side and do the same thing on the other side, is scroll the proximal reference for dissection. And so there's a little bit of guesswork here. But here's the advantage to OCT. The stent is rendered for you automatically. You grab the edge where the stent is obviously going to have the dissection if there is one, and it takes milliseconds rather than seconds to be able to do this and identify everything because it's automated. And when we do apposition for IVUS, this is particularly difficult. And what we need to do is go through manually to look for a gap between the wall and the artery, which can be difficult, especially in the setting of calcification. And this requires a fair amount of careful degrees of assessment compared to this situation, where the OCT automatically shows us a white bar, shows us the rendered stent, and shows us that the stent is absolutely fully opposed. And what about expansion? So when we do expansion, the biggest problem with IVUS guidance is that we have to manually find the segment of the artery where the minimal lumen area is. And so what we do is go ahead and measure the distal reference because that's going to be our target. So you have to make this measurement correctly. And so once we've done that, This is the biggest issue with IVUS with post-procedural assessment. Exactly where the minimal lumen area is left to your discretion by your eye in an abnormally shaped vessel, and that makes it much more difficult. And what you're going to see here is where we end up making the measurement for the minimal stent area by IVUS and by OCT is in fact different. And it's different because the OCT automatically detects for us the minimal stent area, which is here at the end of the stent at 5.76 centimeters, 5.76 millimeters, compared to where we found an IVUS, which was basically just an abnormally shaped or asymmetric segment of stent. And so that's our final PCI. And what I want to highlight is both of these technologies give us the both almost identical answers. They both gave us the same treatment strategy. They both gave us the same steps. But because of the automation of OCT and the superior resolution, I would argue that the PCI guidance is easier by OCT, especially for the untrained eye. Nonetheless, we have to accept that in situations like chronic total occlusions, left main coronaries, osteal lesions, and advanced CKD, IVUS is a superior modality. So I will debate with Gary that there's going to be a paradigm shift with regards to how we use these two modalities. In that when OCT was originally the niche device for research for identifying macrophages, in fact, we're going the opposite way. And now IVUS will be used for more niche areas, while OCT guidance will be used for contemporary PCI guidance. So my key learning points is that IVUS is indeed utilitarian and OCT has superior resolution. Both overcome limitations of angiography. For non-CTO PCI, most IVUS have similar crossing profiles and distal catheter dead space. Both IVUS and OCT have advantages and disadvantages, but the specific clinical condition or lesion best suits which modality when. In general, OCT is superior for PCI guidance based on its improved resolution and automated software, and in general, IVUS is superior for specific clinical indications. Thank you very much.
Thank you. Thank you very much, Dr. Ziad, for this wonderful talk. Now, Professor Bahulen, can you invite Dr. Gary Mintz and introduce him?
He needs no intro.
Now, Dr. Bahulen, you're muted.
Muted, sir. Your mic is muted.
Yeah. Now, thanks, Dr. Roni, and it's a great pleasure to be with all of you for this exciting session of intracoronary imaging, and thanks to National CSI for this opportunity. Now, it's my great pleasure to invite Dr. Gary Mintz to say, what is the way forward? Is it the IVUS? Ziad has convincingly put that the way forward is the OCT. Yeah, somehow he has finally said that it is more or less equal, but he has put all his arguments vehement. So let us hear to Gary Mintz. And Gary Mintz does not know any introduction to this crowd. He had been to us with the last at least 4 times this year, especially after this sort of webinar have started. Dr. Gary Mintz, please.
Sure. Thank you very much. As you know, this was initially intended to be a debate with Jonathan Hill. But that said, I think you're going to find more similarity than difference between what Ziad said and what I am going to say. But I'm going to put forth the argument, or at least indicate the argument for IVUS as a continued important imaging modality. So it was commonly thought, and is still commonly thought, that IVUS and OCT measure differently. And based on the OPUS class study in particular, that the IVUS measurements are larger than OCT, and the OCT measurements are accurate, or more accurate. But more recently, when talking about high definition IVUS, which is quite frankly the only thing you should be using today, the measurements are almost identical. And in addition, in terms of the predictors of stent thrombosis and restenosis by IVUS and by OCT, they are the same. Number 1 is under expansion. Number 2 is what happens at the edges. Malapposition, quite frankly, has never been shown to have any impact on stent thrombosis or on restenosis. As a result, we have developed a universal intravascular imaging stent sizing algorithm that has been published twice just recently, and it is similar to what Ziad shared with you. But I also like to pay tribute to Bernard Fisher, who is the father of evidence-based medicine. He died about a year ago, and he famously said, "In God we trust, all others must have data." So here's the data. Randomized trials, meta-analyses, and registries, IVUS in white, OCT in blue, and both IVUS and OCT in yellow. And you can see that overwhelmingly the data shows that IVUS guidance improves patient outcomes, with really a paucity of data in the OCT world. Let's first talk about routine DS implantation. We have two large randomized trials of 1,400 patients each, showing that IVUS guidance halves the event rate at 1 year follow-up, and if you achieve IVUS optimal criteria for stenting, the event rate at 1 year is 1.5%. First, the IVUS XPL trial from Korea, and now we have 5-year follow-up data showing that these results are not only maintained at 5 years, but continue to improve from 1 to 5 years. And the same thing from China, the ultimate study showing almost identical numbers to IVUS XPL, both acutely in the first year, and they have 3-year follow-up data that was just presented at TCT. And I'll just share with you one meta-analysis of 10 randomized trials of IVUS versus angiographic guided stent DS implantation, showing that IVUS guidance reduces cardiac mortality, MI, TLR, and stent thrombosis conclusively. What about high-risk patients and challenging anatomy? Well, we showed now 25 years ago that angiography is significantly limited in its detection of calcification. You have all read about our work with a criteria for stent underexpansion by OCT, but we recently submitted and is preliminary and provisionally accepted a similar score for IVUS based upon the length of calcium more than 270 degrees, the presence of a calcified nodule, vessel size, and whether calcium is in fact perfectly circumferential. So here's a clinical example in the right coronary artery. You can see this focal lesion. The patient has chronic kidney disease on hemodialysis, and the length of calcium more than 270 degrees is certainly significant. There's a calcified nodule right here, and there's circumferential calcium right there. So based upon that, a stent was implanted, and you would expect stent under expansion, and in fact, stent expansion is only 45%, regardless of what it looks like angiographically. So just like we have a stent sizing algorithm that's universal for intravascular imaging, we have a calcium modification algorithm that encompasses both OCT and IVUS based on the criteria that I just shared with you. Left main disease. This is a consensus document that I wrote with the European Bifurcation Club about how you use IVUS for left main intervention. It is reliable in determining whether or not you should treat or defer. It's as good as physiology. You can look at plaque distribution from the left main into the LAD and the circumflex, which is consistent irrespective of the Medina classification, whether you have Medina 111 or 010. 60% of the time you have plaque in the distal left main that extends to both the LAD and the circumflex, 15% from the left main into the LAD with focal disease in the circumflex, and 15% of the time disease from left main into the LAD with no disease in the circumflex. For example, you see here Medina 110, but by IVUS pullback, you can see, particularly from direct pullback from the circumflex, you can see a huge plaque burden with some lumen compromise at the circumflex ostium. So why is this important? Because data from Korea indicates that when the lumen is less than 4 and the plaque burden is more than 50%, if you do single stent crossover, you are more likely to get jailing of the circumflex with an FFR less than 0.8. And if you do that, in a recent study also from Korea, the event rate is threefold higher at 5 years of follow-up. In terms of criteria for stent optimization, this is one study from Korea, the rule of 5, 6, 7, and 8 in terms of minimal stent areas. But recent data from Excel that's not yet been published suggests that we should aim for a left main stent area of 9, an LAD stent area of 7, and if you do a 2-stent technique, a circumflex stent area of 5. I don't know exactly where patients from India would fit into these two paradigms. Are they more like patients in the West, or are they more like patients in Korea? But this clearly suggests that there are patient population-specific differences in target minimal stent areas. And especially in Excel, we recognize the importance of acute stent deformation, which cannot be seen angiographically. And if you have acute stent deformation, the event rate at 3 years of follow-up is double. In terms of outcomes, there are only 2 randomized trials. This is a meta-analysis of the 11 published manuscripts on IVUS versus angiographic guided left main intervention, showing a reduction in all-cause mortality, cardiovascular mortality, stent thrombosis, MI, and TLR. And I always like to show this study from the UK. It's a nationwide registry from 2007 to 2014, showing a national reduction in mortality with IVUS guidance of 34%, with the greatest reduction in mortality in the interventionalists with the greatest left main PCI experience. Chronic total occlusions. This review article by Fred Galassi indicates all the various utility for IVUS-guided CTOs. Here's an example of an osteal LAD CTO, a nice ramus branch where you can park the IVUS catheter. You can see here the proximal fibrous cap of the LAD, allowing you to direct the guide wire appropriately. You want to end the stent in the true distal lumen and connect the true distal lumen to the true proximal lumen. This is a right coronary artery, reverse card. You can see true lumen distally, break in the vessel wall from here, here, false lumen, and now true lumen. And this is a case from India that was shared on one of the WhatsApp discussion groups. You can see the right coronary artery, again, a CTO, but this is an in-stent restenosis CTO. So we're intra-stent. Now the stent is here. The guide wire and the IVUS catheter are outside the stent. Now we're into the distal vessel where here's the distal right coronary, and now we're clearly in the false lumen. This is the true lumen here. So at this point, restenting is the wrong thing to do because you will end the stent in a false lumen and have no distal perfusion. In terms of outcomes data, whether by intention to treat or per protocol, there's either a 75% or 80% reduction in events in this randomized trial from Korea. Ziad mentioned renal insufficiency, and I must credit Ziad for this, what I consider to be an unbelievably important concept in PCI. So we've known for a long time that if a patient has chronic kidney disease and develops contrast-induced nephropathy, which is dependent on the amount of contrast that's used, their mortality at 1 year can be as high as 25%. Ziad has pioneered the idea of zero contrast PCI. Yes, you have to do a diagnostic angiogram using minimal contrast, and very often you send the patient home for a week and bring them back, and then the PCI itself is done with no contrast, totally contrast-free. If you don't use contrast, you don't get contrast nephropathy. If you don't get contrast nephropathy, yes, they may wind up on dialysis because they're underlying kidney disease, but you don't put them on dialysis. If you transition a patient from borderline renal insuffunction to being on dialysis, even if you fixed his coronaries, you have not done that patient a good service. I would argue that you've made his life much more miserable. Finally, in terms of myocardial infarction, the best data comes from Korea, an online registry of more than 10,000 STEMI patients with a reduction in patient-oriented and device-oriented cardiac events. patient-oriented events because of reduction in all-cause mortality, device-oriented cardiac events because of reduction in cardiac mortality compared to angiographic guidance. So as Ziad pointed out, there are more similarities than differences between IVUS and OCT, especially when you're talking about HD IVUS and especially for routine stent implantation. This is my reorienting Ziad's little chart, but again, it's almost the same information, just slightly reformatted. So to me, the question is not IVUS versus OCT. I don't like debates. I don't like this debate. I think it's meaningless. But the question is imaging versus angiographic guidance. To be honest, the volume of clinical data favors IVUS overwhelmingly. And at Columbia University in 2019, 78% of PCIs in the entire year were done with IVUS guidance and 10% with OCT guidance. So if you add that up, you're talking about almost 90% of PCIs at Columbia University Medical Center were done with imaging guidance, but the vast majority with IVUS guidance. That said, in 85% to 90% of PCIs, IVUS and OCT are interchangeable. Pick one and get good at it. Thank you for your attention.
Thank you, Gary. Excellent talk. Now we have a discussion, 6 minutes discussion. The first question I would like to ask to Gary is, left main, is a situation where, we have limitation because of the imaging required for large size. Many a time ostium has to be visualized, at least when the stent has to go to the ostium or if there is an osteal disease. Do you think that the IVUS may have a better role to image left main than OCT? That's one often asked question.
Right. So Ziad and I would agree that left main is one of the indications for IVUS over OCT. The exception would be a distal left main lesion where you don't have to cover the ostium. The problem is you don't know whether you have to cover the ostium until you image the ostium. And data from Korea says that if your osteal plaque burden is 50%, you should cover the ostium. And you can't figure that out until you have a good look at the ostium, which is nigh on impossible with OCT. So it's a combination of vessel size, but also being able to clear it. Now, some people say, okay, you put in a guideliner, you inject through the guideliner, da da da. I mean, to me, you're going through a rigmarole when you just have a much better technique with much better data.
Thank you. Dr. Ronnie, please.
You're muted, Ronnie.
Sir, Ronnie,
Yeah,
sir, your mic.
Thanks, Ziad. Right. No, my question is to Dr. Ziad. I mean, would I be right if I say right now that other than CTOs and ostial left mains, I think OCT probably is the image, is the way, is of choice to most of the cath labs because of the ease of use, because that's how at least I follow right now.
So, pardon my analogy, but to me, OCT is like a Tesla. It's got all the features, it's all the bells and whistles, but you kind of need to know how to drive it. And it's got some downsides, right? You can run out of battery. But IVUS is like a really nice pickup truck. It can get you anywhere. You can drive it through the mud. You can drive it through the snow. You can deliver your TV on it. You can pick up your whole family in it. So that's really how I think of it. If you have all the equipment and the conditions are correct, OCT is a superior modality because it's easier to make the steps in order to guide the PCI. However, IVUS is easier to perform because there's no flushing involved. You don't have to worry about the guide catheter. So if I had to summarize in one sentence, the ease of performance for IVUS facilitates users who are unfamiliar with imaging guidance. For those who are avid imaging users, the technology of OCT facilitates PCI more easily and readily.
And if I can jump in, do you know what the numbers are in terms of OCT versus IVUS? I mean, my sense is it's like, it's still overwhelmingly IVUS in the world.
Oh, by far. Right. So I've recently seen the SCAR data registry, which is was presented actually at EuroPCR and TCT. So the OCT use in terms of relative use, is increasing more rapidly than IVUS, although IVUS is also increasing overall. So globally, the imaging curve is going like this, but the OCT curve is more steep. And, that's partly because it's more often used on live cases. There's probably more public posturing with it. It's newer, it's cooler, all of those things. But overall, I would say, just like Gary said, HD IVUS is really good. And I'm going to go on record, and you're going to hear me say this on camera. If I could only buy one, I'd get HD IVUS. Because it does everything, right?
Right. I was going to ask this question to you because, in the Indian perspective, we get asked this question. There is a cath lab and they want to invest in one machine for imaging. And I'm going to ask both of you this question. I know Ziad did say this. 60 HD IVUS is expensive. Now, to the Indian audiences, what would both of you suggest and why? Dr. Gary?
Yeah, so it's an individual choice, and the person making that decision needs to do a little bit of homework. So the homework includes visiting a lab or multiple labs, seeing which one they like better, talking to the people locally, find out which companies are going to give them the best support, because without local support, you are on your own. And I can tell you, having visited India, that the support varies from state to state within India. And then pick one and get really good at it. But it's a personal decision. And I'd even tell the companies, okay, bring the machine into my lab, let me use it for a day with a clinical specialist, and I will make the decision based upon your support, who the person who's going to help me, and so on. In terms of cost, I don't know what the costs are in India, but in the US, Ziad, I think they're roughly equivalent today.
They're equal.
Yeah, Ziad, how would you answer this question?
So I would say this. If I had a cath lab with 1 or 2 rooms, and I could only buy one, I'll be a little bit more categorical and say that I would get HD IVUS. Because you're more likely to engage all of your physicians into one technology if they're not good at it versus 2, right? No. If you have too many choices, you don't know what to use when, and then you have an excuse, I don't know, let's just do angio. If you have one, it's at your disposal, and you get someone in your group, a tech, a nurse, someone who's invested to help you, and you do it in every case, you'll get very good at it very quickly.
Yeah.
And so in that regard, for a small cath lab that's doing routine work, I think that there's an advantage to IVUS because you can do the CKD, you can do the left main, you can do the CTO, you can do all that. But if you're in your lab, Ronnie, you need all the gear. And then if you're in Dr. Ajit's lab, you need all the gear because you're doing things that are cutting edge. Then I think OCT has the advantage because it's easier. The one other thing I would mention is if you have fellows who are training under you, I think now the trend is going to start to lie towards OCT because I would say, Gary, that it took me, I learned OCT first and it took me longer to learn IVUS. In fact, Gary probably remembers me emailing him 5 years ago and saying, Gary, why is it so dark behind this? It's lipidic. I should be able to see the wall. I can't. Why? But the OCT was a little bit more obvious. So that's how I sort of play the dichotomy.
Yeah, and let me just amplify something Ziad said. Every busy lab, maybe every lab should have a dedicated individual, non-physician, who is the imaging specialist. We did this 25 plus years ago in Washington. We took one of the cath lab techs who happened to have been an echo tech in the Navy. She became the IVUS tech, and she then taught the doctors. Then at Columbia, first it was Celia, now it's Kadi Fall. Both of them were unlicensed physicians. And Kadi is the expert. You go to Erasmus Medical Center and it's Jürgen Lithgow. He's the expert. They are your right hands. It's no different than if you're doing a PCI and the angioplasty tech whispers in your ear, you really should use a 3.0 stent, not a 3.5 stent, and you listen to them because they've seen as many cases as you have. Well, it's the same thing with imaging. They will do the setup, they'll make the measurements, they'll help with image interpretation, and they will then teach you and teach the other people in the lab. And of course, if you have multiple labs, you really should have everything.
I mean, so much so, Ronnie, that I would be as bold as to say, if you don't want to hire that person, don't buy the machine.
Wow. Great. Great points from both of you. And I think we've had a wonderful session. And I think the Indian audiences would love it. And we have a lot of take-home messages. Professor Bowland, would you like to end this or summarize it?
We had a wonderful discussion from both of us, and then we have a good comparative idea about both high definition IVUS as well as OCT and its practical way of looking at it. I think we will conclude the session and thank both Ziad and Gary for joining us and illuminating us with all the aspects of imaging, intracoronary imaging, and certain practical aspects. Thank you very much.
Thank you and goodbye.
Bye.
Thank you. Thank you very much, Dr. Ziad and Dr. Gary. Thank you.
Shall we move on to the next part of the session? Next is a lecture, Eye-Optico Trial and Light Lab Data. Ronnie Matthew, who's study. Ronnie, please.
Yeah, thank you, sir. Thank you. Can you see my slides, sir?
Yeah,
and
perfectly.
Can you hear me?
Yeah.
Right. Great. Thank you. And it's an honor for me to be presenting this Eye-Optico study to the National CSI. This was presented a month back at the TCT Connect, and this was one of the first and large multi-center prospective study on OCT from our country. This is my disclosure statement. Now, the objective of the Eye-Optico was to determine the impact of real-time OCT and angio co-registration on physician decision making for PCI optimization in South Asia. We were very fortunate to have 9 sites all over the country, including Bangladesh. They were all high volume sites, as you see here. Dr. Tejas Patel from Ahmedabad, Dr. Hiramat from Pune, Dr. Matthew Samuel from Mumbai, Dr. Balbir Singh from Delhi, Dr. Shengetwelu from Chennai, Dr. Viveka Kumar from Delhi, Professor Fazila Malik from Dhaka, and Dr. Shivakumar from Madurai. We further had the great opportunity of having a dedicated core lab, and my co-chair here, Dr. Vijay Kumar, was in charge and doing a great job analyzing all the CTs and optical coherence tomography. So the primary objective of this study was to assess the change in treatment strategy with OCT. If with OCT there was a further need for lesion preparation compared to angiogram, or if compared to angiogram, with OCT there was a change in the device landing zone and accordingly a change in the stent length or diameter or a change in stenting strategy. Similarly, post-PCI, the variables studied were whether OCT had identified a malapposition or a dissection or an underexpansion, plaque prolapse, which was not detected on angiogram. The secondary objectives were the success rates, the MACE at 6 months and 1 year, which is ongoing and which will not be presented now, and the cath lab metrics, primarily the additional time utilized and the additional contrast volume required. So we had a very interesting study flow, and this is all done real time in the cath lab. So based on the angiogram that was first done, the physician was asked to define a PCI strategy based on the variables that I just discussed with you. Now, once he formed this strategy, the OCT was done. And with the additional information from the OCT, whether there was a need for lesion preparation, whether there was a change in your landing zone, change in stent length or diameter, this strategy was documented. Then ACR was done. And then, based on the ACR data, if there was a need for further change in strategy, that was noted. Finally, based on this, the percutaneous coronary intervention was performed. Post PCI, again an OCT was done, and a need for PCI optimization was documented based on the findings of either malapposition, expansion, or dissection, as I did say. ACR was again performed, and a need for change in strategy again documented. Now, we enrolled 500 patients from November 18 to March 2020 from 9 sites across India and Bangladesh. 28 patients were excluded from the primary endpoint analysis due to inadequate imaging, and hence 472 patients have been included in this analysis as per protocol. 2 patients died. The follow-up at 6 months, 443 patients have been done. It's ongoing. And at 12 months, 245 patients have been done, and it's again ongoing. So this was the baseline characteristics of the patients done. If you look at the right panel, nearly 50% of patients had some form of recent acute coronary syndromes. And on the left panel, if you look at the risk factors, more than half of them had hypertension or diabetes. And you would think that this is a high-risk population, but this is sort of the snapshot of the patient population we get in our high-volume cath labs in our country. The lesion characteristics, similarly, if you look at the right panel, type B or type C lesion was seen in more than 85% of patients, and some form of calcification seen in nearly 50. So if you look at the results, on the left panel, there was a change in PCI strategy once OCT was performed after angiogram in nearly 76% of patients. And this change in decision was due to a further need for lesion preparation in 25%, a change in the intended stent length in 53%, stent diameter in 36%, a change in the landing zone in 61% of patients. Now, once ACR was done after OCT, if you look at the right panel, adding ACR further changed PCI decision strategy in 22% of patients, which included, as I said, a change in lesion preparation or a further need for lesion preparation in 15, a change in stent length in 10, a change in landing zone in about 16% of patients. Post PCI, OCT identified a problem in nearly 30% of patients which required some additional intervention. And this problem identified were under expansion in 15%, malapposition in 15%, edge dissection requiring further treatment in 3%, tissue prolapse in 7% of patients. Addition of ACR with OCT did not have any additional strategy change post PCI as expected. Coming to the secondary endpoints, if you look at the time for conduct of OCT and ACR, pre-procedure, the time required was an additional 6.6 minutes, post-procedure additionally 10.7 minutes. That was due to an additional OCT procedure that was required when we identified a problem in 30%. Looking at the contrast volume on the right panel, the additional contrast required was only 40 cc with OCT. The average contrast used was about 205 ml. So finally, if you look at the overall impact of OCT and ACR in this study, pre-procedure OCT on the left panel changed decision making in 86% of patients, and in post-procedure, if you look at the right panel, in 30% of patients. And overall, OCT and ACR changed angiographic based decision in 90% of our lesions in our study. So to conclude, this is the first South Asian study reporting the outcomes of OCT and ACR guided PCI in patients with coronary artery disease. OCT and ACR changed angiographic based decision in 90% of lesions, which included a pre-procedure OCT change of strategy in 76% of lesions, ACR additionally changing strategy in 22% of lesions, and post-procedure OCT identifying a problem that requires therapy in nearly 30% of patients. The 1-year clinical follow-up and data will be reported later. So before I conclude, I just wanted to share with you and compare these two studies that were presented this year at the TCT Connect. Both OCT, on the left panel was the iOptico that was done in our country, and the Light Labs that was done in the United States. If you look at this, two studies done in two different geographic locations, two different racially different people, and yet in both of them you had an 85 to 90% change in strategy with optical coherence tomography, which showed that wherever the situation, imaging or OCT, as in this case, does help us in addition to angiography. And I thank you all for your kind attention, and I thank all my co-investigators that made this study happen. Thank you very much.
Thank you, Ronnie. Right, brilliant work, and I think you deserve congratulations for coordinating such a wonderful study from our country. Now, we'll have some questions on that because the topics seems to be independent topics. In your study, you have a strategy change by OCT, which was probably expected one because IVAS has already shown that this was a change. Why the ACR, which is another additional thing with OCT, why it has not shown any significant strategy changes? That is one thing which requires some clarification.
See, ACR did show additional change in strategy in 22% of patients in this study, and I think it's a very good point that you did that you have pointed out. The disadvantage when we had only OCT was that you saw a good image, but if you wanted to correlate it to your angiogram, you had to see a side branch and correlate the distance of that lesion to the side branch. That's how we did on OCT. When ACR came, we didn't need to do that. So in like right coronary artery, it really helps because you really do not have many side branches for you to pinpoint where on the angiogram is the OCT that you are seeing. So I think when you added angio-co-registration, if you realize most of the changes that occurred was a change in the stent landing zone, especially in the Indian coronaries when we have diffuse disease, trying to land a stent into a non-lesion area or a lesion or an area which had less than 50% plaque is a challenge. And that's where ACR, I believe, would help more in our Indian subset.
That's probably right, because most of the things might have been corrected by the imaging itself rather than the precision of geographical location of the stenting. So I believe that probably in your clinical outcome may be reflecting some changes, some relationship with the ACR-based stent placement, because the stent edge problems are much less when you have used those ACR in your cases.
So Ronnie,
yes, sir.
I must compliment you on an exceptional study, very scientifically done, with a very specific purpose, and that's to be demonstrated. So compliments, congratulations, you put India on a good map and a good worldwide forum. But let's just analyze what you're saying. And I'm for imaging, but if you start analyzing it and you say 90%, you change your strategies, it almost makes people who do it without OCT feel as if they're doing everything was wrong compared to an angiogram. Now, the deficiency is, the critique here is that you have no control group. And therefore, if people hadn't acted on that OCT, you still can't prove the single important point that they would have done any worse or maybe any better. That's the first point I would like to bring up. Unless you actually had a criteria which was very well defined before, which said, this is when you change your strategy. If you had A, if you had B, if you had C, if you had D, so that the strategy in an open label study was not changed because everybody was in favor of doing an OCT and changing their strategy based on OCT. I hope you've understood what I'm saying. It builds in a bias from everybody to change their strategy. at 1 year, which is going to be the crux of the study, not the change in strategy.
Yeah, that's right.
Your
Right.
point is absolutely well taken, sir. And I think that's where the problem with optical coherence tomography has been, as we heard the previous two speakers also. The outcome part is the part that is yet to be defined very well. Whether all these that we have said with our data, that we did find all these changes, whether this translates into outcome or a decrease in MACE over a period of time, and in such a study needs randomization. Entirely agree with you.
Thank you.
Thank you, Ronnie. Is Dr. Vijay with us?
Yeah, Dr. Vijay Kumar is here. Vijay?
I have not seen him so far.
He's there.
Yeah,
Vijay?
I'm here, sir.
Vijay?
Yeah, I'm here, sir.
Yeah, please. Your comments.
And nothing to add, sir. I'm also part of the study, so it is nothing great to comment. But see,
It's a wonderful
initially we thought we do a randomized study, but to getting a number of like Illumian 4 to get 2,500 to start with, because we don't have much experience in doing imaging-based studies in our country. So that's why Abad decided to go ahead with a registry rather than it is just a preliminary this thing to run a big study in future. Maybe we might be running a calcium or bifurcation something in future. But a good thing is if you see the data, it's a very well collected data. So that is a very encouraging sign for us. So definitely you should be doing a good work in future. But it is actually a preliminary one, but it is a well done study.
Yeah, that's it. Comparable to any data from.
Absolutely.
Yes.
And you saw me clapping.
Vijay, continue with the session. Next session, Vijay.
Yes, I don't have this thing with me, sir. Brochure with me.
Okay, I think we will invite.
I think it's my talk.
Yes.
Yeah, it's your talk next is Dr.
His talk is going to be on imaging in calcified lesions. So please.
So let me share the screen. Oops. What's happened to my screen? Can I just get back and share the screen? Okay. Let me just see. So screen share. Give me a moment, please.
It's come, sir. It's come. You can just put up slides.
Okay, so is it clear now?
Yeah, sure.
I'm going to talk to you about imaging in calcified lesions, and I hope I can stick to time. Calcified lesions have been the nemesis of interventional cardiologists for times immemorial, since PCI started. And of course, it constitutes nearly 25 to 30% of our patients. The heavily calcified lesions clearly constitute 10% of our practice, especially as our patients are getting more and more complex, as the techniques have evolved to safety. We certainly have more sicker patients and more complex patients coming to us in lieu of surgery. And therefore, PCI of heavily calcified lesions is associated with high procedural complications. We have problems of stent delivery, we have dissections, we have perforations, we have underexpanded stents, which have adverse outcomes, both in immediate and long term. And of course, these are very challenging lesions. And many of these patients do go for surgical revascularization just because they have heavily calcified lesions. We also realize that this is the group which exists in terms of elderlies, in the ones with the diabetes, diffuse disease, chronic renal failures, previous bypass surgeries. All these have heavily calcified lesions. And this is the data on 1 year outcomes of heavily calcified lesions showing greater cardiac death, MI, target lesion revascularizations, and stent thrombosis rates over a 1 year follow-up period. Obviously, we now have newer dedicated tools for calcium modification. We have understood their use in plaque modification, and it is feasible. But to get the best outcomes, there is an increasing role for intravascular imaging because we need to define the lesion calcification far more accurately. We need to choose the modality of treatment amongst the 4 to 5 treatment options of plaque modification that we have, and we need to optimize the results of stent implantation, as you've just heard from the past speakers. And we have a number of detection tools as well as treatment tools. We know that we have coronary angiography, and by the way, coronary angiography is perhaps the least accurate and sensitive of the methodologies for detecting calcification. Of course, we have the non-invasive modality of CT, but then we have OCT and intravascular ultrasound, which we'll discuss, and we have a number of plaque modification tools related to atherectomy, laser, intravascular lithotripsy, which are introduced into the country in January of this year. And then, of course, we have the cutting and scoring balloons and the ultra-high pressure balloons. So how do we actually put this into perspective? Clearly, my technical considerations, my 10 commandments for calcified lesions gives a highlight to imaging for getting the optimal result. And only once you have imaged do you actually have the ability to implant a stent, because you know then the lesion will fully expand. So let's dwell on a bit on the intracoronary imaging, which exists in terms of OCT, intravascular ultrasound, and virtual histology. This is just to explain that coronary angiography is the least sensitive of all the tools, for detection, for localization, and for quantification. But where do the other intravascular technologies dwell? Those who have not seen these visuals, and I hope most have, this is the dense, heavy calcification, but it's superficial calcification, which is seen by intravascular ultrasound. But then with this calcification, nothing is seen behind the calcification. While OCT, this is histology, and look at how beautifully it demonstrates calcification, which is described out with a low intensity, but a well-circumscribed area. And therefore, this and virtual histology, of course, the fibrous tissue is dark green, the fibropathy is light green, and the necrotic core is red. And of course, dense calcification appears like white bone. Of course, you can describe concentric and eccentric calcification by both these methodologies fairly well. And that is well demonstrated by intravascular ultrasound versus OCT, as well as circumferential calcification. The napkin ring demonstrated a 360, nearly a 312, 320 degree arc demonstrated here by OCT. OCT gives good images of deep calcification, and I think that's perhaps it is an important aspect of analysis. Calcium nodules are much better seen on OCT, and of course, concentric calcification with the depth of calcification we've just discussed. When we start seeing the results of our tools, of our therapeutic tools, again, for us, OCT images thinning of plaque due to rotational atherectomy, cracks, fissures into the plaque as a result of intravascular lithotripsy, much better than intravascular ultrasound. And certainly for ambiguous lesions such as this, where filling defects were seen in the RCA thinking that they were thrombus, but when the balloon could not cross, an OCT was done to see that all this was nodular calcification all the way. It was rotational atherectomy, which was at the first phase, thought not to be done because of thrombus, actually resulted in burring of the nodular calcification and expansion of this vessel. And therefore, OCT predicts expansion. In lesions where you have eccentric calcification, however thick, you may create cracks and you may still create large lumens because the expansion is towards the normal vasculature. In eccentric calcification, you may have thin concentric calcification and still can crack this with high pressure balloons, leading to expansion of the stents. But if you have thick circumferential calcification, and we'll come to what we mean by thick, you actually, OCT is mandatory because it'll demonstrate a calcium which is not cracked, and implanting stents into this would certainly lead to underexpansion, and it's equally. So calcium fracture is predictive of expansion. And it's any calcium plate which is greater than 500 microns thick is resistant to fracture with balloons. I think this is to be well understood. And that is what predicts stent expansion. If there's no calcium fracture, you have lesser expansion of the stent. If there's calcium fracture, you have greater expansion of the stent. The stent expansion index is greater. And if you have no calcium fractures, you have a higher binary restenosis and target lesion revascularization. And that is what's translated into this retrospective analysis, which therefore is a rule of fives, which means that if you have circumferential calcification greater than 180 degrees, which is half the circumference, if you have thickness greater than 0.5 millimeters, and if you have length greater than 5 millimeters, you score this. And if you have actually all three of this, you have nearly an 80% chance of under expansion of the stent. And of course, if you have one of these, and this goes by the rules of scoring, you can actually have a 40% chances of under expansion. That is actually what reflects in this retrospective analysis, which demonstrates that you actually have a thickness here, which is less than 0.5. And even though you have a 360-degree arc of calcification, you have a good expansion. You can have a thick calcium, but only a 75-degree arc, and you have a good expansion. But if you have everything which is going bad for you, look at this. You hardly have any expansion of the stent, and it falls. When we compare for this, exactly for this reason, quantification by imaging is best done with OCT rather than IVUS. IVUS can actually demonstrate calcification, but it's very difficult to quantify calcification, and it's OCT which is better than IVUS. Therefore, this is what fits into our decision algorithm of treatment of calcified lesions early on. And I would say right at the outset, IVUS becomes, in a way, preferred option of, OCT becomes a preferred option of assessment of exactly what we were talking about in moderate to heavy calcification, in those where a balloon can actually cross, in those where an OCT can cross. It helps in decision making as to the choice of therapy, which is important. Just in terms, I don't see a clock out here, but I hope I'm in time. And Ronnie, you can tell me that if I'm not in time, and Dr. Berlian. But I'll just, this is exactly 3 minutes to end this session.
Yeah, sure.
You have 5 minutes more.
I have how many minutes more?
5 minutes.
Okay, good. So that's good. So this is the examples of what happens in our daily life. This is a case done at another center. The balloon did not open up the lesion. And I wish at this stage an imaging had been done for this case. Now, unfortunately, imaging was not done. The operator at that stage decided to implant a stent. In fact, actually what you don't see is implantation of 3 stents, proximal as well as distal. When the lesion still got missed, a 3rd stent was implanted here. So we have now 3 stents, but luckily at the site of the lesion, it's not 3 overlapping stents. And the lesion, of course, did not give way still. And the axiom is do not implant a stent till the lesion is fully dilated. And of course, imaging should have been performed. Well, there we are. This is, we left with, therefore, the final result. You can see that there's a residual stenosis which is left behind, inability to dilate this any further, 3 stents implanted in this vessel, and the patient was sent home. He did not have a stent thrombosis, which he would have, had a very high chance of having, but obviously did have restenosis, and by December, he was back with restenosis and intractable angina. He also has a circumflex lesion, as you can see here, which wasn't attempted at that time. It is calcified. And of course, what did the IVUS demonstrate? It demonstrated, firstly, proximally. The vessel is large, 4 millimeters, and you've got a stent floating around. The proximal of those 3 stents is just floating around. 2.5 millimeter stents were implanted, and one of them was underdilated. And what we see is concentric calcification. We have underexpanded stent. And we have a large vessel. We have a vessel which is close to 3.5, 3.75 millimeters. Of course, we now have 2 modalities. In fact, we have 3 modalities which can help underexpanded stents and circumferential calcification outside the stent. One is the ultra-high pressure balloon. We also have intravascular lithotripsy, which can actually crack the calcification outside the stent. And we have the laser now available with us as it has been approved. Well, in this case, the ultra-high pressure balloon is used at 45 atmospheres, and that opens up that lesion. And then, as I'd already seen that the ostium was 4 millimeters and above, a stent is implanted into the ostium and expanded to high pressures to give up what is now a large vessel, a 4 and a 3.5, which was initially thought to be a 2.5 millimeter vessel. Again, because of this, the imaging, and we have here a nicely expanded 9.6 square millimeters of an area in the of a stent area in just the area which had been underdilated. And you can see that we have large lumens throughout. I think this is the value, but then we go to the circumflex, and there's another value here. IVUS demonstrates that this is circumferential calcification again here. Luckily, we had obviously we would go in with the rotational atherectomy, do the circumferential calcification. A 1.5 burr I thought would do the job, but it did not. You can see that the balloon still doesn't, the lesion still doesn't dilate. And I can now see that it's not cracked at all. So what strategies do we have? We need to go to a bigger burr to actually create a crack in the calcium. We can do an intravascular lithotripsy to calculate, to fracture the calcium. And we went to a larger burr, followed by a dilatation with an OPN balloon, which we had from the other side, and the lesion gave way, and we actually got huge lumens on that circumflex, as you can see here. Now, we have to understand that combination technologies take us forward, imaging takes us forward, and we actually have to understand that how it can take us forward. So now that we have intravascular lithotripsy, which I introduced in the January of this year, it actually demonstrates that in this circumflex, the LAD I opened up, did IVL to the LAD. It opened it up beautifully, but I wish I had done imaging on that circumflex, because as I continued to do IVL on the circumflex, as you can see here, I had underdilatation at one point and the lesion did not break. I actually then went in, implanted a stent, and did an OPN ultra high pressure dilatation at 40 atmospheres to still find that there was some residual stenosis. And that's when I actually did the imaging. And look at here, what I'm trying to do is that there's a calcified nodule right at the bifurcation, which I'm trying to treat with ultra high pressure balloons. I was lucky that I didn't rupture the vessel. But I also find that despite my ultra high pressure balloon, I have an underexpansion, a fair degree of malapposition, which I then had to treat with a 4 millimeter balloon, but not at the site of the calcified nodule, more proximal to that. And that's when I got a good stent apposition. And that's the final result, as you can see. And you can see that area of calcified nodule just beyond the bifurcation. And finally, this is a case of a restenosis in stents. This stent is implanted elsewhere. This patient comes back with restenosis. I'm not sure where the stent is implanted because it's a whole calcified vessel right from top to bottom. We can't see the stents, and actually there was an underdilatation because the operator had okay, so I heard that. Well, I couldn't cross this vessel, so it was burred. And then this is what I noticed after an OCT analysis. If I don't run it through in the interest of time, numerous calcified nodules right here, circumferential calcification, underexpanded stent, and that was very visible on this OCT analysis. And therefore, further lithotripsy, followed by a lithotripsy all the way, followed by ultra high pressure balloon dilatations going up to 4.5 millimeter of OPN at 40 atmospheres. Remember, multiple underexpanded stents existed in this vessel, giving an expansion of the vessel with acceptable residual stenosis in a heavily calcified vessel to give him the best possible results. So I think I'll give you my last message, and that was the final result. These are very complex high-risk cases. I want to announce to you the CHIP CTO India 2021 on 16 January to 17 January 2021. And then just the message is heavily calcified lesions are the worst nemesis for an interventional cardiologist, as well as a patient for treatment and outcomes, and imaging is essential for optimization of heavily calcified lesions. OCT obviously has an advantage over IVUS in decision-making and optimization. And the combination of calcification modification modalities may be needed for the best final outcomes for our patients, must be image guided. Thank you very much for your attention.
Thanks, Ashok. Thanks for the excellent cases which you have shown. One quick question, do you routinely verify for calcium split with another run of imaging in all these cases?
That's a great question. I think we should do it more often. No, I don't. But you saw how I went in on the circumflex without verifying it after rotational atherectomy. I wouldn't do it so much after an IVL because you can see the balloon expansion on IVL. But certainly after rotational atherectomy, you may actually pass a 1.5 burr and do nothing to that. You may still have a calcification with no fractures and no cracks. I think that's where we should do it far more often than we do it in IVL. Yes. Fractures are indication of a better stent expansion in small studies.
That's it. Yeah. Ronnie, any questions or?
Yeah, sir, I think based on your experience right now, what would you think is the best way to treat a calcific nodule? Of course, on imaging, that's something that we often catch, a big calcific nodule? And what would you suggest?
So, Ronnie, we do not have any great tools at the moment for calcified nodules. The best we can actually have two. Firstly, if we have a guide wire bias, we would get that calcium. And we're going to analyze the guide wire biases and see if we can create those guide wire biases. For example, we may be rotablating down into the circumflex, but if we find that the calcified nodule is somewhere up in the left main, we may pass the wire into the LAD and try to get closer to the calcified nodule. The same goes for passing the wire into a large diagonal rather than LAD to catch a calcified nodule, create a guide wire bias. And the second is, once we have orbital atherectomy, we have a greater ability to catch the calcified nodule, which is not so easy for rotational atherectomy because of the larger burring diameter or larger ablative diameter of a ablation tool. And finally, I do some runs at slow speed at 130 RPMs per minute with rotational atherectomy. This Japanese study which tells us that you can actually get, say, vibration of the rotational atherectomy burr to create larger lumens than you can get with just a high-speed rotational atherectomy.
Thank you for that wonderful tip, and thanks for this incredibly good lecture on calcified lesions. I think we did learn a lot. Thank you, sir.
The most important is never go with the ultra-high pressure balloons on calcified nodules.
Absolutely. Yes, I think that point is well taken. Thank you very much, sir.
Thank you, Ronnie. Thank you. Great.
Now, Professor Bowland, can you invite Dr. Ajit? Yeah.
I think the next topic is
Ajit, Dr.
coronary imaging for vulnerable plaque is the jury out. Dr. Ajit Maleshwari. Ajit?
Just a minute. Yeah, okay.
You have to go to slide number 1, sir.
Sorry. Okay, can you see me and can you hear me?
Yeah, very well.
Okay, sorry, I just put up the last slide. Okay, so the question is coronary imaging for vulnerable plaque, is the jury out? And what we need to really look is what's the definition of vulnerable plaque. So you have a functional definition, which is a plaque which is often non-stenotic, which has a high likelihood of becoming disrupted and forming a thrombogenic factor on exposure to an acute risk. There's a histological definition, a plaque which contains a thin fibrous cap, lipid pools, and macrophage. And a prospective vulnerable plaque is a signature that has been proven in a prospective study to identify a plaque that is prone to disturb and can be recognized and measured in the cath lab. So we have discussed this before. There are 3 important causes of coronary thrombosis and acute coronary syndrome. One is rupture, where the plaque gives, the thin cap gives away, there's a cavity and then thrombus on that. Plaque erosion, there is no obvious cavity, just a giving away of the endothelium and thrombus formation and a calcific nodule. So this is a typical patient with a vulnerable plaque on OCT. At the type of the lesion, you can see large amount of lipid plaque and a thin cap fibroadenoma, which is basically TCFA, which is basically 65 microns or less. And these are the lesions which can rupture and create problems. And this is a patient in the right coronary who developed a ruptured plaque, and you can see the nice cavity and the ruptured plaque with a nice cavity here, which is creating the ACS. Typical ruptured plaque. This is a plaque erosion where you cannot see a cavity, but you can see thrombus with no disruption of the cap. So clearly, these are issues which we should know, which can cause a plaque to become vulnerable. And finally, there's a calcific spur, which can create another area which can give away and create thrombus. And these are the 3 common causes of ACS. So what is the impact of a vulnerable plaque? The impact of an early vulnerable plaque detection would be important so that it could be a major breakthrough in management of patients with coronary, peripheral vascular, and neurovascular lesions so that you can prevent the ACS story. Now, this can be determined by 2 ways. One is morphology of the plaque and activity. The activity is usually the plaque's warmth and its pressure. And morphology, we will go through. We saw what it can show. It can show a thin cap fibroadenoma, can create plaque burdens, and if the lumens are small, that they can rupture and create an ACS, creating vulnerability. Now, if you look at temperature, we have shown that thermal heterogeneity within the human atherosclerotic coronary artery is seen, and with a special thermography catheter, you can see up to 2.6 degrees centigrade increase in temperatures as you go towards unstable plaques and myocardial infarctions. And if you treat them with statins, the temperature comes down by about 1.2 degrees. So clearly a cause and effect, that there is a temperature rise, and if you treat them with statins, the vulnerability of the plaque comes down. We can also check the pressure, and this is by a specific catheter again, which is called as an intravascular elastogram or a palpogram, which can process the pressure at the level of the plaque and show that these are vulnerable. And finally, one of the important tools is virtual histology, where you characterize the lipid content of the plaque by color and show that if it's red, it's a lipid core. If it's fibrolipidic, it's yellow. If it's calcium, it's white. If it's fibrous, it's green. And the ones with yellow and the red are ones which can rupture. Now, the controversies of vulnerable plaque is this a plaque which is the issue, or it's the milieu which is the issue, or it's the patient which is the issue? And these three have to come together. It has to have a concrete combination of a plaque and which is vulnerable with a scenario which is clinical to create the vulnerability in the plaque. We always have plaques which rupture in coronaries, but they do not create ACS very often because of the natural processes of cleaning up. Now, the other issue is which plaques cause events. So we've seen that in a vulnerable arterial bed, there can be diffuse arterial vulnerability, and you can have multiple plaques many times which are vulnerable in the same bed. So it's not necessary that you have only one plaque. And in fact, in 80% of patients with ACS, there's more than one ruptured plaque in these lesions. So the next issue is that the milieu. So apart from the plaque, we have to look at the vulnerability of the milieu. And this could be related to either the lipid content, lipoprotein A, which is very important because it's one of the anti-thrombogenic pathways which can create problems in patients. Inflammation, diabetic patients, patients with other inflammations like COVID-19 can have high IL-6, HSCRP, and other acute phase reactants which can create problems in patients. Hypertriglyceridemia and diabetes, a typical metabolic issue, can create problems. Homocysteine can create problems. Blood hypercoagulability, we know that D-dimers, factor V Leiden, and Wald-Milgram factors, these can cause. Smokers, there's hypercoagulability. And in the scenario of a minor plaque erosion or a plaque rupture, smoking can create a prothrombotic milieu, create platelet problems. And we have also got issues of thrombocytosis and anticardiolipid antibodies, which can create the problem. The next issue is which plaques cause ACS. It's not the severe plaques that create ACS. And this is the problem here. It is the moderate plaques and mild plaques that create problems. And you can see 68 plus 18, that's about 80 plus 85% of patients have less than 70% stenosis, which cause plaque rupture. So to say that these stenotic lesions are the ones which create plaque rupture is wrong. Unfortunately, it is the stenotic lesions which also increase luminal narrowing in the future. And this we have seen with angiography and functional testing, that the severer the lesion, they progress. But that's not necessary. That's only in stable angina. In ACS, it can be the milder lesions which rupture. So clearly we have this problem of both happening. FFR can also help us to check these things, that the FFR of less than 0.75 is important for stratifying these patients. The two important studies, which have recently been published, is important for us to know. One is the prospective natural history study of coronary atherosclerosis, which was looking at patients who were having plaque characteristics which predisposed to plaque rupture, which was published in the New England Journal of Medicine, which was the Prospect 1 study. And we found that TCFA plus a lesion area less than 4 and increased plaque burden, they put together, the chance of events was much higher than either of these. And these are 4 characteristics which we should combine to see if these plaque ruptures are predictable in the future. The Prospect 2 was this time published presented in the TCT Connect this year. And this was a prospective natural history using NES-IBIS in patients with acute myocardial infarction. The background being the same issue, that we have these vulnerable plaques which may progress suddenly, And can we do some preventive pharmacological or medical stabilization or stents to stabilize these plaques? And the prospect study looked at large plaque burden, small lumen area with thin fat fibroadenoma assessed by intravascular ultrasound in angiographically so-called mild to moderate lesions, which were FFR negative and predicted the future of events. They also used the NIRS, which was looking at the lipid-rich core, and this is a way of looking with spectroscopy inside the coronary arteries to see whether the plaques are yellow, red, or not lipid laden. And the design of the study was very, very nice because it looked at patients who, after successful treatment of flow limiting lesions with the recent MI, that's a culprit lesion, had a look at all the other 3 coronary arteries, proximal 6 to 10 centimeters, with a combination NIRS-IVUS catheter. And the untreated non-culprit lesions were prospectively identified by IVUS with their lipid contents with a blinded NIRS and followed up. They were looked at for 4 lesions were looked at, the originally treated culprit, the scaffold randomized treated lesions with an absorb stent, the untreated non-culprit lesions, and the intermediate ones on an angiography. So NIRS is something like this. You look at the plaque over 4 millimeters and look at the pixels and the amount of yellowness in those pixels with the probability of lipid more than 0.6. And you get something called as a lipid core burden index over 4 millimeters and predict that these plaques are unstable. So this is a design, 900 patients with ACS, culprit treated, non-culprit checked. If they had more than 65% plaque burden, we randomized the yes ones to absorb BVS with good medical treatment. If they had no, they were medically followed up with a median of 3.7 years with a routine coronary angiogram, IVUS, NIRS follow-up at 25 months. What happened? Total MACE was 13%. Surprisingly, the non-culprit had about 8%. And this tells you the story that it's not always the culprit which causes the problem. The non-culprit can create problems. The BVS randomized patients at 4.3% events, while the medically treated culprit lesions at 4.2%, no much difference. But the intermediate MACE was 2.5%. The predictors in a multivariable model was plaque burden more than 70, and LCBI at 4 millimeters more than 320 plus, and a minimal luminal area of less than 4 millimeters. The conclusions was, after treating flow-limiting lesions in AMI with contemporary deaths, MACE occurred in 14% of patients at a median of 3.7. 8 were unanticipated events in untreated non-flow limiting plaques. 4.6 were from recurrent events at culprit lesions. 3 vessel intracoronary imaging with NIRS-IVUS was safe, and these identified lipid-rich angiographic lesions in mild non-flow limiting plaques, which were responsible for future events. And the combination of a lipid-rich plaque and large plaque burden can help us in vulnerability. The prospect observed was a direct follow-up of this study, where what they did was simply took those patients which were, having a plaque burden and treated them into 2 arms, which I showed you, either with the absorb BBS or medical treatment. After we showed that the FFR was negative or the IFR was low, and treated those patients with good medical treatment versus absorb plus good medical treatment. They were then followed up at 25 months with an angiogram and a NIRS-IVUS follow-up. And what they then showed was very nice. The MLAs improved in the BVS plus good medical treatment as compared to good medical treatment. P-value is highly significant across the primary lesion and across the entire lesion. So definitely, the absorb gave you better lumens. Outcomes, no different. Target lesion failure, same between good medical treatment and absorb plus good medical treatment, but lesion-related MACE numerically was better with the absorb, but did not achieve p-value significance. This was published simultaneously in the JACC, which showed that angiographic mild lesions with large burden was safe in PCI, and the beta BBS was creating an enlarged MLA at follow-up, but the MACE outcomes was no different, and this is something which needs to be prospectively followed up with larger randomized studies. So in my conclusion, imaging of vulnerable plaques is a fascinating research tool, providing useful insights into the pathophysiology of ACS. Most of the data are with ruptured plaques. We still don't have much data with erosions, And we have some nice work which we have done at MMM, which is important in the erosion area. The local therapy in the absence of documented ischemia is clearly unproven as of present. The risk stratification should be important. It's not only about the plaque and the ischemia detection, but we need to look at markers of necrosis, inflammation, and thrombogenicity. And today, I think what the jury is that you need systemic therapy to stabilize the plaques, which includes antiplatelet therapy and high-dose statins. Whether a stent will help in the future is unclear right now, and we need large randomized studies with the same. Thank you very much for your patient hearing.
Yeah, thank you, Dr. Ajit, for this excellent talk. I mean, I want to ask you one question. A vulnerable plaque versus a culprit lesion which does not have a significant plaque underlying that. Would you consider both of them say the same? For example, my question is, you see a ruptured plaque, but the FFR is negative. Would you go and stent it, passivate the lesion?
So this is exactly the information that we are looking at. So Ronnie, we always see ruptured plaques in coronaries as you image, and many of them don't create an ACS. They just spontaneously, heal. And you can see, we had a recent paper by Dr. Mintz showing healed plaques from China, because Zhang is the first author, where you can see very clearly that many of these plaques just rupture and heal without even creating ACS. Now, what causes the ACS is ultimately at that point of rupture, what happened in the milieu, whether it's thrombotic or not. So just seeing a vulnerable plaque or a ruptured plaque doesn't make clear that you need to fix it by a procedure, especially if your functional test is negative. This we have clearly seen with erosions that we don't need to fix it at all. I think we don't need to fix it even with the ruptured plaques. If your flows are good and your lumens are good, I don't think there's a reason for us to fix it just because there is a rupture, though the science behind that has not been proven yet. But obviously, if you have a rupture with a large plaque, with a stenosis, with lumens which are small, and there is a flow disturbance, you need to fix it. That is for sure. So I think the jury is not out whether we can have a mild ruptured plaque with a cavity, with a good lumen. Do we need to stent it at all? I think this needs further investigation.
Yeah.
I can add something to it, sir. So it's actually, we always think, erosion with a good lumen area, we have to leave it. And suppose you find a ruptured plaque, better to fix it. So that works in AC scenario because, the current means contemporary teaching is whether you have an underlying stimulus for thrombus formation. In case of ruptured plaque, when you have a cavity that is filled with a necrotic core. So that is a persistent stimulus for thrombus. That is one of the most important cause where you have reocclusions following your thrombolysis. So that is where you have to fix when you find a ruptured plaque. But you find a ruptured plaque just means incidental finding of a cavity, and with a good lumen, don't have to do anything. So it is whether there is a stimulus for your thrombosis. In acute setting, you have still some necrotic material remaining inside the cavity, so that is a stimulus for your thrombosis. It is not the cavity per se, where what you see in patients with ACS, multiple ruptured plaques you see. So unless you find something necrotic core or something inside, there is a stimulus for your thrombosis, you don't have to treat it.
Now, are you trying to say that if you see thrombus with a cavity, you must stent it?
Yeah,
a clean cavity, leave it.
Yeah. Suppose you find a patient who had a STEMI, and you find maybe a 70% stenosis, but a big rupture plaque with thrombus, better to fix it rather than leaving it.
Well, I think right now, Ronnie, the jury is not clear on this area. So I think we do this. We see a large rupture, we see some stuff in that artery, we know it's ACS, we know that's the culprit, we put a stent. Now, we have no natural history on these follow-ups, whether they will reclot once you treat them with statins and you treat them with dual antiplatelet therapy or whatever. And this is exactly the paper. In fact, I asked Dr. Mintz this question last week in our meeting. Would you stent every ruptured plaque? And he said no, because on a follow-up of healed plaques, you don't need to do that because many of these plaques just heal. In our bodies, there's always plaque ruptures going on, and they're all healing by itself, and you're not putting stents anyway. So this visual fixing of vulnerable plaques with mechanical procedures, I think is still not very clear. And I don't think this study has Prospect 2 defines anything. I think what we need is larger, better randomized trial, maybe with better stents and better identification of those vulnerable plaques which are more sensitive criteria to define whether you need to fix them or not. At this point, general medical therapy.
One other point which
So,
is
excuse me, Baulane sir, we are encroaching into the next international speaker session. So I'm sorry to interrupt you. Thank you very much, Professor Baulane, Dr. Ronnie, Dr. Vijay Kumar for chairing this wonderful session with all the speakers who did a very good job. We all enjoyed this session. Thank you very much, and we'll move on to the next session. Thank you very much.
Thank you, sir. Good night.
Thank you.
Bye.
So we'll go to the next session. So we move on to session number 48, which is Pearls of Wisdoms from the Masters. And to chair this session, we invite Dr. Atul Mathur, Dr. C. Raghu, and Dr. Arnab Datta. Have they logged in?
No, sir, not yet, sir. I think we can start, sir. All are playback.
So we will invite the first speaker for this session, Dr. Vera Helena Rigolin, who will speak to us on tricuspid valve disease, the new frontier. Session.
Hello, everyone. Thank you for the opportunity to talk to you today about tricuspid valve disease, the new frontier. Thank you to the course organizers for inviting me to speak about this topic. And I'm sorry that we're not able to meet in person, but I look forward to seeing you again in the live format at some time in the near future. I have no disclosures or relationships to disclose. I will be talking, however, about investigational tricuspid valve repair devices. To better understand the tricuspid valve arena, we need to first understand what causes tricuspid regurgitation. We can lump this into three main categories. The first is what we call primary tricuspid regurgitation, which is when the problem is the tricuspid valve itself, such as prolapse, rheumatic disease, issues that affect the valve mechanism itself that then results in regurgitation. Secondary tricuspid regurgitation occurs not when the valve is malfunctioning, but rather when there's a problem with the right ventricle. And that is shown in this middle panel here. You see that the right ventricle is dilated. There is displacement of the papillary muscles. This causes stretching and tethering of the leaflets, causing malcoaptation of the leaflets, and then regurgitation. And finally, we have a third category called isolated tricuspid regurgitation. And that's actually due to a problem not of the right ventricle, but of the right atrium. And here, the right atrium dilates, it stretches the annulus, pulls the leaflets apart, and results in tricuspid regurgitation. And the classic disease state that causes isolated tricuspid regurgitation is atrial fibrillation. So here's an example of a patient of mine with serial echocardiograms between the year 2000 and 2011. And you see she has chronic atrial fibrillation. And you see that between 2000 and 2011, she's had progressive enlargement of both her atria, particularly the right atrium, however. This results in stretching of the tricuspid valve leaflets, then they don't coact properly, and the result is severe tricuspid regurgitation. Back in 2011, our only option in treating a patient with symptomatic disease such as this was surgery, and she was referred for open heart surgery and had her tricuspid valve replaced. Here's another example of something that we're seeing more and more often, and that's tricuspid regurgitation due to pacemaker interference. This is best illustrated with the 3D images on the right-hand side of the screen here. You see that the pacemaker lead is impinging the septal leaflet of the tricuspid valve, preventing it from closing, and it's resulting in severe tricuspid regurgitation. Now, if we look at the breakdown of what the causes are of tricuspid regurgitation, we see that the majority of the cases are functional in nature, meaning it's not the tricuspid valve itself, but rather the surrounding structures. About 80% of the cases are functional. Only 20% are primary. So we have a huge opportunity in terms of our identification of the problem and treatment modalities for this large group of patients. And why is this important? It's important because significant tricuspid regurgitation is bad. And as you see from these slides, regardless of the type of tricuspid regurgitation or despite whatever etiology causes the tricuspid regurgitation, the presence of significant TR leads to a worse prognosis. If we look at the 2014 AHA-ACC valve guidelines for the indications for surgery for tricuspid regurgitation, we see that there's really only 2 times where there's a class 1 indication for tricuspid repair or replacement. And both of those are in patients with left-sided valve disease who are undergoing surgery for their left-sided valve disease. And while the surgeon is there, he or she will take care of the tricuspid regurgitation at the same time. All other indications are either class 2A or class 2B. A lot of this has to do with the challenges associated with tricuspid valve surgery and the poor outcomes that can potentially occur. And this is mostly due to the fact that we tend to wait too long to send patients with severe TR for surgical repair or replacement. With that in mind, however, this leaves us great opportunities for transcatheter therapies for the tricuspid valve. I must say that here, at least in the United States, all of these devices shown are investigational in nature. So really, we're entering a new frontier in percutaneous tricuspid valve repairs. There is a long list of potential devices that can be used for this, and many of them are listed in the slide. I'm going to be showing you examples of a Cardioband device, the tricuspid MitraClip, the Pascal device, and an Evoque tricuspid valve replacement. So before I get to that, however, I want to emphasize to you the importance of doing a very comprehensive echocardiographic examination of the tricuspid valve to best define its anatomy and to help determine which patients are the best candidates for the specific transcatheter devices. And since we have several devices under investigation, some tricuspid valve morphologies may be more amenable to one device or another, thus again emphasizing how it's important to do a comprehensive anatomic assessment of the tricuspid valve. With transesophageal echo, we often start with the mid to lower esophageal views at 0 degrees. The mid-esophageal view is shown on the left side of our screen, and here we see predominantly the anterior and the septal leaflets. If we push our probe down so that we're more into the lower esophagus, we tend to see the posterior and the septal leaflets. The other really helpful image is this biplane image shown on the left side of the screen. If we move our biplane cursor more towards the aortic valve, we are crossing the anterior aspect of the tricuspid valve, and the corresponding image here shows the septal and the anterior leaflets. If we move our cursor more posteriorly, when we see our corresponding biplane view, we're seeing the septal and the posterior leaflets. The transgastric view can also be quite helpful, and you see here that we are seeing all 3 leaflets en face. Other key images are 3D images of the aortic valve, as shown in this slide here. And so let me give you some examples of this. So our first case is a 76-year-old female who has a history of a prior mitral valve repair due to a flail leaflet, and she has a 32 millimeter ring annuloplasty. She also underwent a Mays procedure for a fib and left atrial appendage closure, and aortic valve repair. She has multiple comorbidities, making her high risk for surgery. She presents with abdominal discomfort and bloating. Her echo shows severe functional TR with RV enlargement and hypokinesis, and she's enrolled in the Cardioband research trial. Here are some images of what the Cardioband device is. It is CE approved for mitral regurgitation, and it is a transfemoral annuloplasty device with proven safety in the mitral position. It was first tested in humans in the tricuspid position in 2016 and received CE approval for the TR repair in 2018, but remains investigational in the United States. And basically the idea is the placement of an annuloplasty-like device done percutaneously. So part of the workup for individuals who are considered for this device is a CAT scan to get best anatomy of the patient. And here we see all the different devices that are in this patient's body. And you can see why she would be a difficult patient for surgical tricuspid valve therapies. We can also do some virtual modeling on the CT to show how the device would sit, and importantly, the proximity of the device with other important structures such as the right coronary artery. Here's another CT rendering showing again an overlay of where the device would sit and how close it is to the right coronary artery. Here are baseline images. You see that the annulus is dilated, both the right atrium and the right ventricle are dilated. There is significant tethering of the leaflet tips and poor coaptation of the leaflets, resulting in severe tricuspid regurgitation. Here's the transgastric images showing the en-face view of the tricuspid valve, and you can see the poor coaptation of the leaflets resulting in severe TR. And here's our three-dimensional images showing the same thing. We can also use the NPR mode to assist with device placement. Here's the NPR mode assisting in placement of the anchors of the Cardioband device and to assure its correct position relative to the annulus of the tricuspid valve. And here we are now percutaneously placing anchors around the annulus, which then is going to stabilize our device around the annulus of our tricuspid valve. And here we see the anchors on fluoroscopy. And on the left side of the screen is all the anchors placed. And then on the right is after we cinch the device, which is essentially taking the annuloplasty and pulling it together. So it's like a purse string that then diminishes the size of the annulus, brings the leaflets into better coaptation and reduces the TR. And here we are now post-cinching. Here's the device around the annulus. And you can see when we turn on our color, we've already seen a reduction in the TR severity. And here's our transgastric view and that biplane view from the before, showing again the significant reduction in TR. And here's some data showing early feasibility of the Cardioband tricuspid system for functional TR. This is showing 30-day outcomes, and it was presented at this year's ACC meeting. And you see that at 30 days, there is a significant reduction in the severity of tricuspid regurgitation. The next patient is an 86-year-old female with severe mitral regurgitation due to myxomatous degeneration. She has a flail A1 scallop and P1 restricted. She's admitted 1 month prior with decompensated heart failure. She was also found to have significant tricuspid regurgitation. So this patient was referred for a MitraClip, which is an FDA-approved device for primary and secondary mitral regurgitation and can be used for off-label treatments of tricuspid regurgitation in patients who have it for their mitral valve disease as well. So here is this patient's echo. You see the flail anterior leaflet on the left-hand side of the screen with resultant severe mitral regurgitation on the right-hand side of the screen. And here's the 3D of the valve. You see the flail scallop right here and the corresponding jet of mid to lateral regurgitation. So this patient had a mitral clip placed between the A2 and P2 scallops, and you see there was a very nice result with a significant decrease in the severity of mitral regurgitation. We now turn our attention to the tricuspid valve. You see our biplane images here demonstrating the tricuspid regurgitation. And here we are again doing more biplane imaging of the tricuspid valve. And here we are now showing the transgastric images on the left, and the 3D images with and without color in the middle and right-hand panels. And now the clip is being placed in the tricuspid valve. And you can see we toggle back and forth between our biplane image, the 3D image, and the transgastric image to be able to guide placement of the clip. And then the leaflets are grasped. And here we're grasping the septal and the posterior leaflets of the tricuspid valve. And here's our final result. With one clip, we see that there is a significant decrease in the severity of tricuspid regurgitation. Our next patient is a 69-year-old female who presented with progressive shortness of breath, abdominal swelling, and lower extremity edema. And she had been recently hospitalized for acute decompensated heart failure and experienced a 13-pound weight gain after discharge despite maximal medical therapy. She has multiple comorbidities, reduced LV systolic function, mild RV enlargement and hypokinesis, and severe functional tricuspid regurgitation. She was seen in our heart valve clinic where a compassionate use of the Pascal device was discussed. And this is an image of the Pascal device, which is CR marked for mitral regurgitation and investigational for tricuspid regurgitation. Here are the images of this patient. Here's our gastric images demonstrating again the significant tricuspid regurgitation, and you can see the poor coaptation of all three leaflets. And here are our 3D images of the same patient. Here now we are inserting our Pascal device, and once again we're going to be toggling back and forth between the gastric images, our biplane images, and our 3D images in order to guide the procedure. And once again, we are using our biplane images, our gastric images, and here now we have the device placed. And you see on the lower color images that there's a significant reduction in tricuspid regurgitation severity. And in cases where the transesophageal imaging is challenging with the tricuspid valve, another option is to use intracardiac echo to guide the procedure as shown in this example. And here's our final image where the anterior portion of the posterior leaflet and the septal leaflet were captured with the Pascal implant. And here is some preliminary data for compassionate use of the Pascal device at 6 months. And you see that in the small cohort of patients, there is a reduction in the severity of tricuspid regurgitation at the 6-month mark. Here is data from the TriValve registry, which is collecting information from patients that undergo transcatheter therapies for tricuspid regurgitation. And you can see the breakdown of the devices included in this registry on the left-hand side of the screen. And here from that data, you see that individuals who undergo tricuspid intervention have a better overall survival and survival free from heart failure when compared to medical therapy. So these interventions do show quite a bit of promise. My final example will be to show a new valve that is currently under investigation for a tricuspid valve replacement done percutaneously. This is a 79-year-old female with severe lower extremity edema and increasing abdominal girth, shortness of breath, and this is all refractory to diuretics. She has a large right pleural effusion regarding thoracentesis. She has liver enzymes that are elevated due to hepatic congestion, and she's enrolled in the EVOKE trial. Here are her baseline images. Again, you see the severe tricuspid regurgitation and the tethering of the leaflets due to RV dysfunction. And again, we go through our biplane images shown here. And here's our gastric images, showing again the poor coaptation of the leaflets with the resultant tricuspid regurg. And then here we are now guiding the placement of the EVOKE valve. We use the same images. We use our biplane images. We use our transgastric images, and we use our 3D images. And here we can also use an MPR mode to demonstrate all images at the same time. And here's our final result. You see that we have a nicely seated prosthetic valve. And if you look in the lower right-hand side of the screen, there really is very minimal tricuspid regurgitation. So in summary, the tricuspid valve has complex anatomy that must be appreciated to safely and successfully treat tricuspid regurgitation. The prognosis of severe TR is poor regardless of the etiology. Functional TR is more common than primary TR and is most commonly due to left heart disease. Quantification is challenging but is very important. Treatment of TR is dependent on the severity, the symptoms, the etiology, the RV function, and whether or not the patient needs concomitant left heart surgery. Percutaneous tricuspid valve repair is in its infancy, but will likely change the landscape of tricuspid regurgitation treatment in the near future. And with that, I thank you very much for your attention. And once again, I congratulate you on your wonderful conference and hope to see you in person again soon. Take care. Thank you.
Yeah. Thank you, Dr. Helena, for this wonderful talk. And we do appreciate you coming in to the CSI. Now, next, it's my privilege to welcome Dr. Tom Johnson. He's a young and brilliant cardiologist from Bristol, United Kingdom. I've heard him a multiple number of times, and it's really a pleasure listening to him. His interests are in bifurcations, and he is a part of the European Bifurcation Club and an avid coronary imaging specialist. So we're going to have a treat here when he's going to speak to us on optical coherence tomography in bifurcation lesions. And that is truly the forefront or the cutting edge now. Over to you, Dr. Tom Johnson. Dr. Tom, I think you are muted.
I've just taken mute off. Ronnie, thank you so much for the invitation, and it's a real delight to be with you this afternoon. I'm only very sorry not to be with you in person. Now, you've asked me, obviously, to talk about OCT, but I'm very aware of the fact that there was a debate earlier on with Gary Mintz on the side of intravascular imaging, and I think it's only right, really, to then consider intravascular imaging in bifurcation stenting. Certainly in the UK, the penetration of OCT to date is probably only 3 or 4% of procedures, and IVUS is less than 10%. So I think actually it's useful to consider both, but I will very much lean towards OCT during part of the presentation. These are my disclosures. And I think the most important would be to say that I am obviously a believer. I have a bias towards intracoronary imaging as an approach to PCI, and particularly within complex bifurcation lesions. Now, the reality is, and this was discussed at this year's European Bifurcation Club, was that there's a tendency for a very polarized view to develop within the community in terms of imaging. And that's in the sense of either being mandatory that we image, or that perhaps we're very lucky and fortunate to have been blessed with IVUS eyes, and you can carry on with an angiogram just simply through your own brilliance. I love having been called young and brilliant, but I think neither of those particularly apply to me. But in the setting of intravascular, certainly in the setting of treatment of left main stem, there is this clear kind of dichotomy between those that will do it without and those that say you should do it always. Now, if we just simply look at UK data, then clearly we are far from the truth. And in fact, this is data we published just earlier this year with Tim Kinnaird in Cardiff. And we can see that really in the most contemporary data, the most recent we have is 2017-18, we see a penetration of maybe 60% of left main stem cases being done by intravascular ultrasound. Here we see in our paper this temporal increase up to 50% by 2014. And there are clearly reasons for why imaging, particularly in the left main, may not be appropriate in unwell patients presenting with cardiogenic shock, or often in the setting of an acute coronary event. That may be felt that imaging is a step too far. But I think clearly this idea that it should always be done does not fit with reality. Having said that, my argument for saying we should be using imaging more comes and is highlighted beautifully in this figure from the European Bifurcation Consensus document on intravascular imaging by Gary Mintz. And this is taking a cohort of just under 100 angiograms where the bifurcation anatomy has been defined using the Medina classification, so from 111 down to 000. And then undertaking intravascular imaging down both limbs of the bifurcation, and then assessing actually by virtue of imaging the extent of disease. And I think this is a really scary, scary image, because this tells us that actually even in this cohort where 60 of the patients were deemed to have no left main disease, Medina 000, actually by imaging we see a very, very high proportion, over 50%, having disease that impacts the proximal and both daughter vessel limbs of the bifurcation. And there's a smattering of other types of geographical distribution of disease that we see with imaging here as well. And so, the reality is that the angiogram and our interpretation of the angiogram very much hides the truth. And so we can't undertake imaging, we can't undertake PCI, I believe, safely without truly understanding the extent of disease. So how about if we then turn to this idea that with IVUS eyes we can do everything, and the supporting statements that we hear is that, I've learned from experience. I have 20, 30 years of experience. I know what I'm doing. I used IVUS maybe 20 years ago, and all it told me was I just need to balloon to higher pressure. I'm fine, thank you, I'll carry on. The other is that in particular reference to bifurcation, that actually we've adopted techniques, particularly proximal optimization, final kissing balloon inflation, the idea of repot, more proximal at the end of a procedure, and these clearly make a difference. And that imaging in itself carries an unnecessary or potentially prohibitive cost, both in terms of financial and time. And I think we do have to acknowledge that across multiple geographies, there are going to be different pressures and differing access to these types of technology. And so clearly, I think cost is an element of has to be considered, but shouldn't be the reason not to use it where the risk of failure is very high. And then the last element would be, well, actually my outcomes are good, so why do I need to change? And I think for me, these are aspects that I'd like to highlight specifically. So if we think about the learn from experience, well, there's some further data from Tim Kinnaird and our BSIS data set that shows, interestingly, that we see a shift in use of imaging, certainly in the first, second, and third quartile, with then interestingly this kind of IVUS eyes type observation that the highest volume operators in quartile 4 are using less imaging than in quartile 3. We look at the temporal changes again, and we see that mainly intravascular ultrasound is used for the left main stem. There's been a slight encroachment of OCT, but there's an issue that some would feel about the depth of penetration, although actually there's been a beautiful study just published by Nicolas Amibile called the Lemon Cohort by OCT, which shows absolute feasibility for the use of OCT in left main. If we then look at this differential in operator volume from quartile 1 to quartile 4, in fact, what we see here is that really high volume intervention is what probably carries the best outcome in these hands. And so we see a tremendous difference here with quartile 4. If we break that down into individual components of outcome, then actually we see a trend with increasing outcome, increasing volume, where we see a better outcome in terms of in-hospital MACI for both quartile 3 and quartile 4. And that's true also, importantly, for mortality. It's less evident, but we still see this trend with kind of diminishing detrimental outcome with higher volume here for periprocedural MI, for other procedural complications. So this actually falls into the hands of the IVUS eyes operators who will say, well, look, it truly is volume that leads to it. But actually, if we remember, our quartile 3, quartile 4, we're using 40 to 50% of imaging. And if we break down simply our left main cases from those that are imaged to those that aren't imaged, we see a very striking enhancement in mortality, a very hard endpoint out to 1 year with the role of intravascular imaging in the left main. And so again, I think this very much weighs heavily on the need for us to use the modality to optimize our outcomes. So how about this idea, well, my outcomes are good, so I don't need to worry. Well, if we turn to the most kind of contemporary data that we have, so XL in terms of left main, David Kandazari did a very nice subgroup analysis specifically on the PCI cohort. And if we dichotomize those with planned 2-stent against provisional stenting, then actually we see really quite significant burden at this composite endpoint of death, stroke, MI, ischemia-driven revascularization out to 3 years. And although IVUS was used in this study up to about 3/4 of cases, but without a dedicated protocol, I would argue that 30% event rate is not acceptable for my patient, and we clearly need to be doing better, spending more time being more appropriate in our decision-making during these complex interventions. Even more contemporary data, definition 2 from China, looking at provisional versus a dedicated 2-stent approach in complex bifurcation. And here, unsurprisingly, with the success of DK Crush, we see a better outcome here with 2-stent. But I would really worry here about the idea of both target vessel myocardial infarction in totality, but particularly periprocedural myocardial infarction, being more evident in a provisional strategy than a 2-stent strategy. And I'm afraid that simply doesn't make sense, particularly when we see the 2-stent strategies being more technically challenging, taking longer. And the intravascular imaging use in these Chinese groups, relatively small, 1/4 to 1/3 of patients utilizing imaging. So we're seeing at the moment that the fact that we probably need to be doing better across the whole board in terms of our interventional outcomes here for bifurcation disease. So how about this idea? Well, there are techniques that we've adopted, and the European Bifurcation Club certainly has been very aggressive in pushing for these techniques to be adopted quite rightly. But actually, there's always been a criticism that maybe we don't have data to support this. But when you consider, and these are beautiful images from the Medtronic Visible Heart Lab in Minneapolis, and we see here deployment of a stent that's sized to a distal side branch. When the balloon is deflated, we see that there is this considerable risk with a stent that is floating in the proximal vessel. And so clearly proximal optimization, the expansion of this undersized stent into the proximal artery, is critically important if we want to avoid distorting the architecture of the stent, if we want to avoid abluminal wiring of this stent and then destruction with subsequent passage of balloons and other devices. And similarly, we also have to be very mindful that these discrepancies between daughter vessel and proximal main vessel require us to think about our stent selection before deployment. And Nicolas Foyn's image here on the right-hand side shows very importantly that there are significant differences in terms of the matrix of stents. You can see here in the Synergy, we have 3 different matrix, where actually it's only the 4O that has the capacity to go up to 5.7 and above, whereas the Medtronic Resolute has 4 matrices with the ability to go to very high sizes in this larger XL cohort. So the selection of your stent according to the vessel size is important, and that's much easier to achieve and to measure with the use of intravascular imaging. Now, in terms of the evidence, this is the first evidence, and really quite exciting, from the eUltiMaster registry from Terumo, which shows really for the first time clinical benefit rather than just this conceptual benefit of proximal optimization. And we see a benefit there against no POT, which importantly it was undertaken. POT was not undertaken in as many patients as we would have assumed, only 30 or 40%. And we see here though a striking improvement in target vessel MI, clinically driven target lesion revascularization, target lesion failure, and importantly stent thrombosis as a result of clearing these stents, ensuring less gross malapposition. Now then, when we consider the next step following proximal optimization, and this again beautiful illustration of what we're doing when we're attempting to wire, ideally in this setting, a distal cell of the stent that's jailing our side branch, we see again on another consensus, the OCT consensus document from Yoshi and Numa, that there are a number of different permutations and combinations that we should be looking for in terms of the effective cross. And if we're doing this blindly, then I'd really argue we have no real way of knowing which of these cells we may have crossed. And the October study is a dedicated OCT study, which is testing now the use of OCT to guide us in appropriate selection. And I must say, in my practice in complex bifurcation, I'm using this already. And we see here in this example where it's been crossed by use of angioscopy, that we have a number of potential locations. We have this distal or proximal cell that we wouldn't want to be crossing. We have actually then a more middle cell that again probably would not be ideal. And the distal cross, in reference to Yoshi Anuma's image on the right-hand side, seems to be the one that I've colored now green and is the target, and in fact is where this wire has crossed with use of the angioscopy. Now, interestingly, when we then look at the outcomes from the eUltiMaster registry in terms of final kissing balloon, we actually only see a benefit in target vessel myocardial infarction. And I'd argue that this is probably due to the fact that we're not using imaging, and the potential hazard is that by final kissing through one of the other cells, we are in theory generating a detrimental result. And so actually in the absence of using imaging, final kissing balloon potentially has a fairly neutral effect, because we may actually be rendering the result kind of suboptimal. And this is obviously what we're trying to achieve, so beautifully represented in this still frame angioscope image. So what does the European Bifurcation Club have to say? Well, we published the most recent consensus in October, and we have a dedicated section on intracoronary imaging and highlight the importance and the kind of evolving importance in complex bifurcation lesion PCI. I think in a fairly balanced stance, we highlight that really there's a role for both intravascular ultrasound and OCT, and that should really be according to the individual's experience. And I don't know the outcome of the debate earlier. I'm sorry that I couldn't attend, but I would suspect there was a balance in the sense that both modalities offer something, and certainly the resolution of OCT is favorable, but the depth of penetration of IVUS and absence of contrast is beneficial for that modality. And the ostial nature, the large vessel, as I say, may favor IVUS, but data certainly just published by Nicolas and Mublet in terms of the Lemon study suggests there's definitely a role for OCT in left main. And then again, as I've said, this resolution, particularly now the ability to detect calcium, is increasingly important, particularly if wanting to modify. And we await the results of contemporary studies. Now, to take it one step further and really looking into the future, this was really exciting data that was presented by Yanis Chatzis, another board member from the EBC, at this year's virtual meeting. And he's been doing some incredibly exciting work using both live simulation and computational simulations of bifurcation, creating 3D models from both angio and OCT, and then simulating techniques and actually even able to simulate discrete equipment device changes, so utilizing different stent types to see how they behave. And this is work that's just been submitted where we've been using both the three-dimensional reconstruction by OCT and angiography, and then comparing the actual result achieved in these clinical settings against the simulated results. And we see actually an incredibly close alignment of the results. And so the simulations seem to be very predictable. And to extend that even further, we can then use the information from the OCT to understand the true tissue characteristics in the bifurcation, and therefore then anticipate that maybe in areas of calcification, as we see in this distal limb of the bifurcation, that may impact in the way that the stent behaves on both deployment and subsequent post-dilatation. And so this has incredibly exciting application. It might be used in the clinical setting where we may get to a point where we can actually simulate this real time and make decisions by using these simulations to test different techniques, different approaches, different devices to choose the optimal decision for our single individual patient. Yanis has already used this in stent manufacture and helped in terms of the decision-making in selection of the Megatron device to the 12 crown configuration. We can use this in principle for virtual clinical trials, and most importantly, I think, for education and training, where we can test and understand techniques which are quite complex and challenging in the clinical setting. So I conclude by really saying, imaging in bifurcation PCI, for the moment, it's not mandatory, but I think it is a very good idea when we're using it in complex disease. And the role really should be to define the disease, to then consider modification of plaque. And I think this is going to become increasingly essential. And particularly now we have the advent of intravascular lithotripsy and increasing use of rotablation in calcific disease. We can only hope actually for better long-term outcomes than those that we observed in even the Excel subset. We then can use this information to enhance our strategy decision-making, to enhance the stent selection. And as I've shown you, there's some really exciting developments on the horizon. And then we must use imaging to optimize our result. So to take it from the very beginning to the end of our procedure, ensuring that we've effectively expanded every element of our bifurcation and the complex disease that we're challenged with every day. I really thank you for your attention, and I look forward to seeing you again in future meetings.
Thank you. Thank you, Dr. Tom, for this excellent overview of imaging in bifurcation. Let me push you a step further. I mean, if you have a choice between intravascular ultrasound and optical coherence tomography, especially in a distal LM bifurcation, would you prefer OCT because it will tell you about a strut because of its resolution? It tells you about the strut crossing. It tells you, as you said, which is the distal or the proximal strut that you cross, whether you have done an optimal pot or whether the kiss has been effective. Or would you say either of the technology is the same?
They're clearly not the same, but the reality is I think they both have benefit, and I'm in a very fortunate position where I have both. I won't often use both in a single patient. I think often I have to say that the software capabilities that we currently have with our OCT system, with tabletop real-time analysis, with the ability for the three-dimensional reconstruction, for me is both exciting but very user-friendly. And so if I'm dealing with a complex distal bifurcation, I will, where possible, select OCT over IVUS. But I absolutely get that IVUS gives us some slightly different information at times. So if we've got a particularly big left main, if we use that as the example for bifurcation, if we have disease which is complex that doesn't allow us a true understanding of the depth of the vessel wall by OCT, then there are advantages. And the reality is, I think in a couple of years' time, we will probably be using a combined catheter. So Terumo within the next 12 months, hopefully, will be releasing their combo catheter of IVUS and OCT so that you have the benefits of both systems. So for the moment, the resolution of OCT, I think, wins for me when we're talking about these decision-making elements in terms of technique.
Thank you very much, Dr. Tom Johnson. On behalf of the Cardiology Society of India, I indeed thank you very much for being a part of this conference, and we look forward to having you in person next year.
Great pleasure. Everyone take care.
Thank
All
you.
right.
Thank you, Dr. Ronnie, for that nice session. We had the opportunity to listen to the masters on both tricuspid valve disease, the new frontier, as well as Dr. Tom Johnson, who came live for the program to speak about OCT in bifurcation stenting. Thank you very much. Now we move on to the last session of the day in this particular hall, which is on evolving concepts in cardiology. To chair this session, I have great pleasure in inviting the chairpersons, Dr. K.A. Chacko, Dr. Banerjee, as well as Dr. Milan C. Chugg. So over to Dr. K.A. Chacko to carry on with this particular session. You are muted, sir. Sir, you are muted.
Chacko sir, your mic is off. Can you unmute yourself, please?
And probably you can switch on a light also in front of you because it's pretty dark. Yeah, that's great. Wonderful. You are still mute. Fine.
Yeah.
It's okay?
Yeah, perfect, sir. Perfect, sir.
Okay. We are on to a very interesting session with 4 of the giants of cardiology on evolving concepts in cardiology. The first is from Dr. Akshay Desai. Before that, may I ask you whether we have the discussion on at the end of each talk, or is it at the end of the whole thing?
Sir, the second, third, and the fourth talks are pre-recorded talks. So what I would suggest is, at the end of this talk by Dr. Akshay Desai, we will have a short discussion with him, and then we will go on to the recorded talks. And if the speakers come online, then we can always have the discussion at the end. We can have discussion for the first talk after he delivers it.
Okay. Welcome, Dr. Akshay Desai. And you are talking from Boston now, is it? From Dr. Akshay Desai is from Brigham and Women's and Harvard Medical School. He's talking about heart failure with preserved ejection fraction and remodeling. Dr. Desai.
Well, thank you very much. I'm just looking to share my desktop here. Just one moment. Okay, hopefully you can see my screen now.
Not it.
Yes?
Yes, we can.
Okay, great. Is the sound okay? Can you hear me okay?
Yeah, perfect.
Okay.
Well, thank you, Professor Chacko, Dr. Milan, Dr. Banerjee, and the Cardiology Society of India for inviting me to participate in this wonderful session. My focus for the next 14 minutes, and then we'll leave some time for questions, will really be on pharmacologic therapy as it is related to reverse cardiac remodeling in patients with heart failure and reduced ejection fraction. Quite a departure from the last series of talks on interventional cardiology. These are my disclosures, some of which may be relevant to the content I'll discuss. There are really 4 objectives for this brief talk, and I want to talk a bit about the process and the importance of cardiac remodeling for the progression of heart failure in patients with reduced ejection fraction. I want to talk a bit about the role of established heart failure therapies, the familiar pharmacologic and device therapies, in facilitating the reversal of the remodeling process. I want to underscore the association of reverse remodeling with improvement in clinical outcomes. Really, what is the data that suggests that this process of remodeling is such an important target for therapy. And then I want to focus in the last few slides on really the emerging data regarding some of the newer heart failure therapies and their potential impacts on facilitation of reverse remodeling. I think we all understand now in cardiology that the model that we have for heart failure progression in patients with reduced ejection fraction begins with an initial myocardial injury that sets in place a cascade of molecular, genetic, neurohormonal processes that results in progressive changes in shape and size of the ventricle over time that then perpetuate and progress the heart failure syndrome. So the process of remodeling is really that mechanism by which these mechanical, neurohormonal, and genetic factors drive molecular, cellular, and structural alterations that contribute to the changes in size, shape, and function of the ventricle. The pathological hallmarks of remodeling are really hypertrophy in the setting of low EF heart failure. That is typically eccentric hypertrophy with expansion of chamber dimension in relation to wall thickness. Interstitial fibrosis and myocyte loss either through direct damage or through apoptosis. These changes initially are set in motion as an adaptive response but are sustained over time, and in that context may contribute to irreversible damage and heart failure progression. Now the classic paradigmatic case of ventricular remodeling is really in the post-MI setting, where it's now been well described that in the setting of an acute myocardial infarction, there's early remodeling related to ingress of inflammatory cells and activation of matrix metalloproteinases, deposition of extracellular matrix and fiber breakdown that results in expansion of the infarct. And then over time, neurohormonal activation, further collagen deposition and fibroblast aggregation that results in eccentric hypertrophy. And as that hormonal activation is sustained over time because of progressive decline in ventricular function and ongoing stimulation, there is progressive enlargement and remodeling of the heart. And it's really for this reason that neurohormonal activation has become such a target for therapy in the post-MI setting and indeed in the chronic heart failure setting when the same processes are clearly operating. Why do we care about ventricular remodeling? Well, I think it's clear that changes in ventricular volume and ejection fraction have become our really best surrogate for long-term clinical outcomes. And this is data from just one of many studies. This is Valiant, a large post-MI trial, in which we saw that changes in end-diastolic volume and end-systolic volume within the first year were big, important predictors of death or heart failure hospitalization in subsequent follow-up. And it's generally clear that end-systolic volume index is one of the best surrogates we have for clinical efficacy of pharmacologic therapy. This data has been replicated in the chronic heart failure setting, so it applies not just to the early post-MI setting, but also to patients with established heart failure from other mechanisms in the ambulatory setting. Now, what we've learned over time is that remodeling is not simply a forward and progressive, irreversible process, but it's a dynamic process that can be reversed. And that reversal of remodeling has been demonstrated in a number of clinical settings, including cardiac surgery in order to pursue revascularization, mitral valve or aortic valve replacement, popularly in patients with left ventricular assist devices. When we see with chronic unloading, there's even the opportunity for myocardial recovery. But I think the most common circumstance in which we see remodeling is with the application of therapy that has now become guideline directed, which helps to reverse the remodeling process in proportion to the effective application of that therapy and the dosing of that therapy. And then there are other settings of reversible cardiomyopathies from toxins or other features that might be seen. And what we know in each of those settings is that the amount of reverse remodeling is a correlate of improvement in functional capacity, of improvements in prognosis, risk of hospitalizations, and importantly, quality of life in our patients. So the question really is, when you see a patient with heart failure and reduced ejection fraction, who is likely to remodel and how long is it likely to persist? So I think one starting point is that remodeling is an incomplete process in most patients, that we know if we look at three components of remodeling, the cellular part, the matrix part, and the structural part within the ventricle, that remodeling happens at the structural level but may not be entirely reversed at the molecular or cellular level. And so I think for most patients, although complete remodeling can happen, for most patients this is really a partial process. And it is really a remission rather than a durable recovery. And this may be one of the reasons that patients who have reverse remodeling that is incomplete may remain at risk for heart failure events, as shown in this data from the Penn heart failure study. And importantly, one of the reasons that withdrawal of neurohormonal antagonists in patients with apparent myocardial recovery, as was seen in the TREAD-HF trial, results in relapse of LV dysfunction over time. So who gets better with reverse remodeling? Really, there are a few clinical parameters which predict reverse remodeling, including non-ischemic etiology of heart failure, shorter duration of heart failure, females more over males, and the absence of left bundle branch block. Cardiac remodeling is clearly facilitated by medical therapy and also by device therapy such as CRT. And then there are echocardiographic and imaging predictors, and most importantly, those we see by echo and MRI, where by MRI, if we see a lot of late gadolinium enhancement, the patients are more likely to progressively remodel over time, whereas those with lesser late gadolinium enhancement or SCAR are less likely to remodel over time. And we'll come back to this notion of biomarkers as a predictor. But really, when we think about what factors we can apply to facilitate remodeling, it's really medical therapy and device-based therapy of heart failure, which have become so important. And that data really follows from this seminal work by Mark Pfeffer and colleagues post-MI, when the application of captopril, an ACE inhibitor, compared with placebo, was shown to reduce potently the changes in ventricular volume over time. That data, of course, fed the application of captopril in the SAVE trial, which demonstrated that this improvement in remodeling correlated with late improvements in clinical outcomes. And that data has now been replicated in chronic heart failure settings as well, and with other therapies, including beta blockers, where this data highlights that the application of neurohormonal antagonists in combination may facilitate not only slowing of the remodeling process, but actually reversal and shrinkage in ventricular volumes and size over time. So we now have a whole host of therapies that can facilitate this process, and we understand heart failure progression in low EF to be the consequence of a neurohormonal imbalance, and our therapies are now targeted at interruption of renin-angiotensin system and sympathetic nervous system activation to prevent vasoconstriction, fluid retention, fibrosis, and hypertrophy, the hallmarks of the remodeling process, and to augment the compensatory mediators like natriuretic peptides that facilitate the opposite: vasodilation, diuresis, antifibrotic, and antihypertrophic processes. And you can see on the right hand of the slide the evolution of therapy over time, from revascularization to application of sequential gangline-directed medical therapy and superimposition of cardiac resynchronization therapy, which has been a true step forward in facilitating the remodeling process for many patients. And what is clear now is that when we look in aggregate at heart failure therapy, the amount of remodeling is clearly a big correlate of how well patients do. Whether we look at improvement in ejection fraction or improvement in ventricular volumes, those patients with the greatest degree of reverse remodeling have the greatest improvements in mortality and heart failure hospitalization over time, whatever the therapy. And indeed, we've learned now from recent data in the PROVE-HF trial that it's not just the amount of remodeling, but the pace of remodeling that drives those outcomes. And in the PROVE-HF trial, which was a single-arm study of new initiation of ARNI in patients with low EF over time, we saw that those patients who had larger and faster reductions in end-systolic volume index and cardiac biomarkers of remodeling like NT-proBNP by 6 months had the lowest rates of subsequent death or heart failure hospitalization at 12 months. Those, on the other hand, who had lower rates of change in BNP and end-systolic volume had more remodeling over time. And I think this highlights the urgency for medical therapy, because the sooner we implement that therapy, the faster the remodeling process can be attenuated, and indeed the better our patient outcomes we can expect to be. So how do we assess how well we're doing with remodeling? Well, one approach is really to utilize imaging, and we've talked a bit about echocardiography and MRI, but I think biomarkers have emerged as a really potent correlate of ventricular remodeling. This data from our study, the EVALUATE-HF trial, looked at changes in end-terminal BNP as a correlate of changes in end-diastolic volume over a very short duration, 12 weeks. And you can see in just that short period of time, in this trial of ARNI versus an ACE inhibitor, you could see that the amount of reduction in NT-proBNP previewed the amount of reduction in end-diastolic volumes. And so NT-proBNP, which is released by ventricular wall stress and might be expected to correlate with changes in shape and size as well as function of the ventricle, indeed seem to be a potent surrogate. And therefore, this data regarding ARNI is quite important because when we look at the PROVE-HF trial, when you gave an ARNI to patients with low EF heart failure, the new initiation was associated with a precipitous drop in N-terminal proBNP within the first 2 weeks that was sustained and progressed over time in follow-up. We saw the same data in EVALUATE. And indeed, as you might predict, based on the data I've shown you, with this significant drop in NT-proBNP, there was a marked improvement both in the short term compared with enalapril in ventricular volumes, end-systolic volume and end-diastolic volume, and also in atrial volumes over time. This acute effect was not seen in ejection fraction at 12 weeks, but we have data from the PROVE-HF trial that in longer-term application of ARNI, that there is improvement in ejection fraction of nearly 5% by 6 months and nearly 10% by 12 months that correlates with progressive improvements in end-diastolic and end-systolic volume. And indeed, in the PROVE-HF trial, we saw that nearly a quarter of subjects who were initiated on an ARNI had an improvement of at least 13% in EF by 12 months, which is quite important since that would be sufficient improvement in ejection fraction to obviate consideration of therapies like primary prevention defibrillator in patients with low ejection fraction heart failure. So the early application of therapy has impact on NT-proBNP and volumes. It also has improvement on outcomes, and this data is now superimposed on the other guideline-directed medical therapies you would have seen, highlighting the incremental value of step therapy for heart failure. Now, this process of remodeling is now understood to be reversed similarly in men and women, and similarly in patients from different ethnic backgrounds and racial backgrounds. This is data in follow-up from PROVE-HF suggesting that though women started with a higher EF, they actually reverse remodeled faster than men. And although black patients in the trial started with very low ejection fraction compared to the non-black patients, there was a similar pace of reverse remodeling with application of the ARNI. So the question also becomes, we have newer therapies that are emerging for heart failure, and while the guidelines have not formally endorsed use of SGLT2 inhibitors in patients with heart failure and reduced ejection fraction, we certainly expect that to happen based on the overwhelming data supporting efficacy in patients with and without diabetes from the DAPA-HF trial and from the EMPEROR-Reduced trial. And this data, which is now emerging in follow-up, suggests that there may be some effect of SGLT2 inhibitors as well on reverse remodeling. We have early data on left ventricular mass from the EMPA-HEART study suggesting a reduction in LV mass in a small number of patients. Most recently at AHA, two important presentations, one from SUGAR-DM-HF in a small number of patients suggesting that over 36 weeks application of empagliflozin compared with placebo was associated with reductions in end-systolic volume. No change in that trial in ejection fraction over 36 weeks, but in a trial looking at longer-term application of empagliflozin in patients without diabetes, the empatropism trial, there was some improvement in both volumes and ejection fraction as well as LV mass. So preliminary data here, not quite as large as the EVALUATE and PROVE studies that support the data for remodeling with ARNIs, and still more work to be done here, but at least suggestion that this may be some of what underlies the benefit of SGLT2 inhibitors in HFrEF. So to conclude, cardiac remodeling is a key driver of heart failure progression, but can be reversed, and reverse remodeling is particularly facilitated by application of guideline-directed medical therapy. Both the extent of remodeling and the pace of remodeling are tightly correlated with reductions in mortality and heart failure events. Replacement of an ACE inhibitor with an ARNI reduces ventricular volumes and improves ejection fractions, particularly over longer-term exposure, and the data regarding SGLT2 benefits in remodeling is actually emerging. So I'll conclude there, and I'm happy to take any questions you may have.
Thank you very much, Dr. Desai. We have got about 2 minutes for the questions. May put forward a very basic question on this. We must have answered this several times. What I want to know is that when a patient presents to the ICU with breathing difficulty, which appears to be pulmonary edema, then in the bedside, do an echo which shows almost normal LV function. How do you diagnose that LV failure with a normal ejection fraction?
So diagnosis of heart failure in the setting of normal ejection fraction, I think, begins, as you've nicely outlined, with the clinical assessment. So I think that many patients, the operational definition of heart failure in the setting of a normal ejection fraction is really that there is evidence of heart failure by clinical bedside exam, congestion, volume overload, in the setting of a normal or near normal ejection fraction by imaging. I think in that particular patient who's presented with pulmonary edema, it's important to consider the underlying drivers of heart failure in that patient, which might include coronary heart disease in many patients. But beyond coronary heart disease, we're recognizing a number of other processes that may contribute that should be deliberately excluded, including amyloid in the appropriate patient, particularly TTR variant amyloid, hypertrophic heart disease, or infiltrative heart diseases of other types. And even in some adults, patients with storage diseases like Fabry. So I think there's a lot to think about in the HFpEF setting, and there are pharmacologic therapies, of course, have been less effective, and we're really working on strategies that emphasize comorbidities, physical therapy and cardiac rehab, and then hopefully the SGLT2 category will have value in that setting. We still have to see from trials like Deliver and Emperor Preserve.
Thank you very much. And do we have time for another question? Natarajan? Any questions? Can't hear you. Natarajan, can?
No, sir.
Yep.
So, Dr. Desai during his talk said there is a problem at the level of the cell, the matrix, and the ventricular structure. So what you see by common imaging techniques is the structure part and not the other two components. And he did mention that if changes persist in the cellular and the matrix level, the problem could recur in future if the pharmacological treatment is suspended for whatever reason. So how do you know whether a permanent change has happened in the cellular and the matrix level so that you can downgrade the treatment and expect a permanent improvement?
I think this is a fantastic question and not one I have a good answer to. I think at the moment we've utilized neurohormonal markers in some sense to guide when risk has returned to normal. I think that if there is truly no evidence of LGE or other patterns by MRI, that might give you some reassurance in a patient who's recovered to normal. I think volume is important if volume returns to normal as opposed to the volume being still abnormal. But these are just markers. I think the certainty really only comes with the experiment of withdrawing the therapy and seeing what happens. But I'm reluctant to do that based on the data we have and the points you so succinctly summarized. In most of our patients at this point without better certainty or surety about who would relapse. I do think that there is some there are some cases, for example, patients with tachycardia-related cardiomyopathy, perhaps those with peripartum disease, where perhaps some patients with prior myocarditis that is recovered. I think those are subsets where we do think that as the process finishes and resolves, that as long as there's no repeat exposure, those patients may be candidates for withdrawal of therapy, and that's just a clinical experience. But patients with ischemic heart disease for certain, and those with toxic cardiomyopathies, those with genetic cardiomyopathies, I think I'm much more concerned about the ability to truly undermine the process. And the metabolomic and proteomic profiling of patients with recovered EF would really argue that there isn't that recovery in most patients.
Thank you very much.
Do we go on to the next one?
Yeah, well, thank you very much for the opportunity. It's been a wonderful session.
Thank you, Dad. We are going to the next one. This is Dr. Bernard Dash from Mayo Clinic. He is going to talk to us about silent atrial fibrillation and implications. Dr. Garg.
Good evening. The topic I'm going to discuss right now is one that is very topical and I think very interesting, the pathophysiology and management of subclinical atrial fibrillation, knowns and unknowns. And what I really want to emphasize is that we do know, we have a fair amount of information and evidence about subclinical atrial fibrillation, but there's a great deal that we do not know. To place it into perspective, I want to just discuss the interplay between atrial fibrillation and stroke mechanisms. We know that atrial fibrillation causes stroke. We also know that a considerable number of people who present with strokes have atrial fibrillation, whether that is stroke causing atrial fibrillation or whether the two just coexist is uncertain. But what is really important is to take into account these other risk factors which are associated with atrial fibrillation, such as hypertension, atherosclerosis, sleep apnea, and so on. And these associations with atrial fibrillation, all of these risk factors also are associated with an increased risk of stroke. What we do not know for sure is to what extent these risk factors cause atrial fibrillation and to what extent causes atrial fibrillation, and to what extent the strokes are due to atrial fibrillation as opposed to these other risk factors. What do we know? We know that silent AF is common. Approximately 30% of patients with devices, if you interrogate them, you will have episodes of atrial high rates, which could be or are probably due to atrial fibrillation. In one study, 1.4% of the population over the age of 65 in the United States had clinically silent atrial fibrillation. This was a screening study. That's about 500,000 patients in the US alone. In approximately 30% of patients, the diagnosis of AF is first made at the time of stroke. AF-related strokes are more severe with a higher rate of recurrence. And even short episodes, 6 minutes or greater, of silent AF are a risk factor for stroke. But the major impact of silent AF appears to be with longer episodes. It's not a static entity. In other words, you may have at one point in time relatively short episodes of atrial fibrillation that over time may progress to much more longer episodes. This is important. In most studies, there is no temporal relationship between the episodes of atrial fibrillation detected on a device and the timing of stroke, which really raises questions about cause and effect as opposed to a surrogate. Is subclinical atrial fibrillation a surrogate of other risk factors that may cause stroke, or is it a direct putative cause of stroke? And the CHADS-2 and CHADS-VAS scores are risk factors for stroke with or without atrial fibrillation. This study, the REVEAL study, was one I was a part of and published in JAMA Cardiology 2017. About 400 patients with a CHADS score of 3 or more, or 2 plus other risk factors such as sleep apnea, for instance. They had implantable loop recorders, and what we showed at 18 months, which was the primary endpoint, is that almost a third of patients had documented atrial fibrillation. And there are 2 other trials very similar to this that come up with the same results. Somewhere around about 30% of people over an 18-month period who were previously in sinus rhythm, to the best of our knowledge, develop atrial fibrillation. Some of those episodes are symptomatic. A large number of those episodes are asymptomatic. On an average, about 4 months to detection. And in fact, if we'd just performed 30-day monitoring, we would have missed the atrial fibrillation in 3/4 of these patients. and the rates didn't change amongst CHAD subgroups. This is a study that we performed in Olmsted County, Minnesota, a 10-year follow-up of incident atrial fibrillation. And what you see is after the detection of atrial fibrillation, in yellow are patients with typical symptoms, atypical symptoms in orange, and asymptomatic in green. And somewhat surprisingly, and we don't really have an explanation for this, those who had atypical symptoms or were asymptomatic had a slightly higher but statistically risk of stroke and TIA compared to those with typical symptoms. Well, you may say those with typical symptoms got anticoagulated, but when we adjusted for that, we still showed that the hazard ratio for asymptomatic and atypical atrial fibrillation was somewhere between 3- and 4-fold greater compared to those with typical AFib. So this study would suggest that being asymptomatic is certainly not an advantage in terms of consequences of atrial fibrillation. Why does it carry a worse prognosis? I don't know. I don't think we know. Now, other studies, this is from the Healy paper and the ASSERT trial in Hamilton, Ontario, Canada. And this is from a large registry by Gage of overt atrial fibrillation, patients with clinically evident atrial fibrillation. And if you look at the CHAD score here, 1, 2, and 3, you can see two things. First of all, the presence of overt clinical atrial fibrillation carries a higher risk of stroke than does silent subclinical atrial fibrillation in orange compared to no subclinical atrial fibrillation in yellow. It appears, though, that once you get up to a CHAD score of 3 or more, then the presence of subclinical atrial fibrillation really carries a much higher risk of stroke, much higher compared to those without atrial fibrillation and in comparison to those with CHAD scores of 1 and 2. So, you know, some data from our study showing that atypical or asymptomatic atrial fibrillation carries a higher risk. These other two studies suggesting it has a lower risk, but I'd point out again that the combination of a high CHAD score and subclinical atrial fibrillation, almost a 4-fold greater, 4% per year incidence of stroke. Now, this was the trial that really brought this entire entity into attention. This was the ASSERT trial from Canada, where they looked at the presence of atrial high-rate episodes of greater than 6 minutes duration within 3 months after pacemaker or defibrillator implantation, published by Healy et al., New England Journal of Medicine. And what they showed is if subclinical arrhythmias were present, and when I put subclinical atrial tachyarrhythmias, it's just that you can't distinguish often whether this is atrial fibrillation or flood or atrial tachycardia. But if they were present at 2.5 years, the risk of stroke was substantially greater than if these arrhythmias were not present. And the hazard ratio for stroke and systemic embolism, 2.49, so 2.5-fold increase. Several years later, they published another paper from the same trial, the ASSERT trial. And this sort of surprised me because in a way it changed the conclusions of the initial paper. Because if you look at the cumulative incidence of subclinical atrial fibrillation, the majority of patients had relatively short duration, 6 minutes to 6 hours. But if you look at the cumulative incidence of ischemic stroke, what you really see is that the event rates are really confined to those people who had 24 hours or more of atrial fibrillation. And this was really puzzling because the initial paper suggested that, you know, if you had any subclinical atrial fib of 6 minutes or more, you were at higher risk. But when they did an adjusted analysis, again, this is the line of identity here, the dotted line, you see that the development of ischemic stroke or systemic embolism is much greater in those who had more than 24 hours of atrial fibrillation. So we still need to learn a lot more about those patients with subclinical AF that have shorter episodes. This is still a gap in our knowledge base. Now, these are three important studies, including the ASSERT trial, that looked at the timing of the detection of atrial fibrillation in relationship to stroke. And you'll see that in a minority shown in yellow, atrial tachycardia / AFib within 30 days before the thromboembolic event was noted in a minority. In the majority of patients, the detection of atrial fibrillation or atrial tachycardia occurred during the study period, but beyond the 30-day window in relationship to stroke. So you could argue that these patients, AFib may have been the cause, direct cause, but in these patients, AFib may have been a surrogate. So to summarize, device-detected atrial high-rate episodes are clearly associated with an increased rate of stroke. The association with AF burden, in other words, the longer the episodes and the more you get, and the more frequent they are, that implies causality. AFib is causing stroke, but we don't know for sure. But then this inconsistent temporal relationship, the fact that 70 to 80% of the time when AFib is detected, it will be detected way beyond the 30-day window for stroke. This suggests not a direct cause, but it really suggests that in these people, subclinical AFib may be a surrogate. And what we also know is that the role of stroke risk factors apply to both. Whether subclinical atrial fibrillation is a powerful risk factor for stroke depends to some extent on their other stroke risk factors, namely the CHA2DS2-VASc scores and so on. This CRYSTAL trial, I think it was the CRYSTAL trial, but it was an important study of cryptogenic stroke, patients who presented with cryptogenic stroke and had implantable cardiac monitor, and over a period of 6 years, 6 months, about 8% developed atrial fibrillation. At 3 years, 30% had atrial fibrillation compared to control patients who did not have a monitor. And this really makes an important clinical point that with cryptogenic stroke, you have to look for atrial fibrillation with long-term monitoring. So this then led to a trial of NOACs in patients with recent ischemic stroke. The Navigate ESUS trial. ESUS is embolic stroke of unknown source with rivaroxaban, 7,000 patients, no effect. And we all thought that rivaroxaban, that this trial would be positive. If you look at major bleeding, increased with rivaroxaban compared to aspirin. And then the RESPECT ESUS trial with dabigatran, again, no difference in stroke, and a slight trend towards more bleeding. So why were these trials negative? Well, if you have 7,000 patients and only 10% develop atrial fibrillation, you're actually doing a trial, a comparison on 700 patients, and they're underpowered. So a lot of work is going on right now to look at the following, and that is, this is one study that we've done, my colleague Dr. Noseworthy and Atia at Mayo. We published this in The Lancet recently, using machine learning on a huge number of patients at the Mayo Clinic. And we looked at almost 700,000 ECGs and sinus rhythm. 3,000 of these patients, 8.4%, we know had atrial fibrillation before the ECG showing sinus rhythm. It was within the previous 30 days. And when we look at the ROC curves for these neural networks, they're surprisingly strong. In other words, the machine learning algorithm, if based on one ECG or two ECGs, was extremely accurate in identifying in sinus rhythm which patients had atrial fibrillation previously. And I think that we well, we are currently doing a study to look at this in people who have had strokes to see whether we can predict who will develop atrial fibrillation and then design the trials in an enriched population. But this is ongoing work. Can everybody be anticoagulated? No, they cannot, because if you look at major bleeding, even with the NOACs, it's still significant, and fatal bleeding much lower, but still significant. So you simply can't anticoagulate everybody over the age of 65 who develops atrial fibrillation. So to summarize, it's common, it's associated with a risk of stroke related to the burden of AF and risk factors. The temporal relationship between the timing of AF and stroke is variable, about 30 days in the majority, at least greater than 30 days in the majority. Whether oral anticoagulants have an overall benefit is being investigated in 3 trials at the moment: Artesia, NOAA, and Danish Loop. The approach to intermittently anticoagulate, which I have great problems with theoretically, was the subject of one trial that was neutral, not surprising. How much AF is too much? The duration, 6 hours versus 24 hours, once a day versus once a week. We don't know this at all. And there's this interaction with the stroke risk factors. In the interim, what would I do? If they have atrial fibrillation for greater than 24 hours and they have stroke risk factors, CHA2DS2-VASc score of 2 or more, you need to individualize the risk. But what I would do is approach 24 hours or more of atrial fibrillation the same as clinical overt atrial fibrillation. Between 6 and 24 hours, we don't know what to do. And that's what the objective is of these trials. In a patient with cryptogenic stroke, I think if you detect atrial fibrillation of greater than 30 seconds or 2 minutes, you probably should anticoagulate them. I think the recent trials of rivaroxaban and dabigatran suggested you do not have to, but they are underpowered. And at least at the moment in my clinical practice, I do treat these patients. Whether, when, whom, and how to screen is the subject of ongoing studies. So I think there are some answers. We do have a fair amount of data, but there's still many questions that are unanswered. Thank you for your attention.
Okay. Thank you very much, Dr. Garg. I believe Dr. Garg is available for taking some questions now.
Yes, good evening.
Natarajan,
yeah, he's there now. So
Yep.
maybe we can have a quick discussion and then
Yep.
go to the next talk.
Okay, sure. Any questions now?
Can I ask a question, Chaco sir?
Yeah, sure. Sure,
Dr. Bernal, that was an outstanding talk on the lesser known thing about silent atrial fibrillation, which you very elegantly presented. My question was with regards to atrial high rate episodes. You did mention that more than 24 hours becomes an indication for anticoagulation. What do the current guidelines tell us in terms of threshold of AF burden by device monitoring? What is the current guideline basis? You said more than 24 hours is based on a guideline or based on experience?
I think more than 24 hours is really based upon not even really so much personal experience, but it's really based on the fact that in the ASSERT trial, it appeared that the risk of stroke was really, by and large, confined to those patients who had 24 hours or more. If you look at those who had shorter durations of atrial fibrillation, there was a tendency to an increase in stroke, but it was not statistically significant. The guidelines are evolving at the moment. This is really an area that we need the data from the 3 ongoing trials, Artesia in particular, the Danish Loop, and the NOAA trial. Whether they whether they are large enough to tell us more about the burden of atrial fibrillation is a question. I think overall, the trials will show whether anticoagulation is beneficial or not. But whether there'll be enough patients in these 3 trials to ask the question that you've just posed, and that is, what about someone who has 12 hours of atrial fibrillation, or 6 hours, or 3 hours, or greater than 6 minutes? Should they also be anticoagulated? That we do not know, and the guidelines do not tell. So the guidelines are evolving and they will change. We really need the data from these trials. So in my practice, if I see 24 hours of atrial fibrillation, I treat them as if it's clinical atrial fibrillation. What do I do at 12 hours? If I cannot enroll the patient into the trial, I probably would treat with anticoagulants if they had somewhere between 12 and 24 hours of atrial fibrillation. But it would also depend very heavily on their risk of stroke in terms of the CHA2DS2-VASc score.
Okay,
I
thank
quite
you
agree
very much.
with you. The 2020 European Society of Cardiology guidelines clearly talks about the same thing that you just mentioned, the interplay between the CHA2DS2-VASc score and the AF burden as shown by the devices AHRE, atrial high rate episodes.
Right.
Even for a low duration, if the CHA2DS2-VASc score is prohibitively high, let's say 4 and things like that, they even say that if it is 6 hours of atrial fibrillation, you should anticoagulate. That's what the latest guidelines mention.
It's not unreasonable. I think it's a class 2B level of evidence. We don't have trial evidence, but it's sort of, the CHA2DS2-VASc score actually predicts events even in sinus rhythm. Not surprisingly, because what does the CHA2DS2-VASc score tell us? It tells us there's vascular disease, diabetes, and hypertension, age, prior stroke. So I think if you've got a very high CHA2DS2-VASc score and you see evidence of atrial fibrillation on interrogation of a device, it's reasonable to anticoagulate. We just have to understand we don't have the trial evidence to confirm that at this stage. Greater than 24 hours, it's easy to understand. But 3 hours, 1 hour, CHA2DS2-VASc score 5 or 4, it would be reasonable to anticoagulate. I think you use clinical judgment.
If somebody doesn't have a device and they have multiple stroke risk factors, like for example, diabetes, hypertension, so heart failure, and so on and so forth. So they don't have a device because they don't have a bradycardia indication, let's say. And does it extend things to a very high level? Do they become candidates for an implantable loop recorder? What's your comment on that? It's a very provocative question that I'm asking you.
I think that actually is what the REVEAL trial was about, the one that I was a participant in. So in the REVEAL trial, I showed the data in one slide. We took patients, I think it was over the age of 65, with a CHA2DS2-VASc score of 2 or more, and plus one other risk factor, like sleep apnea and so on. And we put in a loop recorder, and at 18 months, I think it was 29% had documented atrial fibrillation. And really, there are 2 other studies that were uncannily, actually, within 1 or 2% came up with the same answer. About a third of people in that 18-month period will have documented atrial fibrillation. Now, you have to understand that the REVEAL trial was not a trial of therapy. All we did in that trial was notify the physician, your patient is having runs of atrial fibrillation. In a subsequent paper, we published the outcomes of what percentage were anticoagulated versus who were not anticoagulated. But the trial was not powered to answer the question about the impact of atrial fibrillation on outcomes. It wasn't powered to do that. It's a long answer, but to reply to your question directly, I think it is very reasonable to put in a loop recorder in such patients. And probably what I would do, I might use a 30-day event recorder first. Body Guardian, Zios patch, just because it's simpler and easier. And if that shows atrial fibrillation, you have your answer. And if not, then I think putting in an implantable loop recorder is a very good idea. Very reasonable. You cannot anticoagulate everybody over the age of 65 with risk factors. I mean, the best NOAC in the world still causes bleeding.
Dr.
Thank you.
Gash, it was a very useful, practically useful and elegant presentation. Thank you very much. That we are moving on to the next session. Dr. Mark Hoffman from the Northwestern University, Chicago, is talking about combination therapy for blood pressure control.
Well, good evening, and thank you very much for the opportunity to present. I wish I could be there with you. I like going to the CSI. I miss being able to travel to India. So I'm excited to talk about some of my thoughts on pushing the boundaries of combination therapy for blood pressure lowering. I mean, it's one of the most common conditions that we all take care of, and we need strategies on multiple levels that help us improve adherence, efficacy, and efficiency. These are my disclosures. The most relevant ones are related to my secondary appointment at the Georgia Institute for Global Health that has patent licenses, research, and has received investments to commercialize combination therapy products. So the great late physician activist Quentin Young was famous for saying, "Everybody in, nobody out." And it was this spirit of inclusivity that really inspires me as I take care of my patients, but also the research of how do we reach those people who we don't readily reach through most of the systems. It's easy for me to remember my patients who adhere to the strategies that I recommend, including complex multi-drug regimens, and they show up to their visits, they take their medicines, they achieve their goals. But what about those patients that we don't remember, the ones who don't follow up? How do we help them? And I think some of these strategies that I'm going to outline are really directed with this spirit of reaching the most vulnerable. So the NCD Risk Collaborations published this report on hypertension cascade of care in 12 high-income countries. This is for women on the left-hand panel, men on the right-hand panels, and we see going from top to bottom, treatment control among those with hypertension, and then control among those treated. We see age groups on the x-axis ranging from 40 to 49 to 70 to 79, and we see the proportions from 0 to 100 of each of these on the y-axis. We see different countries are represented by different colors. And so overall, we see even among the best performing countries, treatment and control rates are 80 to 70%. These are really the best high-income country funded health systems when we think about this. So we still are missing 30% of the patients are from control. So a related paper in the same journal was looking at the hypertension cascade of care in 44 low and middle income countries. And so this is looking at different regions, Latin American and the Caribbean in panel A, Europe and Eastern Mediterranean panel B, Southeast Asia and the Western Pacific panel C, and Sub-Saharan Africa panel D. We have the cascade of care of individuals with hypertension on the x-axis, ranging from did they ever get their blood pressure measured? Did they have it diagnosed by a physician or other health professional? Was it treated and controlled? And we have the proportions again on the y-axis. So we see approximately 17.5% prevalence among adults, that only 74 had ever had their blood pressure measured. And then 39% had hypertension diagnosed, 30% treated, and only 10% controlled. So those are systems of care that are clearly not working for the majority of people. Now, there were some groups who were more likely to have higher rates throughout this cascade of care, and they were women, older individuals, more educated individuals, wealthier individuals, and non-smokers. So the kind of healthier people are the ones who are more likely to seek care and to get care. When we think about non-adherence, it operates on several levels, and this is a figure from BMJ more than a decade ago that I think remains useful to think about things on a patient level. So I write or type in a prescription for my patient, and that's really the initiation component of adherence. But then we also have the trickier one called persistence. And we really think about that persistence over time. And we can have a fall in adherence because of discontinuation of treatment, but we can also have a fall related to poor execution of the dosing regimen. So many studies will show that at about 1 year, almost half of our patients aren't taking the medicines as we've prescribed them. That's incredible to think about this, the time and effort that we put into getting the patient into the clinic, getting an accurate measure of blood pressure, negotiating with them pharmacotherapy potentially, and then half of those patients a year from now won't be on that therapy. Again, clearly the system is not working. There are other ways to think about non-adherence, and this is a system-level approach by Bamaris and colleagues published a few years ago, looking at things like health system inputs. Is there enough physical resources, space in clinic, the blood pressure cuffs, human resources? Who's taking the blood pressure? Are they trained to do this? Intellectual resources. What are the pathways or protocols that might be part of a hypertension system of care? And what are the social resources to allow people to afford their medicines? There's also the way in which health system delivery is organized in a country or region. Who's in charge? Governance. I mean, that's often a hot button political issue. And then finally, money. Who's financing the system? The out-of-pocket payments that our patients have to provide will oftentimes be deterrents in care and be reasons why they're not refilling their prescriptions. And these all relate to things related to awareness, getting your blood pressure even checked, starting treatment, continuing treatment, and then being controlled, which is our goal. Now, the exemplar for a system-level hypertension control program is the Kaiser Permanente Northern California's model. In this paper by Mark Jaffe and colleague outlined the key components of it, included things like a hypertension patient register. So these patients were in panels, so it wasn't just me remembering my patients who come back, but it's, yeah, we need to call back those patients who haven't shown up. That's one strategy that we can improve retention in care. There's quality reporting of treatment and control rates at the site level to let them know how they're doing related to retention, diagnosis, treatment, and control. Treatment guidelines were simplified and they focused on the use of fixed dose combination therapy as first-line treatment. And then importantly, in the United States, free non-physician follow-up at 2 to 4 weeks after medication changes was part of this package. So trying to improve the ability for patients to be followed up, make it easier for them. Now, this figure on the left shows the temporal trends in single pill combination use during the program. And it only reached about 25% of the participants. This has continued to climb, but it's combination therapy is part of a package or system to improve the adherence and control rates. Control rates are shown here, temporal trends. Kaiser is shown in the circle. X-axis is time, y-axis is proportion controlled. And you can see that it started out in 2001. Control rates were about 45%, getting up to 80%, later reaching 90% in Kaiser's system. And you can see the national and California trends shown in the triangle and the square box, respectively. So if I think about the efficacy and safety of combination therapy, there's quite a bit of literature synthesizing clinical trials related to this. So Salam and colleagues have published a systematic review of 2-drug fixed-dose combination therapy compared with monotherapy. There were 33 trials and more than 13,000 participants. And these are individuals with a baseline blood pressure of 155 over 100 on average. And the interventions ranged from different types of combinations. So these could be a full standard dose, or it could be less than standard dose or some combination thereof. And the mean systolic blood pressure lowering difference compared with standard dose monotherapy, there was a graded relationship. So as you could expect, higher doses of medicines in that combination led to greater reductions in systolic blood pressure, with corresponding increases in the proportion of patients who are controlled. Now, the withdrawals due to adverse events were modestly higher, but still low overall, about 3% in the fixed dose combination therapy. So taking that idea a step further, Ruth Webster and colleagues, including Salam, published the Triumph trial, asking the question, is 3 halves greater than 1, or really 1.4, because that was the amount of standard dose monotherapy, or standard dose blood pressure lowering drugs in the usual care arm. And so the question here was, does the use of a pill containing low doses of 3 antihypertensive medications provide improved blood pressure control compared with usual care among patients with mild or moderate hypertension? And this was among 700 patients from 11 urban clinics in Sri Lanka. And the proportion achieving a target systolic and diastolic blood pressure at 6 months was 70% in the triple pill arm and 55% in the usual care arm. So demonstrating an improvement in the ability to achieve control. So Salam and colleagues again performed another systematic review, this time of 3-drug fixed-dose combination therapy compared with 2 drugs. And here, there have been 14 trials, more than 11,000 participants. The mean baseline blood pressure is higher in this systematic review. That's how we often will be thinking about these combination therapies, their clinical use. And the mean systolic and diastolic blood pressure lowering difference of 3 versus 2 was 5.4 and 3.2 respectively. You have a higher hypertension control rate, and again, withdrawals due to adverse events is relatively low, about 3%, and similar between the 2 groups. So taking this idea even a step further, the quad pill pilot study asked the question, is 4/4 greater than placebo? It's a lot of fractions today. And this forest plot shows the results of the quad pill pilot, as well as additional trials of quarter dose therapy. So there are 36 trials with 1 quarter dose therapy showing a reduction in blood pressure of 4.7 over 2.4. You can see 6 trials, including 2 drugs at quarter doses, and the quad pill was the first of 4 drugs at quarter doses. And this pill, placebo-corrected, reduced systolic blood pressure by 22 millimeters of mercury, so a substantial amount. And we had corresponding reductions in mean 24-hour ambulatory blood pressure monitoring as well. So this begs the question, could this be done in a longer-term setting? And so this is the basis of the quartet randomized controlled trial that Claret Shao and Anthony Rogers are leading. This includes the combination of irbesartan, amlodipine, and dapamide and bisoprolol in very low doses compared with standard dose irbesartan. And this is looking at the systolic blood pressure difference at 12 weeks. The results of this will be reported next year. We're doing a parallel trial here in Chicago using a slightly different combination that includes candesartan rather than irbesartan. We have this same outcome and main change and difference in systolic blood pressure at 12 weeks, and these are across federally qualified health centers here in Chicago. So again, those people who are less likely to receive optimal care. And as I think about this stepping back on the system level, we think about how can we improve hypertension control system efficiency if we're going to treat as many as 1.4 billion individuals around the planet with hypertension. So if you kind of roughly estimate, how much people would need for 1 drug over the course of 1 year, that's 500 billion tablets that need to be flying around, manufactured, distributed, sold, taken, all in a time that they're not going to expire. Since most people need 2 to 3 medicines, we're talking realistically at least 1 to 1.5 trillion drugs. Now, the systems clearly needs more and simpler blood pressure cuffs, more health workers, investments in information systems, and bigger, stronger, and faster supply chains. But combination therapy is one of many interventions that's usually considered on the patient level, but I don't know of any other intervention that can reduce the number of pills needed by half or more. And Ivor Benjamin published this brief report in The Lancet outlining the inclusion of fixed-dose combination therapy in the WHO's model list of essential medicines, which I was happy to be a part of that application that was successful. So overall, there's a massive scale of hypertension burden, requires a response that is effective and efficient. As we saw, the cascade of care is not working in many parts of the world, and combination therapy can help. Combination therapy serves as the backbone for many hypertension control programs, including in the US, much like HIV, TB, and malaria care. And triple drug, half dose, and quadruple drug, quarter dose combination therapies may be strategies to push the boundaries of simplifying treatment to improve adherence, efficacy, and even efficiency. I'd like to thank my collaborators at Northwestern, the University of Abuja, the George Institute, the Center for Chronic Disease Control, PHFI, and my sponsors. And I'd like to thank you for your time and attention. Look forward to any questions.
Well, that was a very informative presentation. We enjoyed listening to that. I have got a question, maybe related to this. Often by the time we get an adequate systolic blood pressure below or around 140, the diastolic blood pressure is way down, 70s or 60s. What are the implications of this and possible remedies if necessary?
Thanks for the question. Yeah, I think it pretty age dependent. So in my older patients who have stiffer vessels, those are the ones who are going to be having that wider pulse pressure. And whether or not they're going to be symptomatic at those lower blood pressures is where there's certainly personalization that's happening. So we're trying to test the effect of these 4 drug combinations in people with mild to moderate hypertension. Most of our thinking about 3 drug combinations is really on these people with really high blood pressures. But most of our patients are going to need at least 2 drugs. And by using lower doses, we're actually able to get better blood pressure control with fewer side effects.
Okay, there's one more question now, but see, the recommendation is that for people above 70, 170 is the cutoff point of blood pressure control. But when we treat ischemic heart disease or any other conditions like that, when beta blockers, ACE inhibitors are given, the blood pressure usually comes down below 170. Is that any detrimental to the health of that patient?
Did you say 117 or 170? 170.
No, 170 above age 70. That is the recommendation for treatment, right?
Not for the 2017 American Heart Association, American College of Cardiology hypertension guideline. For people who are treated with pharmacotherapy, 130/80 is the target blood pressure for those individuals.
So when we treat ischemic heart disease or left ventricular failure, we give drugs and the blood pressure comes down even below 170 for people of 70 or more of age. Is that detrimental to their health?
No, treating people with blood pressures above 170 is, 130 to 170, they have substantial benefit from pharmacotherapy to lower their blood pressures.
Okay, that's reassuring. Thank you very much for that elegant presentation. We move on to the next topic. This is very interesting. Role of iron in the treatment of heart or the health of heart disease. Dr. Inder Anand from the University of Minnesota.
Well, thank you so much. And I'd like to take this opportunity to thank the organizers for inviting me to this wonderful conference. It's a shame that we're doing it not in person, but hopefully we'll have occasion to do that. Now, here are my conflict of interests disclosures. Now, heart failure in this condition, anemia and iron deficiency are very common comorbidities and often coexist. Together or independently, they are associated with worse symptoms, increased hospitalization and mortality. Treating anemia with erythropoietic stimulating agents in heart failure does not improve outcomes, maybe deleterious, is not recommended. Iron deficiency seen in about 50% of chronic heart failure patients and about 70% of patients with acute decompensated heart failure. IV iron improves symptoms, exercise capacity in HFrEF patients, but the long-term effects on outcomes and safety are still being studied. There are no studies in patients with HFpEF and only one recent study in acute heart failure. Now, iron deficiency could be absolute when the total body iron is decreased or functional when the total body iron is normal or increased, but it to meet the needs of the target tissue because of sequestration in pooled storage pools or in the inflammatory states. Now, in patients with heart failure, we now have agreed that a ferritin level of less than 100 micrograms per liter or 100 to 300 micrograms per liter, if transferrin saturation is less than 20, include patients with both absolute and functional ID. Using this definition, these workers from Poland were one of the first ones to show that in patients with HFrEF, overall, the absolute or relative iron deficiency was seen about third of the patients, much more so in the anemic or compared to non-anemic patients, as might be expected. But irrespective of the anemia condition, the presence of iron deficiency increased the mortality or morbidity, here measured as the death or heart failure, heart transplantation by, as you see, nearly 60%. Now, in this pooled analysis, international analysis of over 1,500 patients who had iron deficiency and or anemia, but all of them had heart failure. So you look at these patients over here who had heart failure alone, no iron deficiency or anemia, compared to these patients who had anemia alone did have an increase in mortality, but this was not significant. But in patients who had no anemia but did have iron deficiency, their mortality was increased, and this was associated with nearly 42% excess all-cause mortality, suggesting that in heart failure, iron deficiency may be more important prognostic marker than anemia alone. So what are the mechanisms of this association of iron deficiency with adverse outcomes? Clearly, they are multifactorial. Besides the importance of iron in the maintenance of hemoglobin, iron is an essential component of all energy-producing mitochondrial enzymes. In iron deficiency, cardiac and skeletal muscle iron content is reduced, causing structural and functional mitochondrial abnormality and decrease in high energy stores like ATP and phosphocreatinine. And this may explain why skeletal muscle and cardiac muscle dysfunction could occur and reduce exercise capacity and worsen heart failure. Recent studies, and I'll show you a couple of these, have shown that iron replacement may be associated with beneficial effect in muscle energetics. So does iron replacement help? Clearly, oral iron supplement is the standard of therapy for iron deficiency. It is readily available, inexpensive, and effectively raises serum iron in patients with non-heart failure. Because heart failure is an inflammatory state, elevated levels of cytokines and protein, and the protein hepcidin prevents iron to be absorbed from the gut and or released from body stores. Oral iron is also not well tolerated by many patients and is associated with adverse GI effect. And then, of course, there are very few studies investigating the effects of oral iron in patients with ID and heart failure. And that is why the NIH decided to carry out this small proof of concept study, the IRON-HF. This was a phase 2 randomized controlled trial in 225 patients with HFrEF. They could be anemic or non-anemic. They were randomized to placebo or oral iron polysaccharide in the dose of 150 milligrams BID. And notice here, after 16 weeks, the primary endpoint, which was peak VO2, or any of the secondary endpoints, were not significantly changed by oral iron. And hence, it became clear that oral iron cannot be recommended for the treatment of ID in patients with heart failure. But even before this was started, there were a large number of studies in Europe and England looking at this proof of concept of using IV iron of different descriptions in patients with heart failure. These were small studies, but overall, they found that the exercise capacity was increased as measured by 6-minute hall walk test, peak VO2, and there was improvement in quality of life scores. The NYHA class improved, and anti-propion levels fell, But as I said, because you see, there was such a small group of patients, they could not measure the outcome, and for that reason, recently, Stefan Anker and his colleagues carried out an individual patient data meta-analysis from 4 of these randomized controlled trials that compared ferric carboxymaltose with placebo and used very identical protocol. They looked at cardiovascular death as their primary endpoint with CV hospitalization using a recurrent event analysis and see how they found a 41% reduction in this combined endpoint, which was highly significant. Now, they also found that these effects were independent of the anemia status. What they also discovered was that the effects were really seen in severe and moderate iron deficiency patients, but not so in mild iron deficiency. Indeed, when they did an analysis of TSAT in tertiles, there appeared to be worsening of the outcomes in those who had the highest tertile of TSAT. This was actually associated with a P interaction of less than 0.02, underscoring the fact that the possibility of the deleterious effects of iron should not be overlooked. Now, 2 weeks ago, the results of the FIRM AHF trial were presented by Dr. Ponitkowski at the virtual AHA meeting, and he's going to explain that later, I think, but briefly what we saw, that the FIRM was a phase 3 randomized controlled trial in just over 1,100 patients from 15 countries and 121 sites. Patients admitted with acute heart failure, either males or females, age 18 or over, ejection fraction less than 50%, with iron deficiency, anemic or non-anemic, after they were clinically stabilized, were randomized either to placebo or to IV iron, and followed for 52 weeks. The primary endpoint was a composite of total hospitalizations for heart failure and CV death. And there were, as you see, several secondary endpoints. That at 52 weeks then, the primary endpoint of total cardiovascular hospitalization and CV death was reduced by 21%, but unfortunately, it did not meet a significant p-value, and the p-value was 0.059. But the component of this, of the primary endpoint, the total hospitalizations for heart failure, was significantly reduced by 26%. Now, built-in within the FIRM trial was a very nicely conducted COVID sensitivity analysis. And this analysis, which was done before the database was locked, patients were censored on the date when the first COVID patient appeared in their respective country. And as you notice here, the primary outcome here, the outcomes are clearly lower than those of the total analysis. And of course, that's because they lost all those patients. But despite that, very interestingly, now you see that the point estimate actually are better, a 25% reduction in this endpoint. The confidence level actually improved, and now you have a positive outcome. Now, they also noticed that the effect was independent of whether the hemoglobin was low or high, the anemia status, an interaction p-value of 0.15. But notice how the effect was, strangely enough, better in those, appeared to be somewhat better in those with higher hemoglobin at baseline. Once again, there was this finding of the effect being mainly seen in those with moderate to severe iron deficiency as measured by ferritin or transferrin, once again underlining or underscoring the possibility of a deleterious effect. Now, this is important because the human body is unable to excrete iron. Under normal condition, iron is absorbed. Absorption is reduced in the duodenum to prevent iron overload. This protective mechanism is bypassed when iron is given intravenously. And at high TSAT, oxygen reactive species mediated damage to the cell can occur. And hence, one has to be sensitive to the situation of iron toxicity in these studies, and hopefully further studies are going to answer that effect. Now, how do we explain these beneficial effects of iron in improving outcomes in patients with HFrEF? And here are some of the interesting findings that have just come on. First, of course, that IV iron rapidly restores skeletal muscle stores, as shown in this study recently published, the myocardial iron trial by Nutz and their colleague. They randomized stable heart failure with reduced ejection patients to either placebo or to IV iron, and measured T2 star and T1 star MRI imaging to assess myocardial stores. Notice how within 7 days, the myocardial iron was restored and maintained for 30 days. And during the 7 days, although ferritin and TSATs improved, none of the other parameters, functional parameters, ejection fraction, KCCQ, 6-minute walk, or NYHA class, or NT-proBNP was changed. But at 30 days, the LVEF tended to improve, but not significantly. There was improvement in KCCQ, NYHA class. So the question arises then, if IV iron is rapidly repleted, repletes the myocardial iron, is this associated with improvement with muscle mitochondrial energetics? Here is a study from Okonkwo and his group in London, the ferric HF2, that tested the hypothesis that IV iron in heart failure enhances skeletal energetics as reflected in shorter phosphocreatine recovery time. In these 40 patients, they found that half of whom were anemic, that in the IV iron group, there was a rapid recovery of phosphocreatine recovery time that was not seen in the patients with who were given placebo. Therefore, this enhancement in skeletal muscle may imply myocardial functional improvement. And in these patients, this was associated with improvement in NYHA class and in post-exercise the dyspnea score, despite no change in hemoglobin at 2 weeks. To summarize then, absolute or relative iron deficiency in heart failure is common. It is associated with adverse outcomes. Treatment of iron with oral iron does not work. Treatment of iron deficiency in heart failure with or without anemia using IV iron appears to be promising. These effects could be associated with improvements in muscle energetics, but both studies are required to prove those concepts. And then long-term clinical studies are required to confirm the treatment of iron deficiency is safe and improves outcome. A large number of randomized controlled trials in patients with acute and chronic HFrEF and in HFpEF are underway to address these issues, and we are greatly looking forward to those results. Thank you.
Thank you very much, Dr. Anand. That was an elegant presentation of an up-and-coming subject, which is being studied now in cardiac failure. I believe we can take some questions now, Dr. Natarajan.
Hello.
Yeah, Natarajan, any questions?
You can maybe a brief thing, because this is the last. We have come to the end of the day. So a few questions you can. Dr. Inder is anyway there, so we'll make use of the opportunity.
Yep. Anybody? Any questions?
Dr. Inder, you're muted.
Then shall we close that the session now?
Yeah.
So thank you very much for all of the presenters here. They have done a wonderful job in presenting the upcoming and new developments in cardiology, different phases. Thank you very much, and hope next year, we will meet in person rather than on the screen. Thank you.
Thank you.
Thank you very much.
So thank you very much, Chako sir, for chairing this session. And all delegates will agree that we had a day full of exciting scientific deliberations. We look forward to your presence tomorrow and day after in large numbers. And thank you very much. Good night. Stay safe. Thank you very much.
Right.